Good morning to all. I welcome you all for the TNFOG mid-year conference with Karnataka Society of Obstetrics and Gynecological Association of 2-day conference. Yesterday we had a wonderful webinar and today we start with inauguration. As of now, today we have 706 registration. Yes, madam. Sahiti, can you play our Tamil Thai Valthu?
Yeah, go ahead. Go ahead.
Jai Bharat Jananiya Tanujate, Jaya He Karnataka Mate, Jaya Sundara Nadi Vanagala Nade, Jaya He Rasa Rushigala Veere, Bharata Jananiya Tanujate, Jaya He Karnataka Mate, Shankara Ramanuja Vidyaranya Basaveshwara Madhvara Divyaranya, Kanna Shadakshari Ponna, Ambala Gumipati Janna, Kumara Vyasara Mangala Dhama, Kavi Kogilegala Punya Rama, Bharata Jananiya Tanujate, Jaya He Karnataka Mate, Sarva Jananga Shantiya Tota, Rasikara Kangala Seleyuva Nota, Hindu Kraista Musalmana, Parasika Jaina Rudyana, Kannada Nudi Kunidaduva Geha, Kannada Taiya Makkala Deha, Bharata Jananiya Tanujate, Jaya He Karnataka Mate, Jaya He Karnataka Mate, Jaya He Karnataka Mate.
Hello, 1 minute. Madhuri has not received the link, it seems. So
Yes.
if you send the link on WhatsApp, she is going to join.
Hello, madam.
Hello. Hello, Sampath.
Yeah, yeah.
Madhuri wants a link immediately.
Sripriya link anuppidu Sripriya.
Okay, bye.
Madhuriki. Can you send the link, Sripriya, to Madhuri madam?
Anupra, madam.
Shai the lighting of the lamp.
Okay, ma'am.
Yes. Yesterday we had the full topic covering A to Z of obstetrics. Today we will be talking about the gynecology subjects. I request our President, TNFOG President, Dr. Revati Janakiraman to welcome the August gathering. Dr. Revati Janakiraman is the founder, secretary and past president of Madurai Society and president MCOT and founder president of IMS Madurai chapter. And she has received Durusha Community Services Award, Lifetime Achievement Award, and she has written on Foxy Focus on Amniotic Fluid A to Z and Pride of Foxy Award in November 2019 at Mumbai, and contributed chapters in many UG and PG books. Dr. Revati, madam.
Thank you, Dr. Sampath, for the kind introduction. It's my great pleasure to welcome all of you, especially our chief guest, Dr. Madhuri Patel, Dr. Sindhya madam, and Dr.
Kasturi.
Dr. Kasturi Dumna, and all the faculties as well as our delegates. Now, the goal of TNFOG is reduction of maternal mortality and eradication of cancer service this year. And TNFOG's contribution to women's health is multifaceted by way of monthly marathon CME, in which UA candidates are given platform and also given prizes to the selected candidates, and Bodhana for PG classes, case discussion as well as case presentation, which is attended not only by the postgraduates but also by all our members, physicians, and they say it is very much useful to them. And both this marathon and Bodhana are brainchild of our vibrant secretary, Dr. Sampath Kumari. And we also conduct classes for paramedicals regularly, training them. And recently we had this 9 months pregnancy care, 9 topics for 9 days along with Foxy. And Foxy TNFOG Manita program is also being regularly conducted, in which we have completed 2 sets already. And not only that, public awareness program is also taken care of by the TNFOG by way of free cancer screening programs by TNFOG as well as all the societies of TNFOG. And we are planning for school health program also in recent future, in which we are going to train our adolescent girls, adolescent children of almost all schools of Tamil Nadu. And apart from that, most importantly, CMEs like this individually as well as along with other states, building up a good rapport between all the states in South, not only in South, across the nation, and developing a friendship among all the societies of India. So I am sure this CME today, for 2 days conference, in which you have got a lot of interesting topics, definitely all will be benefited. And I wish in future, we will be conducting more and more programs jointly with all other state federations also. I wish this conference a grand success. Thank you very much.
Thank you.
Sampath, you are unmute yourself. You are muted. Sampath, unmute.
Madam. So next I invite and Dr. Vidya Topi, the president of Karnataka Society of Obstetrics and Gynecological Association, for her welcome address. She is the professor of and HOD of Al-Amin Medical College, Vijaypur, Kasoga President 2023, and was chairperson for Food and Drug and Medico-Surgical Equipment Committee, Foxy 2018-20 Best Committee Award she has got, and ICOG Governing Council Member 21-23, Foxy Champion Award 2019, and National Corresponding Editor of Jogi, Organizing Chairperson of Kasoga Conference in 2016, President of Bijapur Society 2009, and Secretary 2007. She has many publications to her credit and written chapters in various books and Foxy Focus, and presented papers at national and international conferences, organized many CMEs, and advisory faculty of both Rajiv Gandhi University of Health Sciences, PG and UG teacher for the past 30 years. Dr. Vidya Topi.
Yes.
For your welcome.
Thank you, Dr. Sampath, for those kind words for introduction. I'm very much pleased to be amongst the stalwarts here, and the senior most people of Tamil Nadu and Karnataka. And I bring greetings from our state, that is Karnataka state of OBGYN. This year, only 1 month back, I have taken over as president from Dr. Kasturi Donimat, who is all here to bless us today as a chief guest, and Dr. Anjalakshi, Dr. Cynthia Madam, Dr. Revati, and other people from Tamil Nadu. Really, it is a very great occasion that Tamil Nadu and Karnataka have jointly organized this. And we are yesterday we have enjoyed thoroughly the all the academics, and I was really surprised that Dr. Sampath, being so busy still from morning till evening as a secretary of Tamil Nadu, for every talk she was commenting until evening, till valedictory she was there. So hearty congratulations to Dr. Sampath Kumari. Regarding Karnataka state, we have taken up wellness of women as a theme, and we have thought of many programs. So wellness encompasses many things in women's life. So we have educate, excel, and empower. This is another theme of ours. And we have again, as Revati has marathon of so many things in Tamil Nadu, we have planned little focused skill workshops as well as awareness programs. We want to take further some of the programs of the past president, Dr. Kasturi, like Menopause Matters, and she has collaborated with the Indian Academy of Pediatrics, so some of the programs with them. And the most important is connect and collaborate. So we are connecting with all the states of India, and especially we want to focus on the South zone. We have got many talents at the South, and we want to bring them to the Foxy platform. That is the aim of mine as well as Dr. Sampath. So we will jointly work on this, and then we go further. Thank you very much once again. We are ready for the today's bonanza of all the academics. Dr. Madhuri Patel has joined. Welcome, Dr. Madhuri. And we were trying a lot to connect to you today, but Foxy always connects to all the states. So welcome again. I request Dr. Sampath to welcome her, and then let her speak some few words. Yeah.
Yes, Madhuri Madam, welcome Madam. Dr. Revati Madam, would you like to introduce Dr. Madhuri Madam?
Yes. Thank you very much. It's our great pleasure to introduce Dr. Madhuri Patel, our Secretary General of Foxy. She was Joint Secretary Foxy in 2009. Former committee member FIGO Preterm Birth, Associate Editor Journal of, that is our Jogi Journal, Honorary Clinical Associate of Wadia Hospital, Mumbai, Honorary Consultant in Police Hospital, Mumbai, Visiting Consultant in Mazina Hospital, Mumbai, plus a former Professor and HOD of OG Department, MGMH, Mumbai, former Associate Professor, GMC, Mumbai, and she has been awarded the MOX, Shailaja and Mr. Narayan Pandit Award for the year 2019-20. She has delivered guest lectures at national, international conferences and given keynote address and oration, and more than 50 publications in national and international journals and book chapters to her credit. She was associated editor for Foxy award-winning book Gynecological Cancer 2007. More than that, she is so kind, nice, and very friendly person in Foxy. And I really enjoyed her visit during our MOX annual conference recently. With great pleasure, I welcome you, ma'am, and say a few words.
Thank you, Dr. Janki, Revati, Dr. Revati, for such a kind and warm words. I must say we were together, when Dr. Revati was, there,
Yes.
as a vice president of Foxy, and we really enjoyed. And of course, the Madurai conference, I cannot forget. We really enjoyed it. So respected our Dr. Kasturi Donimat. She's a past president of Kasoga. Then another was chief guest, Dr. Cynthia Alexander, former director of IOG Chennai. Then Dr. Revati, Dr. Sampath Kumari, Dr. Vidya Tobi, Dr. Vijaya Lakshmi, Dr. Anjana Lakshmi, and many more, seniors and juniors from the Kasoga and the Tamil Nadu OBGY Society. Very good morning to all of you. And I cannot forget Dr. Sampath Kumari, that she is a very, very active, not only as a VP, and Foxy also, she has conducted so many conferences, webinar, and also Vidya, when she was a chairperson, she has conducted so many things. And I heard Dr. Revati and Vidya, how powerful they are and how much work they are doing for their society. So I'm really congratulating you and I really appreciate you. As a Secretary General, I would like to mention that, Foxy is the most vibrant, prestigious, and one of the largest OBGY organization in the world. We have now 266 member bodies and about 39,500 plus committed members to women's health. Then we have a mission that we support and protect our OBGY practitioner. Then we believe in disseminating education, knowledge, and research. We also serve to advocate the cause of reproductive and sexual health and right. And our primary aim is reduction in maternal mortality rate. I am very happy. The South maternal mortality rate is very, very low compared to the North and the East. So, we are marching, our nation has reached to 97 per 100,000 live births, maternal mortality rate. And we are marching towards our sustainable development goal of MMR less than 70 per 100,000 live births by 2030. And we are all, not only the government, but also, our organization, not only Foxy, but our member bodies, our all states are working for the same to reducing the maternal mortality rate. And of course, we cannot forget our grassroots level worker, our obstetrician, who are doing the maximum work to reduce the maternal mortality rate. And because of them, we could reduce this maternal mortality rate. So I really acknowledge, appreciate, and congratulate all of you. Then, we have a problem of 30, 60, 90. That we have reduced the maternal mortality rate, but still our mothers are dying. That is 30,000 mothers are dying per year. We don't want any mother to die. Secondly, our 60,000 women are dying because of the cancer cervix, and our 90,000 women are dying due to breast cancer. So in a Foxy, recently we added also a mission that preventive oncology and elimination of the cervical cancer. So we'll all are working and we'll have to work more and more for the women's health. And with this, I heard Dr. Revati and Dr. Vidya that all states, we all are connected, we are same because we are working towards women's health and we are, support to each other. And Vidya has rightly said, we have to connect and collaborate to reduce this, maternal and mortality rate, as well as we have to improve the women's health. With this, I congratulate, Tamil Nadu Association as well as the Karnataka for the most app, conference. It has been happening from 6 yesterday, and Sampath Kumari is there for each and every session that I have heard. But let me tell, Sampath is very, very committed person. And then I wish all of you best luck for your future endeavor. And I would like to say that there are eminent speakers, chairpersons, moderator, panelists. They have given you since yesterday, on the most enlighten us on the most important topics of the maternal health, and they are going to enlighten us, which will help us in day-to-day practice to help our women. At the end, I would like to quote Nelson Mandela, which is my favorite quote, that education is the best weapon when used can change the world. So dear friends, let us use this education to update our knowledge and give the best to our women to achieve our MMR less than 70 per 100,000 live births by 2030. I thank all of you for inviting me and honoring me for this occasion. Thank you once again.
Thank you, madam. Thank you so much for the wishing us. And yesterday we had obstetric topic. Today we will be having gynec topic. As of now, we have 706 registration.
Wow,
Dr.
very
Vidya
nice.
Topi, thank you. I invite you to introduce Dr. Cynthia Alexander.
Yeah,
Dr.
yeah.
Vidya?
Yes, it is very, I'm very happy and it is my pleasure to introduce Dr. Cynthia Alexander, former Director IOG Chennai, Superintendent Government Hospital for Women and Children, former HOD of OBGYN Madras Medical College, Chennai. She has been awarded by A.L. Mudliar Traveling Fellowship Award in 1988, Lifetime Achievement Award, TNMGR Medical, she is from TNMGR Medical University, Lifetime Achievement Award from Dipsy Lucknow, Times of India and Economic Times Award New Delhi in 2018. So we would like to have some blessings and some words from Dr. Cynthia Alexander.
Thank you so much to have such a nice person to introduce me. So I begin. Kalai Vanakkam. I'm speaking from Tamil Nadu, no? So I have to wish that way. And welcome all present at this webinar, a lovely Sunday morning. Across borders and boundaries, the TNFOG reaches across to all our gynecologists saying that we are a united India. I thank the President, Dr. Revati, Dr. Sampath Kumari, and Dr. Vijayalakshmi for this invite of being the chief guest. Lovely to share the online days with Dr. Madhuri Patel and Dr. Kasturi. Once again, across the border, in spite of the preparation for your polls, you all are getting ready, I know, it is wonderful to see Dr. Vidya, Dr. Rajeshri, and Dr. Suman. On a personal note, I thank Sampath Kumari and I wonder how many hours she has in a day. 36 hours? Very enterprising. Always at it. She's at it always. I wish her all the best in all her endeavors. My dear friend and guide, Dr. Anjalakshi, is there, and my classmate, Dr. Amala Devi, who's going to chair the next session. We have been classmates from 1965, and she has always been a great pillar of support, not only that time in my college days, but even to this day. So once again, lovely to see so many speakers from both the states. And yesterday's topics were all well selected, and today again to show how we empower women. My previous speaker, Dr. Madhuri, said about education. I always believe there are 4 E's which we should practice for women. And if that is practiced, the family, the society, and our country will definitely go a long way. So what are these 4 E's? Empowering women, educating women, empathizing with women, and equality of women. So in any household, if this is taught to the members of the family, the men, the sons, everybody, definitely India will definitely change and will go a long way. So I thank everybody for having given me this opportunity, and I wish this program all the best, definitely. Thank you so much.
Madam, for the blessings. Thank you so much, Madam.
Thank
I
you.
invite Dr. Rajeshri to introduce Dr. Kasturi, Madam.
Pranamam, everybody.
Just one sentence enough. Already we are running late.
It's my proud privilege to introduce our dear past president, Dr. Kasturi Dhonimath Madam, who is such a dear person in the entire Kasoga. She has been the president of Kasoga for the year 2022. Currently, professor and head of department for the Department of Obstetrics and Gynecology in KIMS, Hubli, which is a prestigious institute, ex-president of Hubli Dharwad Society, principal investigator for international research projects, MCI inspector to colleges all over India. She's been a UG and a PG examiner at many universities, chairperson of the graduation committee Games, and a TOT trainer, faculty at many state, national, and international conferences. Apart from that, she's been a Rotary member, which itself speaks of the character of the person, and conducted Gnana Harsha Kasoga PG CME for the last 6 years, which is quite popular among the postgraduate students, contributed chapters in many books, and conducted many workshops, CMEs, and conferences. Madam, please grace the occasion and comment about this conference.
First of all, thank you, Rajeshwari, for those such a beautiful words. You made my day. First of all, pleasant morning to one and all assembled here on the virtual platform. Ellarigu nanna namaskara. And I'm very, very happy to share this platform with Dr. Madhuri Patel, Secretary Foxy, and Dr. Cynthia Alexander, very, very senior person. It's a moment of privilege and a pride to share chair with such an eminent persons. And also to be chief guest for this OGCON, such a grand event, such an excellent academic extravaganza, which is again mastered by none other than Dr. Sampath Kumari. We are great friends. And I totally agree with Cynthia madam when she told how many hours she has in a day. Even I always think how many hours. Such an enthusiastic person, always full of activity. And we were together in many conferences. We were in Andaman. So many conferences. I am there with her. I really admire her. Actually, now she has to take a class to the juniors. What is the secret behind her, all this enthusiasm, energy, and she has to inspire. So we'll have one session on that sometimes. And this thing to Tamil Nadu OB-GYN Society, Dr. Revati, Dr. Kalpana, I can see, and Dr. Other members, secretary, treasurers, and Anjalakshi. I know so many members. So all of them for doing such excellent work in Tamil Nadu OB-GYN Society throughout the year. They have such master list that which they are going to do, and they're doing a great work. And by their great work, they have reduced the maternal mortality in Tamil Nadu, even morbidity and mortality. I'll be usually asking, let us see what Tamil Nadu is doing so that we can apply it in our state and we can implement and reduce. So we would be looking up to you all from all the seniors from the Tamil Nadu OB-GYN Society, Dr. Revati and team, and Dr. Sampath Kumari. So let us interact with each other and see what we can practically put in our society, in our area also, which we have done to reduce the morbidity and mortality. Yes, this is the need of the hour, reducing the mortality and morbidity, because we cannot see a young woman dying due to some preventable causes. So I know most of the things are due to neglect in the periphery and so many other things, so many are beyond our reach. This is always I tell pregnancy, delivery is like unpredictable thing, and suddenly something will pop in. So, but let us see what all at least which we can prevent. And now we have from Kasoga a very, very dynamic president, Dr. Vidya, and very dynamic secretary, Dr. Rajeshwari, and treasurer, Dr. Suman. They all are a great team with a great EC team, and the EC members are also very active. They have taken charge just 1 month prior, but they are already doing so much activities, so many this thing. They have planned so well the whole year. I'm sure this year is going to be great under the leadership of Dr. Vidya Thobe and Dr. Rajeshwari and Dr. Suman. So this collect and collaborate, which Dr. Vidya's theme is there, I also endorse it. This is way how now Tamil Nadu, Kasoga, together we are doing this academic extravaganza for 2 days. So this way, when we connect with other states and do, we can get ideas, this transfer of knowledge. Knowledge, if it is just kept to ourselves, it has no value. Only when we share it with others and at the end, help the society at the ground level, we are really doing some work. So if a candle, just if it alone burns, no value. If it lights so many other candles, it can light the whole area there. So that way, same knowledge sharing is extremely important, skill sharing. So this kind of conferences are a need of the hour. And yesterday, even I attended excellent topics. A to Z of obstetrics was covered. Today, looking forward for A to Z of gynecology. And thank all the faculty for preparing such a short notice and delivering in such an excellent way. As thank you to all the faculty for yesterday and today. and all the delegates who have joined in. Only because of you all, it makes a grand success. Thank you once again for inviting me as chief guest, and all the best wishes for the today also. Thank you. Looking forward for more such events. Thank you. Yeah.
Thank you.
Thank you, Dr. Kasturi ma'am. With the wonderful blessings from Dr. Madhuri ma'am, Dr. Cynthia ma'am, and Dr. Kasturi ma'am, we will go to the scientific session. I would like to introduce our coordinator, my MOC, Dr. Rajapreeti. Dr. Rajapreeti is an assistant professor at Government Teni Medical College, and she has done her MBBS in Chettinad and MS in Mookambika Institute of Medical Sciences, and she is consultant at Punitam Hospital, Madurai, member of FOXI and TNFOG, presented papers in various conferences. Welcome, Dr. Rajapreeti. Rajeshri, who is having from your side?
It's Dr. Shobha Shavi. She's online.
Yes, we have another MOC, Dr. Shobha V. Dr. Shobha V. She is a consultant in Sanjeevani Hospital, Bahalkot, and Secretary, Bahalkot OBG Society, past Secretary, Critical Care Committee, Kasoga, Chairperson, Safe Motherhood Committee, Karnataka, presented posters and papers in national and international conferences, participated in many CMEs, Government Jagdishwari Mishra Prize in ASUOG Lucknow, conducted many awareness program, and won first prize in poster presentation of Kasoga Conference, state coordinator for many projects. Welcome, Dr. Shobha. Dr. Rajapreeti and Dr. Shobha can take over.
Yes, madam. Good morning, everybody. It's a very great privilege to be with the stalwarts of both Karnataka and Tamil Nadu societies. I thank Dr. Vidya Tobi, Dr. Rajeshri madam for giving me this opportunity. And I also thank Dr. Sampath Kumari madam and Janaki madam for together creating this great event together with Kasoga. Rajpreeti, would you like to tell something before we move on to the speakers? Rajpreeti?
Shobha, you proceed.
Yes, madam. Yes. Now we have our chairpersons for the next, the first session of today. That is Dr. Rajeshri Palladi madam and Dr. Amala Devi J. I call upon Dr. Rajeshri Palladi madam to introduce madam. Madam is a very good friend of mine. She is the secretary of Kasoga. She is a very inspiring and hardworking lady. She is the professor and she is director of Aditya Multispeciality Hospital, Gulbarga, professor and ex-HOD of Department of OBG, KBN Institute of Medical Sciences, Gulbarga. She is an undergraduate and postgraduate teacher, postgraduate guide and examiner, undergraduate examiner, chairperson Genetics and Fetal Medicine Committee of Kasoga, and she did a great job during her session, during her tenure. And she is also the past president of Gulbarga OBG Society. She is vice president of Rotary Club, Gulbarga Executive Committee members, Kasoga, website coordinator, executive committee member of Kasoga, North Zone, organizer of 25th Kasoga State Conference in 2014, which was a great hit. And she is also faculty in many national and international conferences dedicated to women's health. I welcome you, madam, to chair this session. Dr. Amala Devi J. Madam is she is MD DGO from Madurai Medical College. She has joined Tamil Nadu Medical Services in June 1972, retired as project officer and joint director administration, DFW Chennai in June 2006. She has done more than 50,000 cases of lab sterilization from 1983 to 1986. She has won many awards like District Collectors Award, for family planning performance and best district administrator award in 2005, Lions Club of Dindigal for selfless and dedicated service, IMA Meritorious Award, Sri Shakti Award, best state doctors award, state secretary appreciation award for outstanding comprehensive service by a branch secretary. She has also won state president appreciation award for IMA for organizing protest for hospital protection in 2011. Dr. Abdul Munaf Best Writer Award, Penia Sintanai Semmal Award by Lion Cosmos Dindigal, State Secretary Appreciation Award for Tamil Contribution, Elakkiya Virudu by Teni Tamil Sangam 2017. She has been Honorary Secretary of IMA Dindigal Branch, Founder Secretary of Dindigal OB-GYN Society, President DSOG for the past 10 years. She is Member Quality Assurance Committee for Sterilization Services and President of DASS Forum. Her field of interest is women empowerment and adolescent. I welcome you, madam, to chair this session.
The next-
Rajashri ma'am, kindly unmute yourself and introduce the panelist.
It's my proud privilege to introduce Dr. Shobha Gudi ma'am, whom we have known in the Kasoga for past so many years doing active work. That is what it speaks for her, other than the titles she holds. She's been a postgraduate teacher examiner, chairperson for the Family Welfare Committee of FOXI 2019 to 22, and has done a very great job in that. President of Bangalore OBG Society for 2018-19 and assessor for the Government of India Project Laksh, which is very important for quality control of the government hospitals, board member of FPAI, peer reviewer of JOGI, GCM ICOG for 2021-23, president of Bangalore Menopause Society 22 to 23, chairperson for Contraception and Reproductive Health ISOPAP 2023 to 25, EC member of Kasoga in 2021 to 23, editor for Obstetric Hemorrhage and author of Foxy Focus for AUB, GCPR, SRH and LAB.
Thank you so much. Thanks, Rajesh.
Yeah, the list is unending,
Yeah.
but what I would like to say is she's a
Yeah,
very, very
thank you.
dedicated and passionate teacher and a worker and does her job so very well to the core. Over to you, Dr. Shobha Gudi ma'am.
Thank you, Rajashri, for the very, very kind introduction. And at the outset, am I audible well?
Yes.
It's my audio.
Yes, madam, you're audible.
Yeah, at the outset, I must thank from the bottom of my heart both TN Fog and Kasoga for giving me this wonderful opportunity on a Sunday morning to connect with so many of you on a subject which is so very important. Thank you, Rajashri, for the introduction. And I can see that the Kasoga platform has become so vibrant with my dear friend Vidya Tobi as the president, you as the secretary, and Suman as the treasurer. All of you very dear friends to me, very close to my heart, and I am really committed to contribute my bit to this great organization. And as for Dr. Sampath's lead, what can be said? I think we should not show a candle to the sun when we are talking about people who work so hard as Sampath. You are inspirational. And my pranams to Revati madam and to Cynthia madam, and to all. My greetings to Vidya Bhatt. I could see her also, to Dr. Anjalakshi and Dr. Bharti. I shall now proceed to, I think I was there when Dr. Madhuri was speaking, and I realized that, you know, she has been connecting so well to all of us, and I thank her for that. So I shall proceed, and I will quickly share my screen, because as I understand, we are already 15 minutes behind schedule. So I shall give a very brisk presentation, and the subject given to me was empowering the woman through offering her the best choices in contraception. And today we are standing with a very expanded basket of choice, especially in the private sector. So I shall make it very crisp, because I think that all gynecologists are aware of the contraceptive methods, but where we go down is that we are not putting it on our prescriptions with enough counseling, and that is where it is making the difference. So a few days back, all of us, you know, a little taken aback when we saw this in our morning newspapers, that India surpasses China's population. Well, it could be a little bit of a hyperbole, or it may be a slight exaggeration, because there are some of the reports which are saying that we are still at 141 crores and not 142.9. Nevertheless, this is what one of the figures have shown. And you know, this has happened very, very quick. And this has happened with so many efforts, in spite of so many efforts from the government. And it has happened in spite of having the longest enduring family planning program in the world. India was the first one to launch a family planning program at a nationwide scale. But then this was to be expected, because most of it is not working as well as it should. We are not surprised. Then what are we going to do about it is the next question. And that is why we must go on speaking about this problem, so that at least it stays at the forefront of our minds. And therefore, I congratulate the two great societies for bringing this subject into the forefront. So can the earth withstand the population explosion like this? This is what it will look like. And I worked for 3.5 or good 4 years for this committee in a dedicated way. And when I started talking about world population, it was 7.7. And when I'm ending my tenure, it became 8 population, 8 billion the world. And if we don't have good stabilization efforts, we will be seeing 15 billion by 2100. Earlier, it was 12 billion when I started speaking. Today, the projection looks like 15 billion on this planet. And certainly our country cannot afford it. It cannot take any more because there is a level of suffocation. Having said that, we must come back to our practice every day with the understanding that, earlier we said that 24 India will surpass China. We can see that today, 23, in the first quarter itself, we have surpassed the other country. And therefore, there is a very high medical need for contraception in our everyday practice, because more than 45%, almost 50% of our pregnancies are unintended. And if they could be prevented, I think we would have achieved a great deal. Going forward, not spending much time on these numbers, going to clinical matters, it is very obvious that when we offer women modern contraceptive methods and they take it up, majority of them are highly satisfied with the method. And the modern contraceptive prevalence rate is actually 40 to 50% today. It should reach 70% for us to make an impact. 19% of women still have an unmet need. In the latest survey, this number may have, the NFHS survey 1920, this may have come down to 15% or so. So increasing the choice should remain fundamental to our practice every day. We must bring in more than what the public basket offers. The public sector basket offers this much. In addition, there is centroman, of course, but what is missing here is non-hormonal contraceptive, which I do, the COC pill centroman, the implants, which I think Dr. Bharti will be speaking on this. There are female condoms in the market today, other natural methods to be propagated, and there are many more. So this should feature in the consultation room of every gynecologist. This should be blown up and put at least under the glass top table. You can keep it in below the glass top, and you can keep it in a way that the arrow points towards you and it is pointing away from the woman, so that she can easily make out which one is the most effective method. And you can see that the LARC method are equally effective as the sterilization. And then there are other hormonal methods, and then comes the LAM method and the barriers, etc. So we need to know what is most effective, because we need to counsel. So what about the combined oral contraceptive pills or the oral pills? And today, across the world, about approximately 25% of women are opting for hormonal oral contraception. But in India, it remains a dismal less than 5%, 3%. So we can improvise on our prescriptions of oral contraceptive pills. Today, we are seeing that the combined pill is the commonest prescribed, but let us remember the progesterone-only pill also has a very, very important role, and it is available today. It is very, very safe. It is more versatile than the COC. Let us also remember that continuous or extended use of pill also gives very good results, and it has special application in women who have associated gynecological disorders. Let us get oriented to the way in which OCPs act. Just let us remind ourselves that it does inhibit ovulation, does act on the endometrium, does act on the cervical mucus, etc. It also has certain systemic effects on the liver, etc., so that it has benefits beyond contraception for women with PCOS. We all know that very well. The evolution is very interesting to track. The first generation COCs had high levels of estrogen. Today, we have the third and fourth generation with very friendly progesterone, especially the drospirenone compound, and the Dynagest and the Nomigestol, which is of course not available, but the drospirenone and Dynagest have made a lot of difference to us, and we must feel free to prescribe them. The low dose OCs especially mean, when we say low dose OCs, what does it mean? Low dose COCs, this means that products which contain less than 35 micrograms of ethinyl estradiol, because that is what is going to affect the health of the woman when it becomes a long-term contraception prescription. The low doses of estrogens are better. So the combined oral contraceptives get prescribed as a 28-day regime, and in the 24 regime, which is very, very useful because the hormone-free interval drops to 4 days. In the extended regime, where more than 28 days is used, and continuous regime, where it can be taken 6 months to a year with, of course, constant visits to the hospital. MEC criteria should become integral to our knowledge every day. Application of MET criteria for prescriptions should also become everyday practice. And we must know that there are recommendations for every clinical situations for every method. Though initially the MET criteria were devised to make prescriptions of oral hormonal pills safe, it soon rapidly expanded to other methods. And today every method, every situation, and every life phase of the woman we have an opportunity to give her a basket of choice depending on all these three. It is also known as the Bitzer's triangle, when we try to fit in these three aspects and we try to prescribe a very good method of contraception, offering it in a basket of choices. That means for every situation, there can be at least 4 to 5 methods. These are recommendations for postpartum women, for women with medical disorders like dyslipidemia. These are requirements for criteria for progesterone-only pills. And then we have the relative benefits and the side effects of COCs. We know that it improves cycle control, acne, hirsutism, bone health, prevents cancers, and eventually reduces maternal mortality. Well, the fear about venous thromboembolism, we need to know that the incidence is very, very low, and the incidence which pregnancy offers as a risk to women is higher than what can be encountered with the prescription of COCs. The progesterone-only pills today in the market, we have drospirenone-only pills and the desogestrel-only pills. They are excellent options. Some of them, the LNG, is used as an emergency contraception. We all know that. Progesterone-only pills have got very high benefit because they can be safely prescribed in breastfeeding women also. That means a woman can start taking as early as 3 to 4 weeks after her delivery. The risk associated with breast cancer is similar to COC. Nevertheless, that means we cannot prescribe hormonal contraceptives for women with breast cancer, liver disease, current deep vein thrombosis, or women with history of pulmonary embolism. The efficacy and safety of low-dose pills have been well established through studies like this. And then we must understand the concept of SARC versus LARC in order to offer the women with higher nuancing the SARC methods. And LARC methods are those which are long-acting reversible methods. And here, the compliance of the woman has got a less role to play. These are lower failure rates, there is better ease of use, and they are estrogen free. That is what we need to remember. All the pills, the rings, the barriers, all of them are known as short acting reversible contraceptives, that is SARC methods. So this is a slide which shows the 4 commonly used LARC methods today. And I think if in the postpartum, post-abortal situations, if we opt for LARC methods, it gives very high dividends for the woman, and the counseling should also be directed similarly. We can also see here that LARC methods have very low rate of failure, and I think we are very perceptive enough to understand that with typical use of LARC methods, which is almost same as the perfect use because there is no compliance error here, we can see that it is as good as sterilization. So this LARC prescriptions are very well endorsed by NICE, ACOG, and even by POXI policy statements. And one of them is with a very high success profile is Antara, that is medroxyprogesterone acetate, has made real waves in the public sector. A very well-known mechanism of action, very well-known contraceptive benefits because it is convenient, easy, private, confidential, and pelvic exam is not required before prescribing, suitable for breastfeeding women after 6 weeks of birth, and provides immediate, in non-breastfeeding women, you can give it immediately, maybe as early as 3 to 4 weeks, and any age and any parity. So it can even be given in younger women. There are non-contraceptive benefits of all hormonal contraceptives, and we understand today that this also reduces the symptoms of endometriosis, PID, and protects against endometrial cancer. There are some limitations that it does not protect against the sexually transmitted infections. I needed to bring home the fact that there is a subcutaneous version with a 30% lower dose, only 104 milligram, and it is subcutaneous, and women can learn to self-inject the subcutaneous preparation, and it is very highly acceptable. It was very, very popular during the pandemic. The counseling should include the minor side effects as well, and it is widely used. Its effect on the bone density, which it often worries the practitioner, that what about the bones, will they become weak? So rest assured that it is actually very reversible. It can be used for years together. We can improve the woman's profile on exercise, give her more calcium and educate her, but generally it is acceptable to use. So very versatile method. Category 1 and category 2 are almost all women, including smokers and including women with gynec disorders and women who are on other medication like anti-tubercular and antiretroviral therapy also can use DMPA. Very few women with active thrombosis or active vascular disease or severe complicated diabetes are contraindicated. Of course, current breast cancer is also. Women with HIV, you can see that all stages and every type of treatment of HIV, it is category 1. So it is very useful. It can be initiated at any time, postpartum after 6 weeks, and this kind of calendar can be scheduled. The breakthrough bleeding, which sometimes happens also, is very troublesome for practitioners to control, and usually mefenamic acid up to 3 to 5 days will solve the problem. Otherwise, very rarely we have to supplement it with another, a strip of COCs. Okay, we shall move ahead to I think other methods. The implant per se will be dealt with by my colleague, Dr. Bharti. I bring in an adolescent here as a case scenario who is also having, features of PCOS. She's also sexually active. And in adolescence, we today understand that we can empower her with every choice. I speak this especially because to bring home the fact of dual protection. This will empower her to prevent STI as well as pregnancy. We can also offer these girls, if they are non-PCO, etc., that intrauterine devices. It is a misperception that intrauterine devices cannot be used for adolescents. It can be used. It has got a very good safety profile. So does intrauterine system of levonorgestrel, and in the IUD LNG IUS has got a really versatile role in the health of women, and we know that it really provides women a lot of relief when they are suffering from HMB and from heavy menstrual bleeding, and it offers them contraception as well. This is a slide which brings home the fact that 24x4 pill has got a very useful beneficial effect on women, because it reduces the drawbacks of 21/7 regime, the hormone withdrawal symptoms, and probably it is more efficient. It is especially useful for women with PMDD and also for women with PCOS. Coming to the end of my talk, I think now, I wanted to share this, that the United Nations has endorsed contraceptive implants as one of its 13 life-saving commodities as well as other contraceptives. You can see the bottom part which says maternal health. The life-saving commodities are oxytocin, misoprostol, magnesium sulfate, etc. But when it comes to reproductive health, the life-saving commodities are female condom, a contraceptive implant, and emergency contraception, because it protects a woman, empowers her to prevent an unintended pregnancy, prevents the harms of repeated abortions, and also protects her from the death due to an unsafe abortion. This is a slide which shows that a long-acting, highly effective contraception is useful in all these situations where woman is sick with other ailments, but it requires contraception because pregnancy is going to put her into a higher risk than what she is already suffering. So LARC methods, especially the copper IUCD, is very useful for women who have major systemic ailments. Okay, the slide has to move. I'm sorry. Sorry for taking this time. Okay, so family planning alone could bring more benefits to more people at less cost than any other single technology now available to the human race. I think this we must remember at all times. Let us create a world without unintended pregnancies. Let us empower our women with choice. And we can see that there is a lot more which can be done today. Thank you so much for the patient listening. Thanks a lot.
Shobha, unmute yourself. Unmute yourself.
Thank you, Shobha Gudi madam. It was a wonderful talk. Who is the best person to talk about family planning than you? Being the chairperson, a wonderful chairperson of family planning committee, you have done a wonderful job. Rajeshri madam, would you like to tell something about madam's?
As usual, madam is such an expert in covering the topic of contraception that it's a time that we realize we are on the time bomb, and very soon we may be exhausted with all the resources, and we have to take this matter very, very seriously. More than maternal mortality, I think population control is the prime significant point now. Thank you so much, Shobha Gudi ma'am, for doing such a wonderful job. Thank you.
Our next speaker is Dr. Vidya Bhatt. I call upon Dr. Rajeshri madam to introduce Dr. Vidya Bhatt. Madam, she'll be speaking on ovarian rejuvenation.
Yeah. What can I say about Dr. Vidya Bhatt? She's such a passionate, dedicated, and devoted person towards the fertility aspects of today that when I suggested some topics, she said, no, Rajeshri, I would like to talk on ovarian rejuvenation because that is what we are facing now. And in the difficult scenarios of the lifestyle changes which are happening nowadays, it's so very pertinent to know that we have to save the ovaries of the girls who are getting so exhausted so very soon. And to tell about Dr. Vidya, she is a laparoscopic surgeon and fertility specialist and medical director of Radhakrishna Multi-Speciality Hospital and IVF Center, Bangalore. She has conducted more than 200 live demonstrations on laparoscopic and hysteroscopic surgeries all over India, and she never gets exhausted of doing her demonstrations. And this year in Kasoga, she has offered to do 4 to 5 workshops in various parts of the Karnataka states, has contributed over more than 45 publications in national and international journals, contributed chapters in many textbooks, Times of India Award for Excellence in Fertility Enhancing Endoscopic Surgeries in 2022, Midlife Asia Award Best Fertility Consultant in 2021, Golden AIM Awards at Healthcare Leadership Award for Excellence and Leadership in Healthcare 2020, Economic Times Best Endoscopic Surgeon for South India 2019 and 2021, twice consecutively, Best Paper in IOG and AICOG, Best Paper in CSDON Prize for Endoscopy. She has held various important positions in the state as the president of Kasoga in 2017 to 18 and president of Bangalore Obstetrics and Gynecology Society in 2012 and 13, joint secretary of FOXY 2013, governing council member of IAG 2020 to 22 and 2015 to 17. And she has a passion for teaching and holds various positions in Rajiv Gandhi University and FOXY ICOG recognized training center for reproductive medicine and minimal invasive surgery and clinical embryology, and has trained more than 500 students, both national and international. At such a young age, she has achieved a lot, and I feel very proud to be associated with her as a friend. Welcome, Dr. Vidya Bhatt.
Thank you, Rajeshri, for the lovely introduction. And it's very nice to be in our south, Yangala South, that is yes, Tamil Nadu and Karnataka. That's basically because I'm so connected to Tamil Nadu also, and of course, Karnataka is my extended family. I feel a little guilty of talking about this topic of ovarian rejuvenation after Dr. Shobha Gudi's enormous talk on contraception and how much we have to do to control the population. But please allow me to talk about this, because the diminishing ovarian reserve is a big challenge for our career women. And today we are facing a lot of problems with diminishing ovarian reserve and with new ART rules, which says that don't use a donor, or third-party reproduction is becoming a challenge. So in the next few slides, I'm going to talk to you about this ovarian rejuvenation, where we can help those women to become mothers by some means and give them a little hope. So talking about ovarian rejuvenation, we have been striving hard to rejuvenate this ovary, which becomes devoid of follicles. And how do we do this? What are the things which we should do to get back, or at least get some follicles to reproduce or do an IVF cycle and get a pregnancy? So ovarian function is egg quality, egg quantity, and together we call it a ovarian reserve. The chronological age and the biological age gives a lot of problems to the woman with loss of oocytes and ovarian aging. We all know that at fetal life, we have a lot of follicles. At birth, 1 to 2 million. In the reproductive phase, we have about 3 lakhs to 4 lakhs ovarian follicles. And at menopause, we have only 1,000 follicles. And when there is diminished ovarian reserve, we bank on these 1,000 follicles. So what is the cause? It remains elusive, but what we have derived out of research is mitochondrial dysfunction with associated oxidative phosphorylation, and reduced ATP level. So this leads to diminished ovarian reserve. Now, what are the guidelines? When we say ASRM definitions, when we look at that, we call it ovarian reserve at a given time, the number of follicles produced by the ovary, the oocytes, at a given age. Whereas when we say it is diminished, the ovary fails to produce, or there is lower count and quality of the remaining eggs which are left in the ovary. Now, when we look at the ISHRAE definition of poor ovarian reserve, it is the poor response which is identified by the reduction of follicles, and with maximum stimulation. However amount of gonadotrophins you pump into that lady, she will not get those follicles. And the Bologna criteria says with advanced age, there is poor ovarian reserve. With poor ovarian reserve, even if you give more than 150, you may not get the conventional oocytes. And abnormal ovarian reserve tests, that is AFC and AMH, which are economical and the best to know the ovarian reserve. Now, the Posidion classification, what does this say? It says that the female reproductive system undergoes changes over time due to aging, pregnancy, and other factors. These can result in reduced fertility and other complications. So you have young women with decreased ovarian reserve, a young woman with decreased AMH, older women with, that is above 35, with decreased number of follicles and decreased ovarian reserve. That is basically age, AMH, and the number of oocytes or no oocytes which are derived in the previous IVF cycles. But what is the good news here? The group 1 and 3 have good quality oocytes of this Posidion, which is the best followed. And the group 2 and 3 will have embryos, but they are of high aneuploidy risk. So in this poor ovarian reserve, when we say that if we stimulate a woman, we get less than 4 follicles, then we say this woman needs to go for IVF or she has poor ovarian reserve. Now, what are the causes for this? Of course, radiation therapy, infection, mumps disease, endometriosis, which is very common, and we see in many women now, and they have to be identified at a very early age. And of course, smoking, which we have to ask, even though the patient gets offended, we have to ask that whether do you smoke, and if you smoke, it is going to cause you problems. Now, what are the tests we do? Of course, as I said, AMH, antral follicular count, and then the ovarian volume, and comparing both the antral follicular count and the AFCs, I mean the AMH. The age, when you look at the reserves, you have to look at the age, their menstrual cycle. They'll complain of decreased quantity of flow. Forget about the PCOS. The decreased ovarian reserve women, they complain of irregular cycles and decreased quantity of menstrual flow. And AFC, of course, ovarian volume and ovarian blood flow also we have to see. And FSH levels on day 2, if it is going to 9 and 10, then she is in for poor ovarian reserve. AMH levels, inhibin B, which is done in the mid-cycle. And of course, the clomiphene challenge test, and then the endogenous FSH and the gonadotrophin tests can be done, which are a little dynamic. Then when do you do these tests? AMH on day 2, and it can be done even in at a later date also. AFC on day 2, FSH and inhibin. FSH day 2 is better, and inhibin in the mid-cycle. Then the adjuvants. Now to the actual talk. What are the adjuvants you'd give to improve the ovarian reserve or to get the better quality oocytes? That is growth hormone, pyridostigmine, coenzyme Q, testosterone, DHEA, AS, and letrozole, and estrogen and OC pills. With all this, we'll also have to see how much evidence is there. Growth hormone, of course, the mode of action is it enhances the ovarian response to FSH, and then the growth hormone promotes this IGF, that is insulin growth factor F, and 2 IGF-1 and 2 also. It stimulates and plays a crucial role in cytoplasmic maturation, and also its actions to FSH, but there is not much of evidence. So it can be given as an adjuvant, but there are some papers which say there is poor response, and even the exact dose is not given. 1 to 12 units, they say, from the day of stimulation to the HCG trigger. And there are large studies which say they do not really help. We do have a publication on this, but it is a small number where we saw there were good number of oocytes and there was a good response in the ART cycles. Then there are some studies which promote growth hormone. They say that the pregnancy outcome is better when you have poor ovarian reserve. What about this pyridostigmine? This is an acetylcholine inhibitor which enhances the action of acetylcholine and which inhibits somatostatin and release in the brain, and thereby it increases the growth hormone. The same principle, which is given about 60 mg twice daily, but there's not much of evidence on this, but a try can be given always. Coenzyme Q, of course, this has a lot of evidence. How does this work? The post-ovulatory aging, what happens here? There is superoxide increase, apoptosis increase, because we are left with only 1,000 follicles. And in each cycle, when the follicles are recruited, there is apoptosis happening. And when this apoptosis happens, if we prevent this is the basic principle of treating a woman with diminished ovarian reserve. If we can diminish this apoptosis, which happens by giving you coenzyme Q, there is diminution of apoptosis. You get a better quality oocyte, and then you can give better yield. So in another study, it is said that there is better fertilization rate, the embryo cancellation, that without forming the embryo, the cycle gets cancelled, that is decreased, and the fertilization rate is improved. So this has good evidence. So we can give coenzyme Q. And there are many studies which suggest that this improves the ART cycle and live birth rate. So we can try coenzyme Q. Letrozole, of course, this has been tried now, but there were negative reports before. So there, what happens in letrozole, these responders, the intra-ovarian androgen concentration are increased by inhibition of aromatization, leading to potentiation of follicle response. So There was one study in 2017 which said, please don't give letrozole. But the subsequent studies said that minimal stimulation protocols with letrozole and gonadotropin improved the IVF cycles. And 2011, it said that there was better response and better oocyte yield and better pregnancy rates with letrozole. And then the key meta-analysis came, and which said that in 2020 to increase the cumulative pregnancy rate, fewer days of stimulation, you can decrease the amount of gonadotropins also and reduce FSH consumption. So you have to treat with letrozole as a co-treatment with ovarian stimulation. We do that and we have got results. And the ASRM guideline says that in poor responders, there is a fair evidence that clinical pregnancy rates after IVF are not substantially different when comparing the mild stimulation using combined oral agents and low dose gonadotropins. So, but there's no live birth rates there. So ASRM guidelines gives a different opinion. So we have to try what is best for us. So testosterone, this is being now used in abundance. So the mode of action is it increases both the antral follicles and the number of granulosa cells. It increases the receptors and then the granulosa cell proliferation, and it has indirect effect by conversion of estrogens through 3-beta diol, thereby increases the estrogen receptors. So you have a better yield. So testosterone is given, and then DHEA. What happens with DHEA supplementation? There is increased androgen, increased FSH, increased rescue of atresia of the follicles, and apoptosis is decreased. This is the basic thing. If we can correct this, then we can get a better yield. And then, of course, you get an increased ovarian response and oocyte yields and increased oocytes and better embryo quality. But the studies do not support this. They said there are 2 meta-analyses which said, no, it doesn't have very good results. Of course, estrogen and progesterone combination pills, when you give prior treatment to patients with poor ovarian reserve in ART cycles, so the increased homogeneity of the follicle cohort induced by steroid pre-treatment, though improve and synchrony of the follicles during the cycle. So estrogen pre-treatment definitely helps in stimulation of the ovarian stimulation of the cycles. Adjuvant therapies, of course, androgens and growth hormones we have spoken about. Aspirin also is given, but not much of evidence, but you can always try these. The ISHRE also says that there is not much of evidence on this, but the newer approaches to parenthood. This is the gamete ovarian rejuvenation. So this refers to restoring the ovarian function in women with diminished ovarian reserve or premature ovarian failure. One promising technique of ovarian rejuvenation is tissue cryopreservation and ovarian transplant. That is, you do ovarian tissue cryopreservation can be done. But of course, if you think of the future, people who have not thought about this, for them, you can use PRP. This PRP has given promising results. So you take the patient's blood, you centrifuge it, you get the PRP solution, and then you inject ultrasound-wise. So what is this composition? It has platelet-derived growth factor, it has VGF, it has transforming growth factor beetle, then it has keratinocyte growth factor and epidermal growth factor and fibroblast growth factor. One is for tissue repair, wound healing, and growth, new generation keratinocytes, and then endothelial cells are transformed. This helps the growth of new vascular endothelial factor, and this helps the cell growth. So what do? You collect the patient's blood. The PRP kits are available, so you centrifuge that, and then you get the activation of platelets in PRP, and ultrasound or laparoscopy wise, you inject into the ovaries. Then the stem cell therapy, which is a new hope, that is regenerative medicine and biomaterials approaches to treat the injured uterus, including the uterus and the ovaries. So direct injection of bone marrow derived stem cells. So how is this done? Let us see it in the video. We do it in our center now, which is quite promising. We have done many cases. Now we have started getting cases from abroad also. So we take from the patient's iliac bone. One thing we have to keep in mind, there could be negative taps. So the orthopedic surgeon has to be very good. And I'm blessed with a son-in-law who is doing all these procedures. So it is very easy. It is inside the family now. So we centrifuge it, our embryologist centrifuges that. And of course, we put in a laparoscope. Look at the ovaries. They are so tiny. How will these ovaries produce follicles? So you take the ovum pickup needle. We take the ovum pickup needle to inject it into the uterus and into the ovaries, because this causes minimal trauma and there is no through and through. You can go in through millimeters and you inject it into the ovary, about 3 ml into each ovaries. Above that, the ovary can't take. Don't cauterize. If there is bleeding, just hold it for some time and then it'll stop, and then you inject. And we also inject it into the endometrium to get good endometrial thickness and better conception rate. Of course, ovarian tissue cryopreservation we should start doing, because our women are now career oriented. We have to slit the ovary, take out the strips, keep the ovarian tissue for cryopreservation, and then once again, you burrow into the ovary at a later stage and then implant these strips and then start stimulation. But before that, please do ovarian tissue ovarian oocyte cryopreservation before doing this, because you never know how good are we in technology. So self-fertility preservation has to be there. That is why we say oocyte cryopreservation. Always offer to your patients that this is available, and then this is their future investment on fertility. The different ISHRE recommendations for protocols, but ideal would be the pool IVF stimulation. You can do genetic pool, minimal drugs, embryo pooling can be done, and pre-genetic screening of these embryos, and then embryo transfer. We do 3 cycles of these pooled stimulation and ovarian tissue, embryo cryopreservation we do. This is our study between 2018 to 23, 17 patients, number of conceptions 10, about full-term delivery 6, number of miscarriages 2, and number of ongoing pregnancies 2. And this is still in press. We are coming out with this publication. So this is the new hope for our patients. Any kind of protocol you can try. There is no hard and fast rule for the protocol. Antagonist, agonist, microflare, letrozole. We tried this, and agonist stop protocol or dual protocol, whatever you want, whichever protocol is convenient. These are the treatment basis for poor ovarian reserve. It is available in the net. So you can, I will not go through this because it's available everywhere for Posidion, poor ovarian reserve, and the best protocols for 3 and 4. This is a little difficult to treat because we land up with abnormal embryos, that is aneuploidy. So we'll have to really do PGD for these embryos. And these are the ISHRE recommendations for the protocol. So to conclude, ovarian rejuvenation has to be considered in women with poor ovarian reserve, ovarian responders, depending upon the Posidion criteria. This is the best criteria. And then with the new ART bill, seeking third-party reproduction is a challenge. Let's not get into the legal problems. So pool IVF stimulation should be considered whenever required. And stem cell therapy shows probably promising results in the future for these women seeking parenthood. Thank you very much for your kind attention.
Yeah, thank you very much, Vidya, for bringing in a topic of very, very clinical relevance. I would like to share a clinical experience which I had. A 20-year-old girl, second-year MBBS, who was delivered in my hospital. Her parents brought her to me and said, here is the girl whom you have delivered. And since 2 years, she doesn't have a menstrual cycle. On evaluation, we found that she had premature ovarian failure. That is when it stuck. That so much is the rise in the incidence of premature ovarian failure in such young girls without any reasons, without any kind of habits or any kind of thing, that it's time that we gear up our clinical acumen to deal with such scenarios which we face day in and day out. And we are seeing many cases who are in the age of 25, 30 coming with premature ovarian failure. And Vidya, I must say, you have done a wonderful justice to the topic given to you, and a topic of passion to you. And I realize that definitely infertility treatment, we have to be moving forward ahead, and gone are the days wherein we were taking the oocyte donation. And as you said rightly, that we have to think of options which would be suiting and doing better work for the patient care. And two good friends, Shobha Gudi and Vidya, talking at the extreme of the topic, but both are very important and relevant. Just as population is important for the nation, but fertility is very, very pertinent for the family who are planning for pregnancy, and such, especially young girls who are facing the challenges of premature ovarian failure. Thank you so much for doing the.
And one more point I want to highlight. It's very sad that we see this in our gynecologists. So I always tell them, please give a break to your career immediately after you finish post-graduation, because the biological clock and the career clock clashes to them. So please, especially for gynecologists, I think we have to be very considerate, because I'm seeing more and more juniors, my students, coming with this problem. So we have to consider them.
Thank you,
madam.
Thank you so much.
Thank you, Vidya Bhatt madam. That was a wonderful talk. After listening to two time bombs ticking, next we go on to our next talk, that is PMS and PMDD by Dr. Suhasini Karnal. I request Dr. Rajeshri madam to introduce the speaker.
Dr. Amala Devi ma'am is joined, ma'am, if you don't mind.
Oh,
sorry.
Yeah,
Okay.
I think we can ask her to introduce.
Dr. Amala Devi ma'am. Amala Devi ma'am, please.
Yes.
Yeah,
So
please introduce.
I'm happy to introduce Dr. Subhashini Karnal. So she's the consultant obstetrician and gynecologist and laparoscopic surgeon, assistant professor in Sri Muthukumaran Medical College, UG Chengalpat Medical College, PG in CSI Rainey Hospital, Dandayarpet, Foxy member, life member of IMA Tambaram, KOGS, Indian Menopause Society, and faculty in regional and national conferences. I welcome Subhashini to give her speech.
Thank you, madam, for the nice introduction. After two excellent talk by experienced speakers, I take the opportunity to thank Dr. Sampath Kumari ma'am for giving me this opportunity. So my topic is about premenstrual syndrome and premenstrual dysmorphic disorder. The topic may seem very simple, but the symptoms of it sometimes may be very severe and very distressing, so that it affects the quality of life. And sometimes people take off from their routine work, and also there is problem with their relationships also. So it's very important for us to know at what stage we are supposed to treat them and how we have to go about in the premenstrual syndrome and PMDD. So first, starting with the definition, according to RCOG, it's a condition which manifests with distressing physical, behavioral, psychological symptoms in the absence of underlying organic or psychiatric disease, which regularly occurs during the luteal phase of each menstrual cycle, and it disappears or significantly regresses by the end of menstruation. So what is PMDD? It is a more severe form of PMS with severe depression, emotional and cognitive behavioral symptoms affecting daily function and relationships. So how common is it? Approximately 80% of all women have at least one symptom of this PMS, and 5% of them suffer with severe PMS. If you take the prevalence of PMS in India, it ranges from 14.3% to 74%, and the prevalence of PMDD 3.7 to 65%. So the types, there are core PMDs and variant PMDs. The core PMD, the symptoms are non-specific and it recurs in each ovulatory cycles. It is present during the luteal phase and abate as the menstruation begins. And it is followed by a symptom-free week. So there are three types: mild, moderate, and severe. Mild does not interfere with the personal or social or professional life. Moderate, it interferes with the personal, social, and professional life, but still they are able to function and interact. When coming to severe, they are unable to interact personally or socially or professionally, and sometimes they even withdraw from the social and professional activities. We have variant PMDs, premenstrual exacerbation of an underlying disorder, such as you have an underlying disorders for diabetes, depression, epilepsy, asthma, and migraine, and these patients will experience symptoms that are relevant to the disorder throughout the menstrual cycle. And non-ovulatory PMDs occur in the presence of ovarian activity within an ovulatory cycle. Progesterone-induced PMDs are caused by exogenous progesterone intake, as in hormone replacement therapy, or by the combined oral therapy. This reintroduces the symptoms to women who may be very sensitive to the progestogens. Then PMDs with absent menstruation in women who still have the functioning ovarian cycle, but for reasons such as hysterectomy, they don't have periods, but still they suffer from this PMDD. So coming on to the causes, still the cause of PMS is unclear, but various researchers have been going on to find out the exact cause so that they can aim at a proper treatment. So these are the various causes that has been attributed to PMS, the progesterone and estrogen fluctuation during the cycle, and there is a genetic background and the previous history of any mood disorders and stress, which forms a major part, and there's increased inflammatory response during the luteal phase of the cycle, smoking, and you have neuroendocrine factors such as reduced serotonin and GABA A, and altered sensitivity of the GABA to the system of allopregnanolone. It is a derivative of a progesterone, which is derived after ovulation. So what are the symptoms that are attributed to PMS? You have psychological, cognitive, and physical symptoms. The psychological symptoms include irritability, mood swings, depressed mood, crying spells, low esteem, anxiety, sleep disturbance, and increased appetite. The cognitive symptoms include forgetfulness and decreased concentration. Physical symptoms like breast tenderness, bloating of the abdomen, fluid retention, weight gain, constipation, hot flushes, headaches, musculoskeletal discomfort, acne, rhinitis, and palpitations. So what are the risk factors that are associated? The risk factors are high caffeine intake, alcohol abuse, stress, anxiety, and with increasing age, overweight, and dietary factors also. So how are we going to diagnose whether these patients are having premenstrual syndrome or a mild form of menstrual problem? So you have to ask the patient to maintain a symptom diary. These symptoms should be recorded over 2 cycles prior to commencing the treatment. So if the completed system diary alone is very inconclusive, then you have to give a GnRH analog. It should be used for 3 months, and then if the symptoms are getting reduced, then you can come to a definitive diagnosis. So this is the diary which we give to the patient to maintain for 2 months. It has all the symptoms along with the pain score of, the severity of the symptom, and it has to be maintained for 2 months. The symptoms, all the symptoms have been included in this chart, and also we have they have mentioned not the severity in the boxes. We have to mention by marking it as X. So they're given rating like 1 not at all, 2 minimal, 3 mild, 4 moderate, 5 severe, and 6 extreme. So this diary they have to maintain for 2 months for us to come to a diagnosis for PMS. So the criteria to diagnose PMS, according to ACOG, they have given this criteria. At least one of the following affective and somatic symptoms during the 5 days before menses in each of the 3 previous menstrual cycle. The affective symptoms are angry outbursts, anxiety, confusion, depression, irritability, and social withdrawal. The somatic symptoms include abdomen bloating, breast tenderness or swelling, headache, joint or muscle pain, swelling of the extremities. So these symptoms should be relieved within 4 days of the onset of menses without recurrence until at least 13 days of the cycle. So symptom-free period must be there and must be present in the absence of any pharmacological therapy, hormone injection, or drug or alcohol abuse. So these symptoms must occur reproducibly during the 2 cycles of prospective recording. And they also must exhibit identifiable dysfunction in social, academic, or work performance. So this is for PMS. And for PMDD, according to the Diagnostic and Statistical Manual of Mental Disorders in the 5th edition, they have given criteria for premenstrual dysphoric disorder. Here, they have to have at least 5 symptoms in the final week before the menses, and they should start to improve within a few days after the onset of menses. So one or more of the following symptoms must be present. That is marked affective liability, including mood swings, feeling suddenly sad or tearful, increased sensitivity to rejection, marked irritability or anger, or increased interpersonal conflicts, marked depressed mood, feelings of hopelessness, marked anxiety, must be there. At least one or more of the following symptoms must be present. So decreased interest in usual activities, subjective difficulty concentrating, lethargy, hypersomnia or insomnia, change in appetite, and a sense of being overwhelmed, and physical symptoms. So from the A to C criteria, at least 5 should be there, and that should be occurred in most of the cycles during the preceding year. So this is the criteria for PMDD. So what are the various treatment options that are available? So it should involve a multidisciplinary team, including a general practitioner, a general gynecologist, and with a psychiatrist or a clinical psychologist, counselor for counseling, and a dietitian as well. And the first and foremost thing will be for us to do a lifestyle changes, to concentrate more on doing exercises, taking a healthy, balanced diet, and reduce and manage stress by meditation or yoga. And the second thing will be to give psychological support and therapy, which is very much important for those people suffering from PMS. So you can go for cognitive behavioral therapy, discussing the symptom with the therapist and giving a positive input. The other next form of therapy is complementary therapy, including calcium supplementation, vitamin D, B6 supplements, and zinc, which are considered to be low in case of patients with PMS. And you have other form of complementary therapy like Vitis agnus, that is castus. It is known as a herb known as chasteberry, ginkgo biloba, and EPO for breast tenderness. So coming into the medical treatment per se, first line of therapy will be non-hormonal. The first choice is SSRIs and SNRIs. It is taken in a daily basis for 2 weeks before the periods or all through the cycle, or you can go in for a semi-intermittent regimen, which is you start with low dose during the follicular phase, and then you go on for the higher dose in the luteal phase. So what are the side effects expected? Nausea, insomnia, tiredness, and low libido. And if in case you want to discontinue the drug, you have to gradually withdraw for us to avoid the withdrawal symptoms. So the drugs mainly used are fluoxetine 20 milligrams, and the paroxetine, sertraline 25 or 50 milligrams, and escitalopram. You can also use alprazolam, which is an anxiolytic, 0.25 milligrams. And you can consider using diuretics. The most commonly used is spironolactone, 100 milligrams. And on to the hormonal treatment, the first choice will be the combined oral contraceptive pills. And the most effective combination is drospirenone and ethinyl estradiol. Drospirenone 3 milligram and ethinyl estradiol 20 micrograms with a short hormone-free interval. That is, you can go in for a continuous cycle rather than a cyclical one. And then percutaneous estradiol combined with cyclical progestogens. It helps in the management of physical and psychological symptoms. So transdermal estrogens, 100 microgram estradiol patches twice weekly can be used with in PMS. The combination you have to combine with a cyclical progestogen. You can use the lowest possible dose of progestogen, and the less likely to reintroduce the PMS-like symptom by the progestogen, you can use micronized progestogen. The other newer drug which can be used is dutasteride. It is an inhibitor of 5-alpha reductase that converts progesterone to allopregnanolone. It modulates the progesterone and the allopregnanolone balance. And then isoallopregnanolone, that is sepranolone, is an allosteric modulator of GABA-A. The dosage is 10 milligrams subcutaneous every second day during the luteal phase. Then ulipristal acetate, that also can be used for this PMS, 5 milligram per day. Then danazole, low dose danazole is very effective for the breast symptoms, but it has potential irreversible virilizing effects. So contraception should be advised during this period to prevent potential virilizing effect on the female fetus. And for severe PMS, we can go in for GnRH analogs. But if it is used for more than 6 months, it should be there should be an add-back therapy with combined ocipil salt. And measurement of bone mineral density is very important. And treatment should be stopped if the bone density declines. And we have tried with everything, the medical management fails. And in more severe cases of PMS and PMDD, you can go in for hysterectomy. And HRT should to be considered. If suppose we are going for bilateral oophorectomy without removal of the uterus, then you have to use a progestogen. And this carries risk of reintroduction of PMS-like symptoms. So you have to think of these side effects when you're doing bilateral oophorectomy alone. So this is in short, the first line therapy is exercise, and the combined oral contraceptive pills to be used continuously or during the cyclically in the luteal phase alone. The second line will be estradiol patches combined with the micronized progesterone. On the third line will be GnRH analog, and finally, if nothing is responding, the fourth line will be surgical management along with hormone replacement therapy. So this is a chart showing how we have to go about in treating the PMS. So the patient is going to maintain a symptom diary, and based on the symptom diary, we can go about in treating these patients. So if the symptoms are cyclical, relieved by menstruation, and you have a symptom-free week, no influence on the quality of life, and no additional factors, then you can give just counseling and reassurance, and there is no necessity for any treatment. If the symptoms are cyclical and relieved by menstruation, and you have a symptom-free week, but it affects the quality of life, then you can go consider alternative approaches to the treatment. If the symptoms are cyclical, relieved by menstruation, affects quality of life, and you have an existing non-menstrual condition, then the treatment should be aimed at treating the underlying medical, physical, or the psychiatric illness and suppress ovulation to avoid the symptoms. If the symptoms are cyclical and you have a symptom-free week affecting the quality of life, no additional factors, then you can treat them as core premenstrual disorders. If the symptoms are cyclical, relieved by menstruation, affecting quality of life, and the patient is already on a progesterone treatment, then you can consider going in for an alternate progesterone treatment. So to conclude and summarize, PMS is always usually underestimated, considering it to be normal for all the females, but sometimes it may be very severe to incapacitate the women. And symptom diary should be at least maintained for 2 cycles before you go on to make a diagnosis and to evaluate for the treatment plan. Always include a multidisciplinary team, and initially go with the lifestyle changes, diet, exercise, and complementary therapies. And you go for combined OC pills and SSRIs in severe cases. And that is last line of treatment, GnRH analogs and the surgical approach. Thank you.
Thank you very much, Dr. Suhasini. That was a very crisp and focused talk on PMS. Amala Madam, would you like to give your
Yes, the 2 symptoms, that is the psychological and the cognitive symptoms, are the most disturbing for a woman when she gets into this PMS. And I just want to know whether it is the which group, either it is the adolescent group or the middle-aged group, which is commonly affected. Suhasini, I just want to hear from her whether what is the particular group that is maximum people, women affected by PMS. And like all the
extremes of age, ma'am, usually in the younger age and as also the age advanced during menopause.
Yeah. At the younger age,
very common in
they will cut their schools, that is, the studies are affected. And women already, they are in the menopausal, premenopausal or menopausal group. They will be already in depression. So both the extreme groups, and the treatment as in for all gynecology, either it is in PCOS or endometriosis, the lifestyle modification and the healthy balanced diet and yoga. Nowadays, they talk a lot about yoga, which can give, and then you should give any patient who is in the early symptoms, you should give them counseling that it is a normal procedure, normal physiological changes occurring in your body, and it's nothing to worry. And sometimes we may need the psychologist or psychotherapist help to treat them if they are having very severe symptoms. So you told me that you started in the beginning that 2 speakers, after the 2 speakers, I am going, you exceeded them. Actually, it's a very small thing. We are not practicing commonly and not aware also. Most of the gynecologists, when somebody comes in these symptoms, we used to give them some placebos only, not exact drugs. But infertility and all, they are unpracticed. So this is a small topic, even though you had given in a very detailed note for all the gynecologists who attended this would have gone a clear-cut idea about your this thing. So thank you. Congratulations.
Thank you so much.
Thank you, Dr. Amala Devi Madam and Rajeshri Madam for chairing the session. Now we move on to our next session. We have 2 dynamic speakers for the next session, Dr. Bharti Rajshekar Madam and Dr. Kalpana Madam. For this session, I call upon the chairperson, Dr. Usha and Dr. Sujata Madam. To introduce Dr. Usha Madam, she has done her MBBS from Coimbatore Medical College, DGO and MD from Kasturba Medical College, Mangalore. She has a fellowship in fetal medicine in 2008 from Mediscan. She is a senior consultant in Lotus Hospital, Erode since 2000, consultant in Lotus Fetal Medicine Center since 2008, conducting UST training program in association with Mediscan Chennai, past president of EOGS. Her area of interest are high-risk obstetrics and fetal medicine. I welcome you, madam. Our next chairperson is Dr. Sujata Alageshan. She is professor in obstetrics and gynecology, Tirunelveli Medical College and Hospital. Foxy Tirunelveli branch secretary for 5 years, conducted live ops and gynec workshop, presented 5 national papers, won best paper award in Yuva Foxy and national faculty in AICOG twice. I welcome you, madam. I request the chair.
Thank you very much, madam.
Madam, there is some
Bharti, you must have logged in 2 devices. Hello, Bharti.
Vidya, it's not mine, which is echoing. I think it is
somebody else.
Yeah.
So, yeah.
Not mine.
Sujata ma'am, please introduce.
Good morning, madam. Good morning, madam. Sorry for the little net. I'm having some net problem. So only it is difficult to join. So I have opened another system. I have closed it, madam.
Yeah.
Okay.
So please introduce now, Dr. Bharti.
Madam, I can't see the slide, madam.
It is
there.
there.
Madam, it's a great pleasure, madam, to have our speaker, Dr. Bharati Rajashekar. Madam, am I audible, madam?
Yeah, you are audible, Dr. Sujata. You can go ahead.
She is the president-elect for KSOGA for 2023-24, past honorary secretary 21-23, and Sahitri Multispecialty Hospital, Hazan. She has held various posts, madam, from KPMA State Vice President, Indian Red Cross Director, IMA State Vice President, past President, and also past President and Secretary of Hazan, OBGN Society. And also she has been a secretary and also PCPNDCT committee member and an executive member of HSSC. She is the Foxy Food Medical Equipment and Drug Committee, and she's from a Preventive Oncology Committee member, Foxy Public Awareness Committee, South Zone member, coordinator, and she's also a trainer for the Foxy DIRA program and Foxy RAC program. Madam, excellent schedule she is having, and we are very blessed to have such a wonderful speaker. We are waiting for you, madam.
Thank you, Dr. Sujata, for this introduction. And at the outset, I would like to congratulate the TNA FOG and Kasoga for having this Connect and Collaborate feast on Saturday and Sunday. And I'm truly enjoying all the sessions. My special thanks to Dr. Sampath Kumari and Dr. Vidya Thobi for giving me an opportunity to be on this platform. And well, today we have had a lot of doyens speaking of different spectrums of women's health. And this is one more prospective issue which we need to create awareness among our gynecologists first before we put it into practice. Are my slides visible, Dr. Shobha?
Not it. Madam,
No,
I've shared
madam.
I've shared it.
We are sharing, ma'am.
Yeah,
We are sharing.
Yeah.
You are sharing it now?
Yeah.
It's not in full screen.
It's in full screen, ma'am.
Yeah, just a minute. Yeah, fine. Thank you very much. So, well, at the outset, can you change the slides as I speak? Yeah. So this is Connect and Collaborate between Tamil Nadu and Karnataka. It brings me immense pleasure because I belong to both the states. I have had all my education in Tamil Nadu and all my clinical practice in Karnataka. So I think I'm the apt person to be connecting and collaborating. Next slide. So next slide. Yes. So family planning could provide more benefits to more people at less cost than any other single technology now available to the human race was proposed as early as 1992 and was quoted by Dr. Shobha Gudi also. Next slide. So we are proud to say that the Indian government brought in the National Family Program way back in 1952 as one of the first countries to have a national program of family planning. And we have come a long way since 1952 to 2012. We have many options in our basket for the betterment of women's health. Next slide. But unfortunately, though we have seen a steepest decline in the growth rate in the last decade, we still have a long way to go. As Dr. Shobha Gudi quoted, we are on a time bomb, just waiting to overtake China. And that is depleting our resources. So the fertility rate, as you see, has been declining from the year 2005 to 2020, but much has to be done. Next slide. Yeah. So what is India's commitment, which was made in the London Summit on Family Planning in 20? It was India's Vision FP 2020 is to ensure access to family planning services to an additional 48 million women by 2020, increasing the financial commitment on family planning to more than $2 billion US, expanding the basket of choices and scaling up the use of currently available methods, and ensuring availability of free commodities and providing services to all clients, including adolescents, through the integrated reproductive, maternal, neonatal, child and adolescent health program, which is a strategic approach towards birth control. Next slide. To prevent unintended pregnancies. But sadly, though, when we look at this chart, we see that the female sterilization is what is occupying most of the options available, and the traditional methods are 6.7, and male sterilization, that is dismal 1%. Next slide. So, coming to the subject, long-acting reversible contraceptives, implants and intrauterine devices are the long-acting contraceptive methods that are highly effective in preventing pregnancy. They are cost-effective and they are associated with high levels of satisfaction and continuation. However, in India, currently, the IUD is the only long-acting reversible method which is available in public sectors and in most private sectors. Hence, introducing implants into the family planning program of India will provide another choice to the current method mix and accelerate India's commitment for universal health coverage through family planning. Next. Yeah. So what are implants? Implants are small solid masses consisting of highly purified drug made by compression or molding or extrusion. Implants are drug delivery systems which provide a controlled delivery of drug over a period of time at the site of implantation. So what are the contraceptive implants we have? Next. Yeah. So we have this contraceptive subdermal implant, which is an excellent method of contraception. They are small and rod-shaped. They provide long-acting, highly effective reversible contraception. They are non-biodegradable and have only progestogens. They provide a controlled release of progestins over years, and the rods are implanted surgically into the upper non-dominant arm, which may be the only hitch in promoting this implants. Next slide. So it is about 1.6 inches long and just about 4 centimeters, that is about 4 centimeters. It is the size of a matchstick and it is flexible and it can be bent. So it does not cause any harm when implanted. Next slide. So we have two types of implants available across the world. The one was the levonorgestrel implant, was the familiar Norplant, the Jadal and the Sino implant, and the newer implants which contain etonorgestrel, which is the Implanon and the Nexplanon. Next slide. Yes. So what is the mechanism of action of implants? Because they contain only progestogens, they cause a thickening of the cervical mucus, making it difficult for sperms to penetrate and prevent ovulation in about half of the menstrual cycles. Next. So as you all know, levonorgestrel is a totally synthetic biologically active progestin. It causes viscosity, increases the viscosity of the cervical mucus, and it inhibits ovulation by action on the hypothalamus and pituitary to suppress or reduce the surge of the LH that triggers ovulation. Next slide. Yeah. So Jadal is these are not available in India right now. It is this Jadel is manufactured by Bayer Healthcare. It consists of two implantable rods, 2.5 millimeters and 43 millimeters in length, and they contain a drug-releasing core encased in a silicone rubber tubing. It consists of 50% by weight of levonorgestrel, that is about 75 milligrams, and it can be used for a long term up to 5 years as a reversible method of contraception. Next. And this is the pictorial depiction of how the silicone core has a levonorgestrel core which will release the hormone systematically throughout the 5 years. Next slide. Just like the Mirena that we use. The Sino implant was manufactured in China. It is similar to the Jadel, contains of two rods which contain the levonorgestrel. Next slide. Over the years, we have come out with better molecules, that is the etonorgestrel. It is a synthetic progesterone very similar to levonorgestrel. The mechanism of action is similar to levonorgestrel, that is cervical mucus thickening and preventing ovulation. However, next. The difference between LNG and ENG is ENG is more potent than LNG. Serum ENG levels show less individual variation over time as compared to the LNG levels. That's the only difference. So the ENG implants are the single rod implants which are in use nowadays. It is a single rod which lasts for 3 years, measures 4 centimeters long and 2.2 millimeters in diameter. It is made up of a core containing 40% ethylene vinyl acetate copolymer and 60%, that is around 68 milligrams of ENG, surrounded by a 60 micropore skin of EVA copolymer. Etonogestrel releases at the rate of 60 to 70 micrograms daily initially, and then it slows down to 35 to 45, and gradually over the third year, it may release as much as 25 to 30 micrograms per day at the end of the third year. Next. So the initial serum levels are quite high to prevent a level that exceeds the 90 picogram ml, which is needed to prevent ovulation. The maximum serum concentrations are seen within 4 days. Hence, it becomes effective immediately after insertion, and its level slightly decreases over the period of 3 years. And after removal, the serum levels of etonogestrel are undetectable by 1 week in the majority of users, with most women demonstrating ovulation within 6 weeks of implant removal. That means their return to fertility is almost immediate. So this is the pictorial depiction of the Implanon kit, which comes with an applicator, which with the implant preloaded, and I will be talking to you about the implant insertion in the next few slides. Next slide. The Nexplanon is manufactured by Merck. It is similar to Implanon. The only difference is it has barium sulfate added to that, so that makes it radio opaque on sonography or on X-ray or CT imaging in case there is a difficulty to locate the implant. Next slide. Next slide. So what does it do? Implants can be used for women in all scenarios. It can be used to delay conception. It can be, that is in adolescents, it can be used even those who have not had a child. It can be used for spacing in between children, and it can also be used to end childbearing once the woman has completed her family. The advantages are it provides 99% contraception efficacy. It works for longer periods, that is 3 years, the single implant. It is safe to use while breastfeeding. It is an option when estrogen-based contraception is contraindicated. It is totally reversible. Return to fertility is almost immediate. The implant may reduce heavy periods or painful periods after the first few years of use. Next. So this is the comparative study between the other available options like Depo-Provera, which has to be used every third monthly. Copper T can be up to 10 years it's used. LNG Mirena 5 years, and the Implanon can be used up to 3 years. But the return of fertility in the last 3 is almost immediate, in contrary to the long-acting Depo-Provera. Next. Next slide. So the disadvantages, as with any other method, there may be vaginal bleeding may occur at irregular intervals, and bleeding patterns may be unpredictable. There may be a period of amenorrhea, which needs to be explained to the client before we insert. Of course, due to the progesterogenic effect, there may be slight weight gain, acne, fluid retention, headache, breast tenderness, abdominal pain, improved PMDD, irritation, and itching at the insertion area. And the other disadvantage is it does not protect against HIV or other sexually transmitted infections. Next. The contraindications, of course, with anything, as with any other progestogens, Any person with unexplained vaginal bleeding, history of heart disease or stroke, anybody with venous thromboembolism, diabetes, current and past breast cancer, and liver disease, active liver disease, it may be used with little caution. Next slide. Or contraindicated. And what does the WHO say for women with HIV? There is no restriction on the use of progestogen only implants for women living with HIV. So it comes under the category 1. However, those women who are on ARBs, it falls under MEC category 2. So when women are being using efavirenz for HRT therapy, they will have to use a better method, that is, along with the implant, they may have to use condoms. Next slide. Yeah. So when do we start this? Well, this is such a wonderful implant that it can be started at any time in most of the women. So when to start having, whenever she's having her menstrual cycle, or if she's switching from a non-hormonal method, you can use it start it at any time of the month. If it is within 7 days after the start of her monthly bleeding, she can have the implants inserted immediately and there is no need for a backup method. However, if her menstrual period was more than 7 days after her monthly bleeding before she gets the implant, she will need a backup method for the first 7 days after insertion. Next slide. For women who are fully or nearly fully breastfeeding, it can be inserted at any time. Only thing is, if her monthly bleeding has returned, she can have the implants inserted as advised by the previous slide that I told you. If it is a woman with more than 6 months after giving birth, you can insert the implant at any time. Best made, if you're reasonably certain that she is not pregnant, she will need a backup method for the 7 days after insertion. If her monthly bleeding has returned, then you follow the same criteria as I told you with the menstrual cycles. Next slide. Next slide. So no monthly, that is when she's having lactational amenorrhea, she can be inserted at any time reasonably, just to make certain that she's not pregnant. After a miscarriage or abortion, if it is within 7 days after a first or a second trimester abortion, she can have the implants inserted immediately and no backup method is required. If it is after 7 days, she needs a backup method as in the previous scenarios. Next slide. Yeah. And what are the common side effects? But before we insert, we need to explain and counsel them and make them understand what it is. Tell them what are the common side effects and how they can be overcome. And tell them that these are going to be transitory. And of course, she will overcome these side effects. And most women may not even have them. Next slide. Next slide. Yeah. So how do we insert the implants? You have to explain the insertion procedure, probably with a video demonstration, or have a ready reckoner on your table and tell them how it is going to be inserted. A woman who has chosen the implants needs to know what will happen during insertion. And the person who is going to insert has to learn the method of insertion. They have to practice under direct supervision and then only take up the implants insertion. Inserting implants usually takes only a few minutes, but can depend on the skill of the provider. Related complications are rare and once again depend on the skill of the provider. So excellent training program by the Government of India and the FOXI is required for insertion. Next. Next slide. So this is the insertion procedure, and what we need for that is we need antiseptic solution, gloves, local anesthetics, sterile gauze, skin closure sutures, and a pressure bandage. And this comes as a preloaded implant, which preloaded applicator, which has the implant inside the needle. So what do we do? Next slide, please. Next slide. Yeah. So place a clean, dry cloth under the woman's arm and position the non-dominant arm, that is usually the left arm, with the elbow flexed and held behind her ear. Mark the position on the arm for insertion about 8 to 10 centimeters from the medial epicondyle and 3 to 5 centimeters below the sulcus. Then prepare the skin and observe this track and then infiltrate local anesthetic, and then using the no-touch technique, you open up the applicator, hold it at the textured surface, visually verify the presence of the implant, and then you have to gently insert the needle just below the skin, stretch the skin above that, you don't go deeper, and puncture the skin at 30 degrees angle, and then insert only the bevel of the needle. Next slide. Yeah, and once you have inserted the skin, you have to pass the needle all through under the skin, and then there is a button to thrush the implant, and so you slowly press the purple button which hold the applicator and press the purple slider so the implant gets into the subcutaneous space, and then gently remove the applicator, place a sterile dressing, observe the patient for about half an hour for bleeding, and then send her home. Next slide. Next slide. So this is the very simplified locating the insertion site, applicator being positioned, needle insertion just like we insert a cannula into the intravenous site, and then you deposit the implant. Next slide. And of course, we know that Dr. Shobha Gudi has been instrumental in training during the ICMR studies for the insertion of and removal of the implants. So what do we do post-insertion? Ask her to keep her arm dry. She may expect a little soreness or bruising at the site on 1 or 2 days. Explain that it's important to have implants removed before they start to lose effectiveness. That is around 3 to 5 years. Give each woman the following information card: the type of implant on the arm which has been inserted, the date of insertion, when does it have to be removed, and where does she have to come in case she has any issues. Next slide. Yeah, and generally there is no follow-up required for implants. Next slide. Unless, of course, when would you ask her to come back at any time? If she has questions or wants another method, if she has major changes in her health status, or she thinks she might be pregnant, or she has pain, heat, or signs of infection at this rod site, or she wants the implants taken out for whatever reason, it is time for the implants, then you can ask her to come back. Next slide. Side effects I've already enumerated: irregular bleeding, amenorrhea, headache, that is the progesterogenic effects. Expulsion of implants are very, very rare. Next slide. Which are the situations to switch over? Maybe when she has migraine with aura, deep vein thrombosis, abnormal vaginal bleeding, not responding to routine treatment, ischemic heart disease or suspected pregnancy, it is time to switch over. Next slide. So removal of the implant again is a very simple procedure. So for whatsoever reason she comes to you for removal, you have to remove it, of course, after a preliminary counseling. Explain the removal procedure, discuss the options which she can have to continue contraception. If she wants to have a pregnancy, counsel her about preconceptional management and give her folic acid and allow her to go for pregnancy as she wishes. So the same sterile tray is required. Next slide. And then you make a small nick. After the local anesthetic is inserted, you make a small nick, you locate the rod, make a small nick, use a curved artery, and just pull out the implant. Next slide. Next slide. Yeah, so I'm just skipping these slides. Next. Said ensure that the complete rod has been given. So what do? Palpate the rods, making an incision over there, grasp the rod with the cryal forceps or curved artery forceps, remove the rod and inspect whether it is completely be removed, put a sterile dressing and send her home according to what she has come for. So the advantages and disadvantages are: advantage is a controlled drug delivery, there's improved patient compliance, targeted drug delivery, it bypasses the first liver metabolism, decrease of side effects, improved stability of drugs and availability. Disadvantage is the only thing in Indian scenario I would say is the mini surgery which is needed, which may be slightly painful, and you know how fastidious our women are, even for intrauterine contraceptive device. So this is where counseling and awareness is very, very important to overcome this disadvantage. It is uneasy for some. So let us come back to some clarity over the implants. Can implants be left in the woman's arm? No. Once the duration of 3 to 5 years is over, we need to remove it. Do implants cause? These are the common questions they will be asking you. No. How long does it take to become pregnant after the implants? Usually 6 to 8 weeks. Will the fetus be harmed if the woman becomes pregnant accidentally with an implant in place? Is a no, because it is only a progestogen releasing implant. Do implants increase the risk of ectopic pregnancy? Definitely no. Can a woman start with breastfeeding start implants? Definitely yes. Can a woman work soon after having implants? Of course she could, but of course she may have a little discomfort in the arm. So an analgesic may help her and she can go on with her normal activities. Can women, including adolescents, use implants? Yes. The WHO has recommended that even adolescents can use implants. Next slide. Next slide. So the implant has helped hundreds of thousands of women in Africa and Europe. The results was proper spacing in childbirth. The children born have been healthy, capable of surviving against the odds. So why not in India? Why not implants in India? It's high time that we bring the implants into our country in the government of India bucket. So the contraceptive implants are on the radar of the health ministry. They have received an ICMR report on the efficacy of these birth control tools that are in use in Western countries for the last 10 years. And it has been discussed in the Lok Sabha that the implants have to be introduced into the government of India contraceptive basket. Next slide. Next slide, please. Yes. So these were the studies. ICMR, I think our family welfare chairperson, Dr. Shobha Gudi, was part of this study. 3,119 women were studied. Implanon was offered along with the existing contraceptive methods. And the positive side was that the relative acceptability of Implanon was observed to be 2.1% among all contraceptive methods. So there is an acceptability. So let us overcome that myth in our mind that our Indian women may not take up the implant. Next slide. Next slide, please. Yeah. So, and the economic studies were conducted, and it has been said that if we include the implant into the family planning program, if only 3% of our women shifted to implants, the total annual direct cost related to unintended pregnancies would reduce to almost $199 million. And the reduction in unintended pregnancies achieved through this uptake would lead to an annual cost saving of almost $27 million from the public health perspective. So it is concluded that introducing implants into India's family planning program can prevent a significant number of unintended pregnancies, leading to fewer maternal and neonatal deaths and cost savings in the health system. Next. And the FOXI also endorses that contraceptive implants are as efficient, reliable, and long-term. And FOXI believes that implants are promising, effective method of contraception. Next slide. Next slide. So our women deserve better. Let us give them what are the options available and let them make their choice. They need to be empowered. We need to give them the best that we could. Next slide. So family planning services are not a privilege, but a basic human right. No client in need should go unserved, and no client should be denied the choice she wants. So I think it's high time that the government of India, the FOXI endorses and pressurizes the government of India to give these women another beacon of hope so that they can live a safe and healthy life, and our women and children can be better for life. Thank you very much. Next slide. So I thank the TNFOG and the KASOGA for giving me this opportunity, and an humble appeal to all the people assembled here. I am contesting for the FOXI Non-Communicable Disease Committee as a chairperson. Nominations are open. The president and secretary of all societies would have to nominate me for chairperson of non-communicable diseases. My humble request to please nominate me and vote for me. Thank you very much. You can end. Shobha, please end. Please end.
Yes, madam. Thank you very much, madam, for that wonderful talk. You're always a confident and a comprehensive speaker, and all the best to you for your nomination. And
please don't forget to send my nomination.
Definitely will do, madam.
Thank you.
Madam, best wishes for you, madam.
Thank
I'd
you.
like
Thank
to
you,
ask
Sujata.
Bharati, madam, one thing.
Yes.
Madam, we have actually, when we introduced PPIUCD, that is the postpartum and the post-placenta, we had the little difficulty. Now it is trained throughout.
Yes.
And
yes,
all
exactly.
paramedicals, everybody is utilizing. So similarly, in near future, the FOXI and the Indian government will train so that it will come into use widely. And
Yes,
another
definitely.
thing, madam, in the perimenopausal AUP, progesterone releasing IUCD will be better than this, no, madam?
No, but what they say is if IUCD also can be used, well, like the Mirena, but if she wants an additional, she doesn't want an intrauterine contraceptive device for whatsoever reason she may choose, you can, and she has say other comorbidities which she doesn't want, you can always insert the implant also. They are similar. Because even this will also reduce the abnormal uterine bleeding pattern,
but the
reduce the heavy menstrual bleeding.
Endometrial shrinkage is very nice with that locally acting.
Yeah, of course,
device.
in Mirena it is definitely nice, but they say this also produces amenorrhea. Of course, I don't have any practical experience, but studies show that they also can be used in women with abnormal uterine bleeding after you rule out any malignancies, just similar to the Mirena. But we are using the Mirena, as you said, in perimenopausal age women, and we are having wonderful results. And we have been able to save many a uterus by using the Mirena.
And the vasectomy is still in the single digit, madam.
Yeah. That is the one very big hitch in our family planning program, because it is often not spoken about by anybody in any platform. We have just almost given it up like. It is just less than 1%. We just have 10 cases, 15 cases in each state. The statistics are very, very poor, and the woman is the one who's being targeted the most often, and she is the one who suffers because of unintended pregnancies. So and the moment we say vasectomy, the woman herself has got this myth which also needs to be removed, and we have to create awareness, I would say.
Next webinar, we will have a talk on how
Yes,
to
madam.
increase the vasectomy.
Yes, madam. And that, madam, we will call the other doctors from
exactly.
IMA and general surgery and all those people on the panel.
General surgeons, maybe.
General surgeons. Thank you, madam.
Thank you very much.
Thank you, Bharti. It was a wonderful talk.
Thank you, Dr. Vidya.
There's a little change in the schedule. We'll be having the panel first, then we'll have Dr. Kalpana's talk because the panelists have to attend one more program. So I call upon Dr. Jyotika Desai, madam, to moderate the panel discussion.
Dr. Shobha, 1 minute.
Yes,
Before
madam.
Dr. Jyotika, I wish to inform that Dr. Bharti Rajshekar is contesting for NCD committee in Foxy.
Yes.
I request all of you to nominate and vote for her.
Surely, madam.
All Tamil Nadu societies.
Thank you
All
so much.
Karnataka.
All Karnataka.
Karnataka already she has given up.
Ma'am, just tell the panel.
I belong to Tamil Nadu and Karnataka, half and half.
She has told in her introduction only.
Best wishes, madam. Definitely you will
All
get
the
through, madam.
best. Yes.
Good morning, friends. It's an
We will introduce you, ma'am.
And we will put the CV slides, ma'am, first.
Yeah, it is full screen. Everything is there. Can see it.
Jyotika, ma'am,
Jyotika, they want to introduce you, Jyotika.
introduce the panelists.
Okay, fine. I'll stop it.
Yeah. Shahidi.
Just one. Okay, fine.
Shobha, madam, kindly introduce.
Make it very
Dr.
short.
Madam will introduce. Okay, and now we have Dr. Jyotika Desai, madam. She's a senior consultant from PR Desai Hospital, Bangalore, DNB teaching faculty. She is chairperson of IMS Education Committee, honorary secretary of ISOPAR, Bangalore chapter, chairperson website committee, past president of Bangalore Society, past president Bengaluru Menopause Society, Foxy South Zone Quiz coordinator, scientific chairperson of ACOG 2019, organizing chairperson IMSCON 2020 Bangalore, recipient of 4 gold medals in MBBS, recipient of Best Committee Award for IMS website chairperson, Lifetime Achievement Award, and Unsung Hero Award 2019 from IIRRH in Life 2019. Madam is going to moderate this wonderful session on immunization. Thank you.
Yeah, thank you so much. Can I share my PPT now?
Madam, you have to introduce your panelists.
Yeah, if I can share my PPT, I will introduce.
Okay, it's already there, madam.
No, I've already taken all the, yeah, that's right.
Yeah.
Can you see it now?
Yes, ma'am.
Can you see my PPT?
No, madam. We are not it.
Okay, then I have to get out and then come back because you all had. Okay. So then I have to go into Zoom. Can you see it now?
Slides are there, madam, but you have to make it full screen. Slide share.
It is slide share already.
Yeah, now it is, madam.
Okay, thank you so much. I thank the KASUGA as well as the Tamil Nadu Federation for asking me to talk on this very important topic and not wasting much time. Prevention, as you all know, is better than cure, and an ounce of prevention is worth a pound of cure. So today we are going to talk on vaccination for women at all ages. And I have experts with me, starting with Dr. Pushpalakshmi, Dr. Rajapreeti, Dr. Rupa Prakash, unfortunately, is not well. She's got a very bad cold. So she rang up in the morning and said she won't be able to make it. Dr. Rachana, Dr. Shanta, and Dr. Jyoti. I'll be introducing my panelists. Dr. Jyoti is a consultant at Jyoti's Women Care and Fertility Center in Guru Kottureshwara Clinic. She is a secretary of the OBG Society of Chitradurga. Welcome, Jyoti. Then Dr. Rajapreeti is an assistant professor in Government Teni Medical College Hospital. She's got the Best Doctor Award on Independence Day and also got an award in the Youth Marathon CME. Welcome, Dr. Rajapreeti. Dr. Shanta Shekhar is from Shimoga, Shanta. She was the organizing secretary of Kasoga in 2017. Welcome, Dr. Shanta. Dr. Rachana is the vice president of Tumkur OBG Society and also the chairperson of the Medical Disorders in Pregnancy Kasoga. And she's got fellowships in fetal medicine, ultrasound, OBG, and infertility. Welcome, Dr. Rachana. Dr. Pushpalakshmi Raja is an assistant professor in Government Teni Medical College, and she also was awarded the Best Doctor Award on Republic Day celebration in Teni.
Thank you, madam.
Mid-conference in 2021.
This is better.
Okay. So here we go. We will start. I hope all my experts are ready. Please keep your mics on. And
Yes, ma'am.
I can't see you all, so I'm just going to call you all. So maybe you can answer immediately and kindly make the answers correct so that we can finish it on time. Immunization refers to the artificial induction of immunity. It can be either by active immunization where live attenuated infectious agents are used, or inactivated toxins, or again by antigens which are obtained by genetic recombination. Whereas passive immunization gives temporary immunity, which is obtained by giving immunoglobulins or antitoxins. Now, vaccinations, as we all know, are among the greatest public health achievements of the 20th century. The very first vaccine was developed by Edward Jenner against smallpox in 1796. And almost a century later, Louis Pasteur followed with a vaccine against rabies. The rest, of course, is history. Now, why is vaccination important for us especially? Because smallpox was eradicated from India in 1978. And again, in 2014, India was officially declared as being polio-free. And all the vaccine-dependent diseases like diphtheria, pertussis, tetanus, measles, mumps, rubella, all of them are reduced much more since what it used to be a decade earlier. But this is just to tell you worldwide the incidence of vaccine preventable diseases. You can from 1980, it has come down, though recently there was a recrudescence of measles again, and again on mumps. So apart from this, you know, most of the diseases, the VPDs as we call them, have come down. And today we are only going to talk to you about, or rather, we are going to discuss about vaccination amongst adolescents, pregnancy and lactation, and in the elderly age group. So let's talk about vaccination in the adolescent. India was recently declared as the youngest country of the world. Why? Because more than 50% of our population is less than 25 years old. Slides are not moving. Yeah, thank you. So less than 50% of our population is less than 20, more than 50% are less than 25 years, and about 30% are adolescents. So we need to give more importance to adolescents. Now the adolescent age, unfortunately, is like a no man's land. By who should vaccinate? Does the pediatrician vaccinate or the gynecologist? And between the tussle, most of the adolescents don't end up not being vaccinated at all. And this shows that the coverage is only around 65% all over the world, and more so in India. So Dr. Pushpalakshmi, you're the opening batsman. What are the recommended adolescent vaccines in India?
The recommended immunization schedule is for 11 to 12 years, we have to give DDAP, annual influenza, and HPV vaccine. The catch-up vaccination, which includes the MMR, varicella, and typhoid, and hepatitis A and B. The high-risk population, we have to give pneumococcal, meningococcal vaccine, and Japanese encephalitis, rabies, and seasonal vaccines, which include the cholera and yellow fever.
Thank you, Pushpalakshmi. We will go now. Since Rupa is not there, would anybody like to take up this? What is vaccination? Yeah, continue, dear.
As we all know, vaccination in children are being covered by universal vaccination program in our country, and it is very robust when it comes to pregnant women as well as when it comes to the children less than 5 years of age. Once they cross 5 years of age, people have to pay for vaccines in our country. So these catch-up vaccinations are being needed for these children who don't take at their scheduled years of age, they have to take those vaccines. The catch-up vaccinations in our country is very much needed so that these children are prevented from vaccination preventive diseases. Vaccinations which are given for catch-up are MMR vaccine. We all know that as age advances, and in these children, the immunity reduces. So catch-up vaccination are MMR vaccine, the varicella vaccine, which is given in 2 doses, and hepatitis A and hepatitis B vaccine, as well as typhoid vaccine. We also have to think over about our HPV vaccine once the child crosses 9 years of age, both in males and females, as well as Tdap vaccine.
Thank you, Mom. You did justice to it. Now, this is something which all of us are aware of, but may not be so cognizant. The mission Indradhanush was a big success. And because of this, WHO has declared that India has reached an elimination stage for tetanus in August 2000. Hello? Now, because of this, but though we have reached the elimination stage for tetanus, that does not mean that we stop immunizing our population. We continue to immunize so that we continue to remain in that stage. So immunization against tetanus must continue. Why is it necessary that we have to give immunization against tetanus? Because the mortality in mild and moderate tetanus is only 6%. But in severe tetanus, it can be as high as 60%. Now, I want you to look at this, the vaccine preventable diseases, the VPDs as we call them. This is from WHO, and this is about the summary in India. You can see that diphtheria has risen. This is only till 2019. I couldn't get statistics beyond that. This is diphtheria has increased. You can see that measles has come down, but not so much. Pertussis also is very much there. Rubella is increased actually, and even tetanus is almost in the same phase. So what does this indicate? This indicates that we continue to do it. Now, Dr. Rachana, how often?
Yes, ma'am.
The TD vaccination, TD or TT? Right now, I will tell you about it later, but how often should you take TD vaccination?
Yeah, ma'am, as we all know, small children, that is neonates less than 1 year, they would have received the tetanus vaccination. So this tetanus does not give immunity for more than 10 years. It usually lasts around 10 years. So we have to give protection to them every 10 years. So this immunity keeps waning. Hence, we have to repeat the vaccine at a decade later. Every once in 10 years, you give TD vaccination. And also, if the child or any individual has an injury or is posted for a surgery, you can give a booster dose, irrespective of whether they have had the vaccination priorly. So whether we know the vaccination their status earlier, so we can give a TD.
Yes, Rachana, thank you. Now, it is important for us to remember that the size of the wound is not important when tetanus is concerned. Even a tiny wound can lead to tetanus. So kindly see that any wound you are protected by your booster dose. Now, there are some facts about pertussis. A lot of discussion keeps happening about whether we need to give pertussis at all. But mind you, look at the statistics. India ranks #1 globally with 24,000 pertussis cases, and this was way back in 2017. And it contributes to 43% of pertussis cases every year globally. Now, this is an undiagnosed and an underreported disease, and it has been estimated for one reported case of pertussis, 83 more infections may go undetected. So now, Dr. Rajpreeti, do you think adolescents require pertussis vaccination?
Yes, ma'am. This pertussis is an endemic disease, and adolescents serve as an important reservoir. They may spread the infections. So to the vulnerable population like young infants. So better to vaccinate all adolescents at around 11 to 12 years of age against pertussis. It provides herd immunity in the society.
Thank you, Rajapriti. So we come to diphtheria again. We don't think of diphtheria beyond children, but now studies have shown that there is a shift to the right, and more adults and adolescents are getting diphtheria. In fact, as recent as 2018, Delhi had a diphtheria outbreak where more than 50 children were lost. Though I know it is fatal on only 5 to 10% of cases. And again, India contributes to 86.66% of global cases according to WHO. You can see the rising number of diphtheria cases in India. So what I'm reading to now is, do we need to give Tdap vaccine? Because you know that Tdap has both tetanus, diphtheria, and pertussis. Dr. Shanta, what are the recommendations for Tdap vaccination in adolescents?
All adolescents between 11 to 12 years of age, they have to be given one Tdap injection. And as well as people who have been given TD, also they need to take Tdap, because there is no immunity against pertussis. And pertussis has got very implications in children with increased mortality in these children.
We come to that.
Tdap has to be taken in 11 to 12 years of children, and also those children who are less than 7 years as catch-up vaccination we have to give.
Now, there's one important thing which we need to remember. We know that when we give to children, we call it DPT. We don't call it Tdap. But when it comes to adolescents and adults beyond the age of 7 years, we call it Tdap. Why? Because the dose of diphtheria and pertussis vaccine is markedly reduced in the Tdap vaccine compared to DPT. So kindly don't interpose DPT for Tdap or vice versa. And FOXI has been recommending Tdap since 2014. Now we come to the most important one, HPV vaccine. We all know why it should be given in adolescents. I'm not going to go into the theory behind it. As of now, we have 3 important vaccines, Cervarix, Gardasil, and Gardasil 9. But apart from that, in September 2022, Serum Institute of India has launched Cervavac. It is a quadrivalent HPV vaccine that is developed along with the government. It was supposed to be priced at 200 to 400 per dose, but somewhere down the line, it is being sold at more than 2,000 per dose. And this was released in as recent as March 2023. Now, there are some updates from WHO, which was as recent as May 2023. That is just a few days back. WHO has updated its recommendations for the human papillomavirus vaccine. Earlier, I think one of the participants will tell us about the dosage, but now a single dose schedule has been promulgated, because this is an alternative to the 2-dose regime, because it can provide a comparable efficacy and durability of protection, just like a 2-dose regimen. And this was recommended by WHO's Independent Expert Advisory, SAGE. This was way back in 22, and this is a WHO SAGE member who said that these recommendations will pave the way for more girls and women to be vaccinated and thus prevent cervical cancer. And this was ably assisted by the IARC. And we know Dr. Swaminarayan is very much part of the IARC. So Dr. Jyoti, now what are the recommendations for HPV vaccination in adolescents? I would like you to tell us the updated recommendations.
Ma'am, in India, both Indian Academy of Pediatrics and POXI recommend the HPV vaccine. And the minimum age for administration is 9 years, ma'am. HPV vaccine was approved for 9 to 26 years. But now in adults up to the age of 45 years can be vaccinated. Yes. But according to WHO, 9 to 13 years should get to 2 doses, 1 at 0 and 6 months. More than 14 years, 3 doses can be administered at 0, 1 and 6. But according to FOXI, 9 to 14 years can be given 2 doses at 0 and 6 months. For 15 to 45 years, 3 doses can be given at 0, 1 and 6 months. But one thing is you have to use the same brand of vaccine for the entire series, madam.
Yeah, Dr. Jyoti, what I would like to tell you is now, according to what WHO has mentioned in May 2023, a single dose suffices. And this is from the IARC as well as SAGE recommendation. And I hope the government takes it up. So if we give just one injection, economically, more children, more of our girls can take it up. That is one thing. Second thing is, 2 doses are sufficient. Earlier, beyond 14 years, we used to give 2 doses. Now, beyond 21 years, 2 doses are more than enough. and less than 15 years and up to 20 years, 1 dose is enough. So I hope all of us take this back so that more and more of our children can be vaccinated against HPV and cervical cancer incidence can be decreased. Now, Dr. Pushpalakshmi, is flu vaccine important in adolescents?
Yes, madam. Our adolescents should receive a single dose of influenza vaccine. As we told earlier, it's an annual vaccine. The strains of the influenza will get changed due to the antigenic shift and the drift. Every year we'll have a new vaccine. They should be get vaccinated around the end of September and October. That is around the rainy season. We have to vaccinate our adolescents.
Very good. So all adolescents require it. Now, what about rubella? Rupa is not there. Who's going to take this up?
Myself, ma'am.
Okay, rubella, varicella, we're going to deal up all these. Okay? Yeah, continue. Now, why is it important?
Yes, madam. Rubella vaccination, as we all know, it is a lifelong immunity. The rubella infection is usually presented as with a low-grade fever, sore throat, and rash. It resolves on its own in 10 days. So it's very difficult to elicit a history of rubella infection in adolescents.
Yes.
So we have to, all the adolescents should receive a single dose of rubella. And they should postpone the pregnancy for next 3 months. It's very important. It is given to prevent the congenital rubella syndrome if the woman gets affected in the first 3 months of gestation. So we have to give the rubella vaccine, preferably in the post-menstrual period, and we can advise the women to postpone the pregnancy for next 3 months.
I have something to say here, Pushpa.
Yes,
why we are worried about rubella is because 85% of the babies born to mothers in the first month, if they had rubella, they'll be abnormal. That's one thing. Second thing is, we don't have Indian statistics, but there is a study from Vellore which reported that congenital rubella syndrome constituted about 9.8% of all children born there with congenital infection. That means our immunization for the immunization of adolescents with the rubella vaccine is not up to the mark. So because there is no cure, we need to be very definite about prevention. Now, I wanted to say one thing. See, if the patient, if you've given a rubella vaccine to any lady, she should avoid pregnancy. We are talking about adolescents here, but in case she is more than 18 years and she can conceive, then, we should avoid pregnancy for only 1 month, not 3 months, Pushpa. It is 1 month only. And in case she conceives within that 1 month, recommendations are that you don't terminate the pregnancy. We only inform the makers of the vaccine that this patient has conceived so that they can follow up, because till up to date, they have never found any abnormality because of the vaccine. Okay?
Yes, madam.
Thing which I wanted to tell here. And yes, so they have to take 2 doses, not 1 dose. Remember that, adolescents. But when we are giving for our women preconceptionally, we usually manage with 1 dose. Okay, what about varicella vaccine?
Varicella, all the adolescents aged 7 to 18 years, they should receive 2 doses. The 4 weeks. If the child is more than 13 years of age, we can repeat the next dose within 4 weeks, madam. If she is less than 13 years, we have to wait for 12 weeks for the next dose.
Yes, the same thing here again, wait for 1 month in case she's more than 18 years and she's married to conceive. Now, what about hepatitis A? These 2 hepatitis A and hepatitis B vaccines are very much neglected. When we think of adolescents, why is it more important? Because they frequently visit restaurants and they eat outside home. So adolescents are very vulnerable to acquire HIV infection, and it should be given as a high priority. This is according to the Indian Pediatrics in 2021. We don't attend to this at all, I must say, very sadly. Then again, what about hepatitis B? Yes, again, it should be given. Why? Because they are more vulnerable to get hepatitis B infection through indulgence in sexual activities. So again, the CDC and WHO say that hepatitis B vaccination should be given to adolescents. And typhoid, of course, it is recommended through the adolescent period up to the age of 18 years, not beyond that. And we'll wait and see, because hardly we give typhoid vaccine to any of our people. I'm sure most of us would have had typhoid in some form or the other in our previous life. Anyway, so now these are about the recommendations by the, this is the ACPI, and it is very beautiful. This one, if we have this one sort of table in our clinic, then you know that you will never mix up or miss out on any of the vaccination schedules. Now we come to vaccination during pregnancy, a very important one. Dr. Rachna, why is vaccination in pregnancy important?
Yes, ma'am. Ma'am, our pregnant women are the most vulnerable population, and the immunity is not just same as when they're non-pregnant because of the change in the physiology, and hence they are at high risk for certain infections which are endemic in our country, especially tetanus, diphtheria, pertussis, and influenza. So we need, in order to overcome all this, our goal is we want to immunize both the mother and the fetus, and also indirectly the fetus is also the neonate is also immunized for the first 3 months of life, because the once the mother is immunized, she will be vertically transmitting antibodies to the baby also. So what happens? The newborn will take 6 weeks to get immunized. 6th week, 10th week, 14th week is when they get immunized to the same vaccines. Hence, till then it will have passive immunization with the antibodies from the mother. Hence, we have to immunize all the pregnant women, ma'am.
Yes, Rachna, very good. One more reason why we should immunize the mothers are because if they get any infection, it tends to become more severe. That is the reason why we need to see that all our women are vaccinated. And then we have these goals, not only protect the mother, like how you said, we've already finished this. Now,
and also routinely you have to give all the mothers, and if she travels to any other place which it is where there's an outbreak of infection, or if she comes in contact with the infected person, even then you have to vaccinate the mother.
Yeah, that's a pre-exposure prophylaxis. And of course, if there's an outbreak of infection, you have to protect our mothers. Okay. Now, ideally, we know very well that our women should be up to date with their vaccinations before they become pregnant. But again, all over the world, more than 50%, maybe more so in India, pregnancies are unplanned. So it is very important that whenever a woman comes to you, you should see that her vaccination status is up to date so that, you know, anytime she conceives, she shouldn't have any problem. Now, Dr. Rajapreeti, which are the vaccinations which are recommended in pregnancy?
Hepatitis A, hepatitis B, influenza, and DTaP can be given that between 27 and 36 weeks of gestation, and tetanus can be given. TT or DD, 2 doses. The first dose immediately after pregnancy, and second dose 4 weeks after interval. TDAP in the 1 dose in the 3rd trimester. Influenza 1 dose irrespective of gestation, ma'am.
Yeah, that is one thing, because we don't have many vaccines which should be given in pregnancy, very few. But let us go into detail about TD, TDAP, and influenza. Okay, fine. Now, what are the, Dr. Shanta? What are the Government of India recommendations for tetanus vaccination in pregnancy? The recommendations have changed.
Yeah, since 1998, the recommendations for tetanus toxoid to be replaced by TD vaccine, and till the supply of vaccine TT is there, we have to immunize them with TT. Otherwise, it is replaced by TD. So all pregnant women, once we know that they are pregnant, are given the first dose of TD, and the second dose is given within 6 to 8 weeks of the first dose. And if the women gets pregnant within 5 years of the first pregnancy, she is given the second booster dose of tetanus toxoid or TD.
Yeah, see the recommendations are, this is from the Ministry of Health and Family Welfare, Government of India. Now the recommendations are, in case, see, in the first pregnancy, like how you said, Ma, it should be the first visit and 2 to 4 weeks, 4 weeks later. Okay. And TDAP has to be given between 27 to 36 weeks. 36 continues in every pregnancy, regardless of whether it is 3 years, 5 years, or 10 years. In second and later pregnancies within 3 years, then she takes only 1 TD booster dose at 12 to 16 weeks. But if it is more than 3 years, then she goes through the same schedule as in a primary. That is 2 TDs and 1 TDAPs. Okay. Dr. Jyoti, what's your opinion of incidence of pertussis in India?
From in India, pertussis is endemic, ma'am, and it adolescents serve as an important reservoir for pertussis, and they are known to transmit the infection to most vulnerable population like pregnant women. So we need to vaccinate all adolescents at 11 to 12 years of age, madam. And this most severe in infants less than 6 months of age. They will present with atypical presentation and apnea, most common symptom, and whoop is absent. They often need hospitalization. There is no classical stages, and well-appearing infants begin to choke, and they will have gas with the flail extremities. Cough may not be prominent. So ACIP recommends that adolescents and adults who anticipate having close contact with an infant less than 12 months of age should receive a single dose of Tdap. And Tdap, we have to get the Tdap between 27 to 36 weeks of pregnancy, because it lowers the risk of whooping cough in babies younger than 2 months of old age by 78%, madam. And because first few months of life are when infants are at great risk of contracting pertussis. So recommendation is for pertussis vaccine for pregnant women is between 27 to 36 weeks by Tdap, and newborns are too young to be protected, as I told.
Yes.
So pertussis disease is highest between birth and 6 to 8 weeks of age. 76% of pertussis related death which occurs in less than 12 or 2 months of age, and most of pertussis continues to be underdiagnosed and underreported. So there is for one case of reported case of pertussis, there are 83 undiagnosed and undetected cases of pertussis are there, madam.
Thank you, dear. Now, why we have stressed on this is that most people say when we talk to neonatologists, they tell us that we don't see any pertussis. But the thing is that pertussis is atypical in neonates. Because it is atypical, it does not go as pertussis, and this is the way it presents. That's why you may not be able to detect it. Now, this is very important. Cocooning, it comes everywhere. All people who come in contact with newborns should be protected against pertussis themselves. And this means all members of the house, whether it's the grandmother, the mother, the aunt, the uncle, the cousin, elder brother, whatever. So this is cocooning is a very important aspect, because you can see here, this is the next one. Yeah, you can see here that sources of infant pertussis cases by contact category. This study has shown that mothers are the maximum sort of reservoir of infection, and they give it to the babies. So here we need to give Tdap to the mother. We are doing it. The father also, the sibling, grandparent, and of course other people who are in the servants or whoever else is there to look after the baby. So it's very important. This concept, we never think about it, and we don't really do much about it. So I think we need to act upon it from now on. So just a little bit about the Tdap vaccine to tell you about the global and the local bodies who are recommending Tdap, the ACOG, RCOG, WHO, FOXI, and the Indian Association of Pediatrics. All of them have the same thing to say. Between 27 to 36 weeks of every pregnancy, please give Tdap. In case you have forgotten to give, maybe the patient comes to you just in labor, then please do it, give it in the postpartum period when she's lactating, when it is perfectly safe. Now we come to influenza. We are worried about influenza. Why? Because the morbidity is more. It can cause preterm delivery. It can cause ARDS. Increased of ARDS is there. So again, about influenza vaccine, ACOG and CDC, they both recommend that we should give influenza vaccine during the season to all pregnant patients, especially those with comorbidities like diabetes, heart disease, asthma, and those who are HIV. Just one shot, any trimester, though we hesitate to give it in the first trimester, in every pregnancy is what is indicated. Now let us see, Dr. Pushpa, what are the first recommendations for influenza vaccination in pregnancy?
OGCON recommends to give the influenza vaccine at 26 weeks of pregnancy, but if there is a pandemic, we can give the vaccine at an earlier trimester itself.
Yes, very good.
We have to give the inactivated vaccine. It protects the pregnant women who are at high risk of ARDS, and also offer protection to the newborn who cannot be protected for next 6 months of life. So it offers protection to the newborn also.
Yes, dear. And they have shown that there's a 63% reduction in influenza illness among the infants up to 6 months in those mothers who received it. Now, a word about hepatitis B. What do we do when our patients come to us? We check all for HBsAg. And if it is negative, we are relieved. But do we act upon it? No, sadly we don't. Now, if it is negative, what should we do? We should counsel for hepatitis B vaccine during pregnancy, more so in the high-risk category. The hepatitis B vaccine is safe in all trimesters. It protects the mother and it provides passive immunoprophylaxis to the fetus. And of course, for babies born to hepatitis B positive mothers, we know what we need to do. So now, Rupa is not there. Who's going to take up this question? Now,
I'll take.
Yeah, please take it. Thank you. What are the indications for hepatitis B vaccine in pregnancy?
All pregnant women, if they are HBsAg negative, and if they are at risk of having infections, and those patients who have got a partner who is HBsAg positive, or if they are being evaluated for STD infections, and if there is recent infection, a history of infection or any drug abuse and all, or if they are having multiple sex partners, we have to immunize these people with hepatitis B vaccine, and it has to be given in all the trimesters if they are not immunized. And taking history is very important, but usually we don't get the history of their childhood immunization as well. Most of us, we don't take booster doses. I think most of us, we don't know our HBsAg titers, what it is. If we have a meniscus injury, actually we have to get ourselves immunized with all the 3 doses, and as well, and check our anti-HBsAg titers, and then see if it is more than 10, we are safe.
100.
As well, to tell the patients, most of us doctors are not immunized with HBsAg. This one, they don't have that titers in the body. So all the pregnant patients have to be immunized, and every 5 years, 1 booster dose.
Excellent.
And the child, if it is born to an HBsAg mother, we have to give immunoglobulin to the child. It is around 30 to 35 international units per kg body weight. And the next, the same dose of HBsAg vaccine has to be given at 0 and 1, 2 and 6 months of age.
Yeah, you should give it within 12 hours. That is what is important in the beginning. Okay. Very good.
We are running short of time.
Yeah, over. We are almost over.
Yes.
Now we're coming to pregnant lady comes with a history of dog bite. Is rabies vaccination safe in pregnancy, Rachana?
Yes, ma'am. Rabies vaccine is safe in pregnancy. Rabies is a dead-end disease. Whether the lady is pregnant or non-pregnant, you should give rabies vaccine. So what is the post-exposure prophylaxis? It depends upon the wound, ma'am. You have to first examine the wound. If it is just an abrasion or anything, you just give the active immunization, which the schedule being 0, 3, 7, 14 and 30. If there is even a little bit of blood at least is oozing, then you shouldn't wait. It is a actually any human dog bite cases should be considered as a medical emergency. You should give immunoglobulin, which is infiltrated locally. So human or equine vaccines are available. Now latest is monoclonal antibodies are available, which are less less reactions. And major institutions like in Bangalore, St. John's and Kim's Hospital, they have these vaccine. So you should give to, when you're immunizing actively, it should be given to deltoid and not the gluteus, because the immune response is very poor when you give it to the gluteus. So you have to give it to deltoid IM vaccination.
Earlier, thank you, dear. Earlier, we used to give it on the abdomen, but now
you're not.
Yes, only in the deltoid. Okay, Dr. Rajpreeti, I want you to answer quickly because we already got a reminder. Gravidae 2 at 37 weeks comes with a child with chicken pox. How do you manage her?
Actually, there is no place for varicella vaccine. This is a live vaccine, should not be given in pregnancy since the risk of pneumonia is high. So we can give varicella IgG immunoglobulin can be administered with when she is exposed 10 days after exposure. So, but it is not clear whether it protects the developing baby, ma'am.
Yeah, perfect. within 10 days of exposure, it will help, but not later than that. Okay. At nearer term, the problems of chickenpox are worse. So please remember, the obstetrician is the important link between the mother and a healthy baby. Now, there are certain vaccines which are contraindicated in pregnancy. Dr. Shanta, can you enumerate them?
Live virus vaccines are all contraindicated in pregnancy. Measles, mumps, and rubella can't be given. Varicella can't be given. We don't give BCG vaccination, yellow fever, polio virus vaccine. HPV vaccines are not given, and live influenza vaccines are not given. As well, the typhoid vaccines, and which are oral, as well as the herpes zoster vaccine is not given during pregnancy.
Thank you, Shanta. Now, all these vaccines which have not been given in pregnancy can be given during lactation. Everything can be given during lactation. Okay. In case they have missed out, like a catch-up vaccination, we should do it during lactation. Dr. Jyoti, can you just tell us quickly about vaccination in the elderly woman? Dr. Jyoti? Is she there?
I will take this question if she is not there.
I am there.
Okay. Come, Jyoti, quick. We have no time.
Tetanus booster dose should be given once in 10 years, madam, throughout the life. No booster dose is necessary in case of an injury or surgery within 5 years of vaccination. TD can also be given throughout life in place of tetanus toxoid. Unvaccinated adults of age 65 years or older can be vaccinated by Tdap, and influenza vaccination should be offered to all women. And it is a live attenuated vaccine. It can be recommended up to the 49 years of age once in a year. And HPV vaccine can be given up to the age of 45 years of age. And herpes zoster vaccine is indicated in the elderly women. These are all the vaccination: tetanus booster, influenza, and HPV herpes zoster.
Thank you, dear. When you're talking of tetanus booster, Tdap, remember cocooning, how you're going to protect the baby by immunizing the attendants. Now, GSK has announced the launch of Shingrix, and this is a vaccine which is a recombinant vaccine against shingles, that is herpes zoster and post-herpetic neuralgia. This was on 24th April 2023. Now, CDC says that adults more than 50 years and older should get 2 doses separated by 2 to 6 months. Now, you should get Shingrix, that is the shingles vaccine.
Sorry to interrupt, ma'am.
Yeah,
we are running short of time.
We have 2 more slides.
Yes, ma'am. Can you please
suggest? Yes, I would suggest one thing. Make your introductions short.
Sure, ma'am.
Whole slide, okay? When you
Okay,
we are over. This
Okay,
is the last slide. So when you get, you have to take shingle vaccine, even if you've had shingles in the past, or even if you have taken chickenpox vaccine, because both of them are the same virus. Right. Now, international travel, everything has to be taken. It will be there in your passport and your visa. So we don't need to go much about it. The only thing is we should give it at least 4 to 6 weeks before travel, so that they would start working and you're protected while you're traveling. Now, a word about COVID-19. Just 3-4 days back, the WHO Director General has said that COVID-19 no longer constitutes a public health emergency of international concern. So we don't know the status of COVID-19 vaccine. We know very well that vaccines are not available freely now, but whenever there is a person who is not vaccinated, I think it is better to advise them to get vaccinated. Okay, then yes. So the important thing is protect our women from vaccine preventable diseases. And thank you very much. I thank my experts for doing an excellent job. Thank you again.
Thank you very much, ma'am. It was a wonderful panel. I call upon Dr. Usha to comment about the panel. Dr. Usha, madam, are you there?
Yeah. It was a very nice panel. And I think most of the time we share the responsibility with our pediatrician. So we also have to be thorough, and we have to coordinate with them and find out to what level they vaccinate. And we should not forget our responsibility in vaccinating the young children, and especially the pregnant women. I think time to change to TD and the other one in the pregnancy. Thank you, madam. It was very good.
So much, and thank you, my panel. You did a very good job. Very good.
Thank you, ma'am.
Thank you, ma'am.
Thank you all the panelists and the moderator. It was really, really enlightening. We learned a lot of things from this. Now, our next speaker is Dr. Kalpana Balamurugan, who she'll be speaking on adolescent endometriosis. Sorry, madam, we had to make you wait because Madam Jyotika madam had some other commitments. Now I call upon the chairperson to introduce the speaker.
I'm happy to introduce Dr. Kalpana. She is the secretary of Mother Office and Gynec Society, and she's been the organizing secretary of MOX Silver Jubilee Conference. And we all know that she's the organizing secretary for the forthcoming Vice President Conference to be held in Kodaikanal in August. She has held various responsibilities in FOXI and TNFOG. We can see her as an active person in TNFOG. And she has delivered many lectures and organized many conferences. And she has 15 papers to her credit. And she has received many awards, including Best Doctor Award by MGR University. So over to Dr. Kalpana for her deliberation on adolescent endometriosis.
Kalpana madam. Come.
Because I couldn't hear you, there is some problem in the laptop. Radhika, can you hear me?
Yeah, I can hear you, ma'am.
Okay.
They're not seeing your slides, Doctor.
Yes, ma'am.
Slides are visible, madam, now.
Yes, ma'am.
I hope my screen is visible.
Yes, madam.
First of all, it's my privilege to be a part of this wonderful webinar organized by two great federations, Tamil Nadu Federation of OBGYN and Kasoga Karnataka Federation. I thank all the office bearers and respected seniors, President TNFOG, Revati ma'am, and Secretary General Sampath ma'am, who is also Vice President South Zone FOGSI, Vijayalakshmi ma'am, and also Kasoga office bearers, Vidyatopi ma'am, President Kasoga, and Secretary General of Kasoga, Rajeshri Palladi ma'am, and also Treasurer Suman ma'am for this wonderful opportunity. It is great that we got blessings from Madhuri Patel ma'am, Secretary General FOGSI, Cynthia Alexander ma'am, Senior Consultant from Tamil Nadu, and also Kasturi ma'am, who was the past Kasoga President. So the topic for discussion today is endometriosis, adolescent endometriosis. As we all know that endometriosis remains an enigma even now. The difference between adolescent endometriosis and adult endometriosis should be known by everyone, because the treatment plan and the presentation varies from adolescent girls to adult endometriosis patient. The symptoms are quite vague in adolescent endometriosis. There is a great delay in diagnosing adolescent endometriosis, and treatment plan also varies from patient to patient depending upon their symptoms. It is really difficult to diagnose adolescent endometriosis. Many a times it is asymptomatic, and it is almost the prognosis is similar to Mona Lisa's mysterious smile. So the innocent cannot be taken as asymptomatic endometriosis and really can't be ignored. So coming to the topic proper, endometriosis, we all know that it is presence of endometrial glands and stroma outside the cavity into the myometrium and also into the peritoneal cavity. So the prevalence is quite common in adolescent girls, starting from 25 to 70%. If an adolescent girl comes to us with chronic pelvic pain, if we put a scope, almost 50 to 70% of girls do have endometriotic spots in their pelvis. So coming to the proposed theories, we have a number of theories which can contribute to endometriosis. Even in premenarcheal girls, endometriosis had been documented, and it could be due to Mayer's metaplasia theory. And Sampson theory is also quite popular because it is quite common in patients with Mullerian duct anomalies, and the position of endometriosis is almost at the areas of spill. And we encounter many a times distant endometriotic spots like lungs and liver could be due to lymphovascular spread of this endometriotic implants. And the spill is quite common in almost all the patients, and out of that, only few patients develop endometriosis. Why should they? That could be an immunological factor also. Cell-mediated immunity is lowered in these patients, and NK cell activity is also decreased in these patients. So we know this is the common sites of endometriosis, and we need to classify the endometriosis stages to plan our treatment. In stage 1, it is mild, minimal isolated implants, and in stage 2, mild endometriosis, less than 5 centimeter endometriotic implants, and there's no adhesion in these patients. And moderate endometriosis, multiple implants with peritubal, peri-ovarian adhesions, and severe endometriosis with deep implants and severe adhesions. So the symptoms are quite vague in these patients. Sometimes the clinical presentation may be typical with dysmenorrhea and chronic pelvic pain in adolescent girls. Sometimes it may be very vague. Radiological diagnosis may be possible even in asymptomatic patients. Biomarkers are also coming into the picture. Many times these patients do have cyclical and also acyclical pain. But when we take a detailed history from these adolescent girls, there is a typical history of prolonged absenteeism from their academic activities and also in their social and sports activities. So sometimes these girls can have symptoms before menarche and after thelarche. So this is the presentation of adolescent girls with endometriosis. Many a times they present to us with acyclical and sometimes cyclical pain. Even they may present to us with GIT symptoms and urinary symptoms, which is quite vague, and many a times we don't think about the diagnosis of endometriosis. So there is a great delay in endometriosis diagnosis. Always tell your patient, adolescent girls, to maintain a diary of pain score, when it starts, how much is the pain, and when is the pain-free interval. And by the time the patient reaches you, she must have consulted various specialists, starting from pediatrician, urologist, and gastroenterologist, and gynecologist. So by the time it is diagnosed, it is almost 4 to 9 years. We should think about adolescent endometriosis, and we should identify these lesions at the earliest to protect the adolescent girls' fertility in the future. So we need to take a detailed history, the time and the severity, all those things, and always think about when you have adnexal mass and severe pain, think about torsion and Mullerian duct anomalies, and also think about endometriosis in these patients. Always examine the patient with to rule out all other causes like Mullerian duct anomalies and adnexal mass, torsion, and then think about endometriosis if nothing is positive for that patient. So many a times we need to treat the patient empirically. Sometimes imaging also helps us to come to a conclusion that the patient is a case of adolescent endometriosis. If there is a large cyst in the adnexa, definitely ultrasound will help us, especially trans-abdominal ultrasound in these girls will be definitely useful when we have typical adnexal endometriotic cyst. Sometimes serum markers may be useful in these patients. Various markers are available. Commonly used is CA125. Other markers are interleukin 6, 8, tumor necrosis factor, CA19-9, and as far as the markers are concerned, CA125 has got a sensitivity of 85% and CA125 specificity is 100%. Peritoneal fluid tumor necrosis factor can also be considered. There are newer markers, urocatin, polystatin can also be used. So even therapeutic trial is considered as a diagnostic marker in adolescent endometriosis. Recent HRA guideline also says that when you suspect endometriosis in adolescent girls, you need not always put a scope and confirm the endometriosis with its typical features or take a biopsy. Histopathological examination of adolescent endometriosis is not really needed in adolescent girls. If you have a suspicion of endometriosis in adolescent girls, go ahead with the therapeutic trial. Non-steroidal anti-inflammatory drugs and OCP can be given if the patient is relieved of her symptoms. Possibly it could be due to adolescent endometriosis, and the GnRH analog trial can also be given in these girls if she is more than 18 years, if the pain is relieved of, the patient is relieved of her symptoms, it can be due to endometriosis. So nothing wrong in going for empirical treatment as far as adolescent endometriosis is concerned. You need not go for confirmation, and we have various non-invasive diagnoses. Maybe in little stage 3 and 4 endometriosis, we can identify them very easily with 2D and 3D ultrasound. We can't miss that endometriotic cyst, which is a typical ground glass appearance with the hypoechogenic, hypoechoic mass with the hyperechoic rim that cannot be missed by any gynecologist. Trans-abdominal ultrasound is preferable in these patients. Sometimes transrectal ultrasound may be useful in these patients if a patient is having GIT symptoms, and if you suspect bowel involvement, you need to do transrectal ultrasound. You need to know how much bowel is involved and what is the distance from the anus, and if you want to operate, what is the mode of operation. We need to think about it, and the surgical treatment should be the last line of management. Let us not jump into the surgical management. Bladder and bowel involvement, sometimes we need CT and MRI. Color Doppler may be useful in if you have a suspicion of malignancy. You can go for Doppler study. It can rule out all other possibilities like malignancy and torsion. All these can be identified and ruled out, and ultimately you can come to a conclusion that the patient is suffering from endometriosis, and transrectal ultrasound has got its own sensitivity, and CT scan may be useful in a patient, especially bowel involvement, bladder involvement, and there is a distant site endometriosis, lung, scar endometriosis. In these patients, CT can be useful. MRI can also be done in selective patients if we cannot come to a conclusion about the diagnosis, and we need to rule out other possibilities and come to the confirmation that she is suffering from endometriosis. Coming to the management part, we need to think about suppression of pain. Naturally, she should be comfortable, and suppression of disease progression, because we all know that this is a progressive disease, and with progression, her future fertility is going to be hampered, and so we need to suppress the disease even if the patient is asymptomatic. And preservation of fertility is the main goal in adolescent girls. Coming to the treatment part, first line of management is non-steroidal anti-inflammatory drugs. The patient should be symptomatically comfortable, and hormone therapy should be given to suppress the disease and to protect her future fertility. And when we are thinking about combined oral contraceptive pills, it should be given continuously for years together, so that a pseudo pregnancy state is achieved and there is no menstruation, there is no progression of the disease, and the patient is also symptom free. And always when we are giving combined oral contraceptive pills, continuously tell her that she may get breakthrough bleeding. It is acceptable if she gets almost 4 breakthrough bleeding in a year. And we can think about progesterone also in these patients. Medroxyprogesterone 30 milligram can be given continuously. Always counsel the patient about the side effects associated with that, fluid retention and sometimes breakthrough bleeding and volume overload. Danazol, it is not recommended because of its anti-estrogenic effects. Now the GnRH analogs can be given in a patient who is more than 18 years, and definitely it is making the patient symptom free and also suppressing the lesion by suppressing FSH, LH level. The disadvantage with GnRH analogs is its side effects like a hypoestrogenic state and also its effect on bone mineral density. So it cannot be given for more than 6 months. And always remember that when you are giving GnRH analogs, add-back therapy should be given to reduce the bone loss. So it can be given a minimal dose of estradiol, 2.5 milligram, or even conjugated estrogen can be given in these patients in addition to calcium and vitamin D3. So if a patient is not symptom-free with medical management and she is presenting with acute symptoms, laparoscopy should be considered as a last resort. And always remember that first surgery should be the best surgery. There is a possibility of recurrence, and her future fertility should also be taken into mind when we are planning for laparoscopic procedures in adolescent girls. And one more differentiating feature from adult endometriosis, where we have typical powder burn appearance, but in adolescent endometriosis, the lesion may be clear, white, red, or sometimes Allen master windows, which can give us some clue about the early diagnosis of endometriosis. So we need to catch them at the earliest so that she is not progressing into severe disease and her fertility is not compromised. So always when you have gone for laparoscopy, try to treat all the lesion and also post-operatively treat the patient with long-term medical therapy or for almost 6 months to 1 year continuously, so that her recurrence rate is reduced and also her progression is also reduced. But sometimes when we have advanced disease, we can go for sandwich therapy, but before going for repeated surgery, always think about her fertility potential in the future, which is really important in addition to relieving her symptoms. So to conclude, coping with endometriosis, which is a chronic disease, is an important component of management. Empirical treatment includes non-steroidal anti-inflammatory drugs and hormonal therapy. Definitive diagnosis is by laparoscopy, minimally. Yeah. Yeah.
Hello.
1 minute, I'll finish.
Okay.
Minimally invasive surgical management is needed. Medical management is the choice for this patient. Alternative therapies can be considered, and psychological counseling can also be considered. So it is really needed for adolescent endometriosis to protect her future fertility. It is our responsibility to protect the girl's fertility in the future. And when the two federations had joined together, it is my humble appeal to nominate and vote for me as a committee chairperson of Infertility Committee. My FOGSI number, all the details had been displayed in this screen, and I've been associated with FOGSI committees for the past 10 years, and 6 years I'm into Infertility Committee. I'm the national coordinator of Infertility Committee, working hard for this point. It's my humble request to all our respected seniors and colleagues to nominate and vote to bring South to a reasonable position. Thank you.
Thank you, madam. That was a very insightful talk. Sujata, madam, can you give?
Ma'am, excuse me, ma'am.
Yes, madam.
Sorry to disturb, ma'am. Dr. Ramani Devi, ma'am, has an emergency, it seems. So she would like to present, ma'am.
Okay.
Sorry to interrupt.
Okay. Chairperson, would you like to tell something about the talk? Usha, madam, and madam?
It was a very excellent talk, Dr. Kalpana. So stressing on that it is a relatively common problem which is really underdiagnosed, and you have really stressed on how to diagnose it and manage it so that the future fertility potential is maintained. And also you have stressed that we should not be operating on every, and the surgery has to be used as a last resort. Thank you.
Thank you. Thank you. This session ends. I thank the chairpersons for chairing the session. Thank you. Our next session is by all the stalwarts, the Dr. Vidya Tobi madam, Dr. Sampath Kumari madam, and Dr. Ramani Devi madam. I call upon the chairpersons, Dr. Cynthia Alexander madam and Dr. Anjalakshi madam to chair this session. And Dr. Cynthia Alexander madam is the former director of IOG Chennai, superintendent of Government Hospital for Women and Children, former HOD of OBGY, Madras Medical College Chennai, awarded A.L. Mudaliar Traveling Fellowship Award, 1988, Lifetime Achievement Award, and Tamil Nadu MGR University Award, Lifetime Achievement Award from DIPSI. And Dr. Anjalakshi, she is the founder president of TNFOG, past president of OXY, past president of DIPSI, PhD in pregnancy diabetology. She is recipient of Best Doctor Award from IMA, retired professor OBG from Madras Medical College, presented number of papers in national and international conferences. She has done a lot of research work in GDM and Lifetime Achievement Award she has got. I call upon both the stalwarts to welcome our first speaker, Dr. Ramani Devi madam, to speak on genital tuberculosis and infertility.
Anjalachi ma'am, kindly introduce Ramani Devi madam.
Hello, good morning, Dr. Ramani.
Good morning, madam. Good morning.
Good morning.
Good morning, Ramani. It is, first of all, I want to congratulate, and I am very happy that the TNFOG is growing to such a great extent. And it is the untiring effect of Sampath Kumari, and who had, actually all Tamil Nadu OGCONs, we are all very happy. And we are very thankful to Sampath Kumari for taking this Tamil Nadu in the map of FOGSI. Okay, and with this, I first invite our first speaker, Dr. Ramani Devi, who is going to talk to us on the, what is the topic, ma? Genital tuberculosis and infertility.
Genital tuberculosis and infertility. Say, Dr. Ramani Devi is an excellent speaker. And she has done a lot of work in endometriosis and also in infertility. So she's going to talk to us on the tuberculosis and infertility. To introduce her, she is a National Vice President FOGSI 2020, International Advisory Board member of Fertility Society of Bangladesh, ICOG Governing Council member, and Managing Director, Ramakrishna Medical Center, Janani Fertility Center, Chairperson, Endometriosis Committee of FOGSI.
Stop that,
yes,
madam. We have
she's got lot of laurels to her credit. So I invite Dr. Ramani Devi, and she'll be coming up with a lot of new points. So let us all listen. Yes, Ramani.
Yes, madam, I am. So first of all, let me thank the organizers, TNFOG and KASOGA, especially Dr. Sampath, Dr. Revati Janagraman, and Dr. Vidya Dupi for giving me this opportunity to give a talk on this. I feel that's a very important topic, genital tuberculosis and infertility. So it was Charles Dickens who said that it is a dreaded disease in which life and death are so strongly blended that death takes the glow and hue of life and the life of gaunt and grisly form of death. So this was much earlier. And as you go through the history, it is called as the Rakshashamana, the king of the disease. And Johannes Lux showed in 1834, he coined the word tuberculosis. And then Robert Koch, he discovered the bacilli in 1882. But I think even centuries have passed, we are yet to conquer this disease. There are so many milestones. Margagni, he described genital tuberculosis in 1774. First case of tuberculous endometriosis was described in 1847 by Quish. Spencer Wales, he first operated a patient with the first loculated tuberculous abdomen. Heggar did the tuberculous self-injectomy in 1883. And Sutherland, he did the first endometrial biopsy to confirm tuberculosis in 1943, and Raymond discovered later tuberculous endometritis. The incidence of tuberculosis burden is quite large. And almost, if you look at India, the 1/4 of the global incidence of tuberculosis is in among the Indians. And 8.5% of the patients are likely to have HIV. They are likely to be HIV positive. Okay, then. It's a second common, genital tuberculosis is the second common extragenital tuberculosis, which has an incidence of 19%, and it has increased to 30% in 2015 from 19% according to ICMR. Then, if you look into the pathophysiology, the organisms we know are the Mycobacterium tuberculosis, which is acid fast due to resistant to surface lipids. And then pathophysiology, it can affect any age group, and especially the women between 20 to 45 years. And postmenopausal, it is quite rare because some of the etiology says that it can be sexually transmitted also. The primary infection occurs close to menarche and increases the chance of genital tuberculosis. And it can always be, almost always, the genital tuberculosis is secondary in nature. And if the bacilli are not eradicated, risk of reactivation, especially in conjunction with the disease, is likely to happen. So when you look at the genital organs, 100% involvement of fallopian tubes is there, followed by 50% in endometrium and ovaries 20%, 5% of cervix, vulva and vagina less than 1%. See, the types of tuberculous salpingitis are, because it happens 100% of the genital tuberculosis, we have the involvement of the tubes. It can be two types, exudative type, or it could be a productive type, which can cause extensive additions. But whereas in the exudative type, there is usually no additions, but only the tubes are found to have a lot of purulent material, caseous material with the earlier the hydrosalpinx followed by pyosalpinx occurs. And most these things are identified by laparoscopy. How the tubes are involved? It is from the submucosa, it spreads to the muscle layer and then to the outside, and it leads to perisalpingitis, and then fibrosis of the entire tube can happen. And tobacco pouch appearance is the commonest appearance, leading to pyosalpinx. And if it goes outside, that is, if it is an exudative type, it can lead into dense additions, that is, the tubo-ovarian mass can be the result. So then comes the endometrium in the tuberculosis. As I have said earlier, 50% of the genital tuberculosis, the endometrium is involved, and the tubercles are seen in the basal layer, and they are shed in each menstruation. Then reinfection occurs, and then ultimately the endometrium is totally burnt out, leading to Asherman's syndrome. And sometimes, very rarely, we can see the caseation or the sinuses. Then ovaries are also affected in 20% of the cases. It can be either periooperitis forming an addition, or it could be ooperitis where there is a total involvement of the ovaries leading into ovarian abscess can occur. So the tuberculosis of cervix is less than 5%, and it mimics usually the cancer of the cervix, and it has three forms. It could be ulcerative papillomatosis or miliary tuberculosis. Then types, tuberculous peritonitis. Ultimately, the entire pelvis is being affected. It can be a serous variety or a plastic variety.
Serous variety is more common where there is presence of ascites, signs of peritoneal inflammation, fever. There is systemic signs are there with the weight loss and anorexia. Here it might resemble malignancy, peritoneal metastasis, and here again the CA125 is increased in level. Plastic variety is less common, and it can happen. I mean, it can cause abdominal masses and doughy appearance. Then the external genitalia, as I have mentioned earlier, it could be in the labia or it could be in the vagina or elsewhere. So the TB of the pelvis, ultimately what it does is it can cause mesenteric nodes, pelvic lymphadenitis, ultimately frozen pelvis, and it might sometimes resemble grade 2, 3, and 4 pelvic endometriosis. The clinical features are mostly the patients, 20% of the patients have tuberculosis in the family history may be there, and 10 to 11% are asymptomatic. In symptomatic patients, there can be general symptoms suggestive of tuberculosis, infertility, or menstrual disturbances. When you look into the menstrual disturbances, initially there may be polymenorrhea or menorrhagia. Later, once when the endometrium gets burnt out, it can lead to amenorrhea. And of course, postcoital bleeding whenever there is cervical involvement or vaginal discharges. Then the signs are, it could be still normal in 50%. Abdominal examination can have a doughy feel, pelvic mass, adnexal mass, tenderness, ascites, vaginal discharges, etc. So infertility is very, very commonly associated with endometriosis and with tuberculosis. And in large studies, it shows around 40 to 50% of the infertile patients can have tuberculous endometritis. So it will present with typical features of tuberculosis of the pelvis, extragenital tuberculosis, and infertility occurs because of so many factors. It may involve the tubes, it may involve the endometrium, and then the ovaries, and ultimately it can cause infertility. And then these are all the general symptoms suggestive of tuberculosis, like fever, low-grade fever, night sweats, and chronic symptoms, and then weight loss can happen. So how do you diagnose? Mainly by the clinical suspicion, laboratory evidence, histopathology, imaging, and endoscopic evidence. And the general investigations, all of us know there is a basic CBC, ESR, X-ray chest, pelvic ultrasound, hysterosalpingography, endoscopy, and we have the recent microbiological test. Once upon we were relying upon the Manto, but now we have the quantiferon gold test, which is the ultimate. And then again, and AFB can be either seen in the microscopy or it could be cultured. And always you never forget to do a HIV testing for these patients with tuberculosis. Like how I said, there can be raised CA125 when there is a involvement of the peritoneal tubercle cavity. X-ray chest can show the old healed lesions or miliary pattern can be seen. And the role of diagnostic curettage, when you do the DNC on the first day of menstruation or by a Pippel's aspiration, you can see the histopathological examination can show the presence of granulomatous lesions or the multiloculated giant cells, Langhans cells, plasma cells, all those cells can be seen. So if it is positive in endometrium, that means the patient has got associated 100% tuberculous salpingitis. But if it is negative, it may not rule out the endometrial tuberculosis. So the culture is the gold standard. We have been using LJ media for a very long time. Then came the BACTEC test. The LJ media takes a very long time, that is 6 weeks. But whereas the BACTEC you can get the diagnosis by 3 weeks itself. And then they are smeared, and the Ziel-Nielsen's method of staining from the caseating material can have a direct study about the presence of this acid-fast bacilli. Negative smear, again, it does not rule out the genital tuberculosis. So now we are all more into the polymerase chain reaction, which is a molecular form of testing. And it is something like xeroxing the DNA. Amplification is done, and it can detect the less than 10 bacilli in a sample. We can get the result, and the results are very rapid. Within 1 to 2 days, you can get it. And in 3 hours, 1 million copies of DNA are obtained by this test, and this helps to study the genomic pattern of this. Again, So then there are chances for false positive PCR also, because it can pick up the dead bacillus and in the previous infection. So that means if the PCR, and then again, there may be false negative, that is paucibacillary nature of the specimen, and portion of the specimen taken for PCR would not have had any tuberculosis. That is an inappropriate sample. So we have if PCR is positive means you take it that the patient would have had an active lesion or in the past or currently the active lesion. So we have to have, there is a need for fine tuning the PCR test in India to reduce the false negativity as well as the false positivity. So quantiferon gold test is again a complementary test for PCR. It is interferon gamma release assay conducted on sensitized white cells after whole blood is incubated with the antigen, and it helps to monitor the treatment also. So in the histopathology, sensitivity and specificity is beyond 80. Smear, it is again high. And when you come to the culture plus the PCR, the sensitivity and specificity are the maximum, that is almost 100%. So how do you manage? Management is only by giving appropriate treatment based upon the histopathology, culture, smear, HSG and endoscopic thing. So usually it is a short course of chemotherapy. That is, we always use this rifampicin, pyrazinamide, and ethambutol and isoniazid. And this should be given 4-drug regime for 2 months and 2-drug regime of ethambutol and rifampicin along with isoniazid for 2 months. So the intermittent chemotherapy is less toxic but cheaper, but gives a higher, and you need to give a higher dose. And the best method is DOT. But in as far as the tuberculous pelvic genital tuberculosis is concerned, we have to give the entire 6 months. So these are all the ultrasound pictures. They can present with ascites, TO mass, and endometrium can have an irregularity. Always a thin endometrium with a calcification can be seen. And in HSD, there are a lot of informations we can get, but never do HSG when the patient has got active lesions. And these are all some of the changes: cottonwool appearance, tufted appearance, tobacco pouches, which is the commonest one, and then pipe stem appearance, and then beaded appearance and T-shaped uterus. Always think about this. Again, there can be filling defect, moth-eaten appearance, then sperm head appearance, and flash-shaped fallopian tubes can be seen. So in hysteroscopy is other one, which is the endoscopic method, which can confirm the diagnosis of endometrial tuberculosis. Invariably, the cervical canal is stenosed or ulcerated, and the endometrial cavity is pale looking, and tubercles can be seen. And when you see, sometimes it will be so thinned out, the myometrium, it can lead to easy perforation, and it can cause uterine synechia, poor distensibility, and then shrunken cavity and a T-shaped uterus. So these are all the tubercles, what you see in the hysteroscopy. And you can see the cobweb nature of you can see the carnuma here and cobweb nature in the hysteroscopy. Again, a sinus can be seen apart from the ostia. You can see the sinus, which are very classic. So this is a patient having tuberculosis with the Asherman syndrome. You can see a very narrow, small cavity, and the cavity has to be dilated with we can go for using scissors. Ideally, it is preferable to use the scissors so that there is no damage. Never use a cautery, and ultimately we can increase only the volume of the uterine cavity can be increased. But if the endometrium is burnt out, then the patient may not conceive spontaneously. They have to go for surrogacy. Maybe the oligomenorrhea can be corrected by doing some sort of bleeding, vaginal bleeding the patient can get. So ultimately the cavity is being enlarged with this. Then laparoscopic appearance is acute cases. It can be congestion, edema, then localized ascites thing, and then miliary tuberculosis. Chronically, you can get salpingitis, hydropio, and caseous thing, and then extensive additions. Mild, there will be hyperemia and tubercles. And then in moderate cases, dense bowel additions. Always when you see the bowel additions in a nullipara, think of only tuberculosis. Then severe cases, it could be TO mass, hydrosalpinx, and pyosalpinx. So this is a patient who has got this patient has got a very early lesions, tubercles you can see. So this particular patient, it was found to be absolutely normal But when you see the look into the hysteroscopy, the patient has got a tuberculosis. You can see the narrow cavity here and the hyperemic cavity in the same patient. So externally, see in this patient, you can very beautifully see the early tuberculosis lesion. So this is the parachute sign. So you can see the pelvis appears normal, but you can see the dense addition extending the upper, the upper abdomen is totally prevented. Again, it's a pale looking cavity. And then this is again a hyperemic small, you can see this irregularity and then sinuses here. Okay, so this particular patient again had a extensive addition of the, so you can see this here in this particular patient, the pelvis is totally occluded. So here again, you can see a lot of this caseating material is again here seen. Okay. Then this is again a patient with a snowman sign. That is, the caseating thing will appear and the dense additions when you are slowly releasing it. See, this is again a nulliparous patient. So you can see this in the fundus, you get the snowman sign. This is a caseation. And both the tubes are densely adherent and both are having hydrosulfings. So this particular patient, you need to release all the additions, remove the caseating material, and then remove the hydrosulfings also. See, when you look into the cavity, if the cavity is normal, probably the chances of conception is going to be high. So this is again a patient of tuberculosis where you can see the extensive perihepatic additions. In this perihepatic addition, the common cause is either chlamydia or a gonorrhea or even a tuberculosis lesion. See, even this is a patient where you can see the very early additions are seen. So the primary treatment, I think I have mentioned 4-drug regime followed by 2-drug. And then the second line management is you can go for an ethionamide, cyclosporin, kanamycin, capreomycin, viomycin. And then there are newer drugs like fluoroquines, that is ciprofloxacin, and anti-leprosy drugs like clofazimine can be used, and beta-lactam antibiotic can be used. But surgical, do you need to really treat the patient with surgical management? Surgical management has got a limited role. There is no place for tubal reconstructive surgery when you diagnose tuberculosis, because that is not going to be effective. Again, it is indicated only when there is persistent of the disease, persistent adnexal masses in spite of the anti-tuberculosis stress or healing fistula, or when there is resistant to multi-drug disease. And when you can go for a surgical management, like how I have shown some of the lab pictures. Chemotherapy should be always started prior and it should be continued. Then coming to the genital tuberculosis, actually the infertility here, as I said, it could be because of the endometrial factor, it could be because of the ovaries. In the endometrium, when there is Asherman syndrome, infertility is 100% likely to happen. In tuberculous oophorytis affects mainly the ovarian reserve. So in patients who are planned for ART, when the cavity is normal, when you go for an oocyte pickup, they need a very high dose for stimulation, longer stimulation, and also the oocyte quality is not good. And implantation rates are definitely affected because of the poor quality of the endometrium. And studies have shown that there is increased cytokine levels, tumor necrosis alpha, which reduces the implantation. So when the patient with tuberculosis treated patient conceive, the chances of conception are very, very low. Again, it is only less than 20%. And among that, the chances for ectopic pregnancy is very high. Miscarriages are also very high. And ultimately, only 5% of less than 5 to 10% of the patients with tuberculosis endometritis, they conceive. So probably gestational surrogacy is indicated, especially when the endometrium is totally spoiled. The chances for assisted reproduction to get implanted, that is very low, and hence these patients may go for a surrogacy. Even in spite of surrogacy, the success rate may be very much low. Again, has it got any role with the male infertility? Yes. Tuberculosis epidermidis, VAS changes can happen. and obstruction can happen to the sperm passage, and ejaculatory duct obstruction can happen. And all these things can again be diagnosed by transrectal ultrasonogram, FNAC, bacterial culture, PCR, and smear for AFB. So these male factors should be again treated with the similar to the 6 months regime, with the 4 drugs in the first 2 months and 3 drugs in the next. So with this, to conclude, tuberculosis happens very commonly. That is 40 to 50% of the infertile patients have tuberculosis, and it is it can be a very early lesion to a very severe lesion, leading to hydrosalpinx, biosalpinx, etc. And ultimately, it can cause Asherman syndrome. And treatment is medical management should be aimed, and surgical management has got a selected role, and the management of infertility is mainly, there is no role for tubal microsurgery. It has to be treated with ART, but still the success rate is going to be very poor. I thank the societies for giving me this opportunity to give a talk on this. Thank you.
Thank you, Dr. Ramani, for this excellent and elaborative illustrative talk. I have a doubt. What is the role of a gene expert in the diagnosis of tuberculosis?
Yes, madam. Now, of late, gene expert, they are giving lot of importance for diagnosis. I think
it's non-invasive also.
Non-invasive,
no,
yes. Non-invasive. Similar to this quantiferon gold test, they are doing it, gene expert. It can be done, but how far it can detect the genital tuberculosis, that is not known.
For genital tuberculosis only, they are telling you can just send the menstrual blood.
Menstrual blood,
in which they can see the gene expert. Okay. Okay.
I'm sorry, because
thank
of
you,
the
ma'am.
late time, we can go to the next speaker if you don't mind.
Yes.
Sorry, extremely. Okay. Cynthia ma'am. Cynthia ma'am.
One, my side, please, I request you to support, nominate and support Dr. Kalpana Balamurugan, who has been working untiringly for to contest for the chairperson.
Yes, yes, Ramani.
Yes. Madam, Dr. Ramani Devi, it was very exhaustive, your talk, and very clear, madam. I request you to support me also.
Definitely, Bharati, I couldn't see you. All the best for you also. In fact, for all the persons, they are contesting from the
definitely all persons from south will be supported.
We will be together.
Thank you, madam.
For Selva Priya, Bharati, Kalpana, and
Jairani.
Our next speaker is Dr. Vidya Tobbi. I request the chairpersons to introduce Madam. Madam is going to speak on chronic pelvic pain. Madam is our dear president of Kasoga.
Dr. Cynthia is there?
No, ma'am. Continue, ma'am.
Okay. So I will introduce. I have the pleasure of introducing Dr. Vidya Tobbi. She is a professor and head of the Department of Obstetrics Gynec, Alamin Medical College, Vijayapur. And she is also the Karnataka Society President 2023, Chairperson Food and Drugs Medical Surgical Equipment Committee, FOXY 2018 to 20, and Best Committee FOXY Award, Dr. Megru Dara Hansoti Award in 2020, ICOG Governing Council Member, FOXY Champion Award, National Corresponding Editor for Jogi, and Organizing Chairperson for Karnataka the conference, President Bijapur OB.
Thank you, madam. Thank you. Thank you, madam.
Many
madam.
credits and laurels.
Thank you.
To her
Thank you.
credits.
Thank you.
Okay.
Thank you, madam. Thank you
Dr.
for
Vidya,
those kind words. Thank
on
you, madam.
chronic pelvic pain.
Yes, I'm sharing my screen. Kindly allow me to share.
Okay.
I think my screen is seen.
It is seen, but go to the slideshow.
Slideshow, ma'am.
Yes.
Is it seen now?
No, the
No,
slideshow
ma'am.
is
Can you
not
please
there.
stop share and share once again, ma'am?
I don't know. It is not happening. Again, I have to share.
Yes, ma'am. You don't click on any PowerPoint, ma'am. Click on the screen and then share, ma'am.
Otherwise, Chitrakala, I have sent the PPT. You
No,
can
I
share
have,
it.
she has PPT, but as I go on talking, please change. Every time
Yeah,
I
you
should
just
not
say
tell
next,
that
ma'am.
change the slide,
You
change
can
the
say
slide. It keeps so much time is wasted. So
yeah,
I
next.
go
You
on
can just
speaking,
tell. We can
please,
change. Yeah.
please.
Ma'am, you can try
Change.
once again, otherwise I will share now.
Yeah. I have to click on what?
Screen, ma'am, screen.
I'm clicking on the, I have to open the this one, I think.
Yes, ma'am.
Yeah, please go to first
No,
slide,
it
ma'am.
is slideshow. You go, Vidya.
No, I'm going on first slide, but it is not sharing. I don't know what is happening.
On the top, now the fifth.
I think
click.
it is.
Okay. Yeah.
Yeah. We are sharing, ma'am.
Yes.
Correct.
But it is
Yes,
not,
yes.
it is going beyond the screen. So I'll not be able to, can you reduce the PowerPoint?
Ma'am, it is in the standard size only, ma'am.
Okay, I will talk and then you go on changing. I'll not be able to see it properly. Anyway, something is wrong with my laptop or something like that. At the outset, I think you people are able to hear me.
Yes, ma'am.
Yes, yes.
Yes.
And you can see the
Thank you,
slides.
Dr. Anjalakshi, for those
Mhm.
kind words. And it is really pleasure to be associated with Tamil Nadu Federation of Obstetrics and Gynecology. And I thank Dr. Revati, Dr. Sampath. I see my dear friends, Dr. Amala, also in the audience. So I thank all the Tamil Nadu people and Karnataka people. I'll be talking on chronic pelvic pain. So chronic pelvic pain is very difficult to manage, as all of us know. And it is a non-cyclic pain perceived to be in the pelvic area that has persisted for 3 to 6 months or longer, and it is unrelated to pregnancy. So this is what the definition says. And this can be constant pain or episodic pain, but it does not include the cyclic pain. It usually refers to the pain that is limited to the anatomic pelvis, that is around umbilicus and in the till the inguinal ligament. And remember that it is a symptom and not diagnosis which causes the functional disability. Next slide, please. So let us know about the physiology of pain, and this pelvic pain may be either from the visceral or parietal, or it can be a referred pain. And this pain may be either nociceptive or neuropathic. So these are the, we should know what is the physiology of pain. And this is a next slide, please. Then nerve supply of the pelvic organs. So pelvic organ nerves are autonomic nerve supply is from T10, 11, 12 and L1, and parasympathetic nerves is S2, S3 and 4. Somatic nerve is from the pudendal nerve, that is S2 and 3. So all pelvic viscera are supplied by the fibers from S2, 3 and 4. So why we should know about the nerve supply is sometimes we get the referred pain, and that's why we should know about the nerve supply. Assessment of pain intensity. When we talk of this assessment of pain intensity, that verbal pain intensity scale, we all know that is VAS, that is visual analog scale as well. So if you record this, we will know how much is the intensity of the pain. If you look at the pathophysiology, the central sensitization occurs when peripheral pain provokes an exaggerated response by the interneurons, which amplifies pain perception. So there is a central control of this pain as well. And it varies from person to person. Some people are, we say that they're very pain sensitive. So it all depends on genetics also. So everywhere the genetics plays a role. If you see the epidemiology, about 6 to 25% of the reproductive age group in our area or in India, or anywhere, if you see the gynec OPD, they come with this chronic pelvic pain. And it has got a potential various underlying cause, including sometimes identifiable or non-identifiable or functional pain syndromes. Next slide, please. I'm not. No, this slide is over. Next slide, please. No, next slide. Yes, I was talking about the common conditions associated with chronic pelvic pain. So there are visceral causes, gynecological causes, like we know about the dysmenorrhea, then we know about the various gastrointestinal causes, urological causes, neuromusculoskeletal causes. So in visceral gynecological causes, commonest causes endometriosis, adenomyosis, any chronic pelvic inflammatory diseases, and leiomyomas, ovarian remnant syndrome, pelvic adhesions, vestibulitis, and vulvodynia. So there are referred pains in these conditions. So mainly we will concentrate on these. Gastrointestinal causes, urological causes, and neuromusculoskeletal causes are the other causes of chronic pelvic pain. Next slide, please. As I end, please change the slide. So every time I need not say. So causes of chronic pelvic pain, these are the broad which we are going to talk today. Next slide, please. Yes, these I have already repeated. So please close this slide. Yeah. What about the principle of assessment? Frequently more than one component, and mainly the additional component is psychological. So always elicit woman's own theory for the origin of pain. So when it started, and also we have the history taking is very important. Consider the involvement of other specialties like anesthetics, gastroenterologist, urologist, psychologist, physiotherapist, and it has got always a multidisciplinary team approach whenever any case of chronic pelvic pain comes to you. Consider a trial of medical therapy always prior to any diagnostic laparoscopy, which we will be talking later. Next slide, please. So initial evaluation is, first is, it is very, very challenging, and you have to treat all possible causes of pain, and there may be more than one underlying etiology. Next slide, please. So overall, your approach should be review all available data. Second thing comes is clinical evaluation and counseling. And there are, you have to have the utilization of standardized questionnaires. Perform a physical examination, have something about the differential diagnosis. And second most important is assessment of the mental health of that woman. Then multiple symptoms sometimes the woman has, they can be bothersome, and you cannot go on writing all the different system evaluations simultaneously. She might be having 2-3 diseases simultaneously. So sometimes they are intermingled, and you cannot say that. There is no data supporting the specific order of symptom work. Next slide, please. Yes. So this is, I just want to give a stress on this. Whenever a case of chronic pelvic pain comes to you, then you have to thorough review of systems, obtain past medical and surgical history, focus on the past menstrual history, contraceptive use, past obstetrics and gynecological history, history suggestive of PID, that is pelvic inflammatory disease, endometriosis, any gastrointestinal symptoms, urinary symptoms, musculoskeletal some diseases, then psychiatric issues. So these are the 5 things mainly you have to take a detailed history. Characteristic of the pain is very important, whether any associated findings are there, any provocative and palliative factor is there, quality of pain, radiation of pain, and setting in which the pain occurs, temporal, at time at what pain occurs, and event that precedes and trigger the pain. These are very important. History taking, how is the pain? Then psychological history with particular focus on, you have to focus on substance abuse or use or abuse, including alcohol, and all things you have to take. Patient safety. Does the patient have any current and past history of physical, sexual, emotional abuse? Prior diagnostics test and pain treatment, and inquire about family history or relevance of clinical conditions such as chronic pain syndromes. Next slide, please. Yeah, so these are the focused clinical clues whenever you're taking history. If she is having crampy pain, you can have, and she has got GIT symptoms, it will point out to the irritable bowel syndrome. And any surgery or any infection, any adhesions might be there. So any postcoital bleeding, it can be a cervical cancer, then a secondary. So all these things you should take into account. Next slide, please. Yeah. So I just want you to go through this website, that is International Pelvic Pain Society. It is a 16 or 18 page some history. So this is a pelvic pain assessment form. You can download that. You can just take and you will find out the various causes to which it will point to. It is very wonderful one. You can just go to this site and take. This is pelvic pain assessment form. So you can just take it. It is very nice one, and you can come to conclusion of the causes of pain and how much we have to attribute to the chronic pelvic pain and its etiology. Next slide. Yeah. So this is about the physical examination, which is very vital. So general, we know that how is a vital sign, gait, posture, patient after sitting, the spine, whether it is a musculoskeletal, then abdominal palpation, any scars, any previous trauma, then any on palpation, any masses, then single digit deep palpation, differentiating a focal versus diffuse pain, trigger points. There are various tests also like Carnet test, and you have to see the extremities and hip flexion, extension. These will point out to any musculoskeletal problems which are causing chronic pelvic pain. So pelvic examination is also important. Give the patient lithotomy, see the external genitalia, any lesions, abrasions, ulcerations, then single digit vaginal examination for tenderness, spasticity, pelvic floor muscles, and any tenderness over there. Bimanual examination can detect the uterine size, mobility, any adnexal masses and tenderness. Rectovaginal examination is also important. The speculum examination will, you can see any infections, any ulcerations, erythema, and posterior vaginal fornix, cervical and vaginal cultures, if any purulent discharge is noted. Next slide, please. So this physical examination and history taking is very, very important. And just look at these life-threatening symptoms and signs. That is any bleeding per rectum, new bowel symptoms over 50, new pain after the menopause, pelvic masses, and especially look at any psychological problems like suicidal tendencies, weight loss, excessive weight loss, irregular vaginal bleeding over 40, and postcoital bleeding. So these are the red flag signs, and you have to immediately treat them. And they may come as a chronic pelvic pain. Next slide, please. So these are the various diagnostic tests you can undertake, like pelvic ultrasound, laparoscopy, hysteroscopy, MRI in few of the patients where the imaging is not detecting any abnormality. STI screen is also important, that is sexually transmitted infections can be detected. And in some of the patients, if no pathology is detected, you can just give a 6 months therapeutic medical trial. Next slide, please. So I have already covered, but some of the cases, laboratory testing is of very limited value. So baseline tests are obtained to screen chronic infectious or inflammatory process. So all patients, you do complete blood count, urine pregnancy test, and further laboratory testing is based on the clinical impression that emerges after complete history and physical examination. As Dr. Ramani was talking on the tuberculosis. So tuberculosis, salpingitis, secondary infections, TO masses, we have to do a battery of tests. Next slide, please. Then comes the treatment. So treatment, the principle is either expectant. In medical, we can give analgesia, then ovarian suppressions in some of the endometriotic cases, antispasmodic in bowel symptoms, and sometimes MRI and focused ultrasound therapy you can give. Any fibroids can be treated like that. And surgical, definitely, if there is a, this is a nutshell. So excision or ablation of endometriosis or adhesiolosis, myomectomy, hysterectomy can be taken. Psychological, it is a different issue, and we have to tackle it by proper counseling and proper management of any medical intervention is required. So often we have to combine the treatment. Next slide, please. So what is a probable etiology? So many patients, they come with this, and we have to find out the cause. So initial treatment of pain from the likely etiology is aimed at addressing the presumed cause. Multiple treatment can be used simultaneously, and we have to find out the symptoms and dysfunction. So there is no single approach to treat which can treat all women with chronic pelvic pain. Next slide, please. Yes. So is there any probable versus unidentified cause? Sometimes the cause we will not know, and if the cause is unclear, then there is no proper well-designed large volume trials which are available for appropriate longitudinal follow-up of these cases. So there is no protocol that start with this treatment. So one is, if the patient has got proper symptoms and the diagnosis, it is a tailor-made treatment. Otherwise, it is just a clinical experience. And what are the studies evaluating treatment for other types of chronic pain syndrome? Like that might be just a back pain or fibromyalgia. Next slide, please. Yes. So this is, we all know that you just put the laparoscope, and many times we advise when the patient comes for chronic pelvic pain, just do the laparoscopy, and we find the peritoneal endometriosis. Next slide, please. So I will not discuss the treatment of endometriosis, what it is we know. And always the patient has dysmenorrhea and dyspareunia. All D's are there, and then chronic pelvic pain. It can be a cyclical pain or non-cyclical pain, and patient comes with the subfertility. So these symptoms are poorly predictive for diagnosing endometriosis. The ISHRE guidelines, they say that only on pain management we can just go on assuming that the patient has endometriosis. But sometimes the endometriosis is very difficult only to detect from symptoms. The symptoms might be exaggerating, but if you put the laparoscope, the whatever the endometrial deposits, they might be very small. So next slide, please. Yeah, next slide, please. So these are the various treatments, strategies. We can stage. We have to treat the symptoms, the patient, how it presents, like infertility or pelvic pain. And we all know the treatment of mild, moderate, and severe endometriosis and pelvic pain. It is a medical management and surgical management. And it all depends on the patient's symptoms and how the patient presents. Next slide, please. Yeah. So the other cause of chronic pelvic pain is a pelvic inflammatory disease. And sometimes it is very difficult. Patient comes very late, and acute pelvic inflammatory disease can land up in chronic pelvic inflammatory disease. And sometimes with the treatment also, the patient will not have any benefit, medical management. Then we have to go for surgical management when the patient has such a badly detected adhesions and the formation of tumors. Next slide, please. Yes, these are the musculoskeletal disorders, and there are various trigger points which lead to fibromyalgia, myofascial pain, lumbar vertebral disorders, pelvic floor myalgia. And this can be due to sometimes faulty posture also. There is an exaggerated lumbar lordosis and thoracic kyphosis, and it can cause to up to 75% of chronic pelvic pain. So your posture and various problems of musculoskeletal disorders can lead to chronic pelvic pain. Next slide, please. Yeah. Gastrointestinal causes also, around 20 to 25% of the patients, they come with irritable bowel syndrome, chronic appendicitis, Crohn's disease, diverticulitis, diverticulosis, and Meckel's diverticulum. And these are the various causes we have to find out from the patient's history and bowel symptoms. Next slide. Yeah. So these are the Rome 2 criteria for irritable bowel syndrome. So at least 12 weeks of continuous and recurrent abdominal pain. 2 of the followings, that pain is relieved by defecation, change in frequency of stool, altered stool appearance, and associated symptoms like abdominal bloating, passage of mucus, and non-intestinal symptoms like lethargy, backache, and dyspareunia. So these one should remember when the patient comes to you with the bowel symptoms. And we have to treat them. Next slide, please. Yeah. So imaging, I have already discussed, so I will skip this slide. Yeah. Next slide, please. Yeah. So role of laparoscopy. So laparoscopy many times forms a major see and treat, isn't it? So diagnosis and treatment of endometriosis, adhesions, and we have to explain the surgical risk. Though they are small, but there is a risk of bleeding, infection, and visceral organ injury. So laparoscopy sometimes may be unnecessary, they say, but underutilization of laparoscopy can also result in the delay in diagnosis and appropriate treatment. And there is insufficient data to guide the optimal timing of laparoscopy. Some people say that you at the start only you do laparoscopy and then give the treatment. Some people say that you give medical management, then if the pain is not relieved, and then you do laparoscopy. So there are 2 schools of thoughts. Next slide, please. Yeah. So when to perform the additional surgical procedure, aim to reduce pain. So whenever there is a patient is refractory to the non-pharmacological or medical therapies, this potential procedure can be taken like pre-sacral neurectomy, lysis of adhesions, and sometimes hysterectomy. So role of these surgery for the treatment of chronic pelvic pain are very, very limited. And whenever we counsel women about the risk of continued pain and new post-surgical pain, means after surgery also she can continue with the pain with additional formation of adhesions and the complications, in addition to the standard surgical risk. This we want to warn. Next slide, please. Yeah, these are the general recommendations of the management of chronic pelvic pain. One is there is many times there is an unclear etiology, and there is no well-designed, no trials for appropriate longitudinal follow-up of the patients because pain is the end symptom of diverse etiologies. Next slide,
ma'am,
please.
sorry.
Yeah, over. I will just go on putting the slides. I will come to the end slide. Yes. You change the slide, I cannot change. Yes. So focused treatment of endometriosis, pelvic floor dysfunction, and individuals whose pain resolve require no further treatment. So it is a targeted treatment. Next slide, please. So unidentified cause or persistent pain, so we can treat them. Okay. So non-steroidal, these are the baseline treatment. That is a medical management. This is a medical management to start with. Next slide, please. Yeah, then targeted, I have already discussed that we have to do when the non-surgical and surgical treatment are targeted at the peripheral pain generators. Next slide. So non-surgical include the physical therapy, trigger point injections, and nerve blocks. Next slide. Surgical, we have already discussed about this, and the hysterectomy. Most of the chronic pelvic pain patient, they land up with the hysterectomy, but the hysterectomy can be reasonable treatment in some of the patients, but not elevate the pain. Remember this, studies have reported to continued pain symptoms in 5 to 38% of the women following hysterectomy. Next slide, please. Yeah, so these are the various risk factors. If the patient is very young, there is a lack of pelvic pathology, there is a depression and presence of pain elsewhere in the body. So the patient has continued pain. Next slide, please. Yeah. So these are the various intervention at the central level. So some of the drugs which act centrally. Like these are the neuromodulators. Next slide, please. So these are the common medications like tricyclic antidepressant, SNRIs, and these can be given in some of the patients where the central origin is detected. Next slide, please. Yeah. So these are the, as Madam was talking of, exercise, cognitive behavioral therapy. These are the other modalities for chronic pelvic pain. Next slide, please. and adjuvant therapy. So they have tried antipsychotics, but you should always avoid opioids because of risk of addiction. Next slide, please. So this is my last slide. So patient which present with chronic pelvic pain, there are unknown causes of pain and known disease process. So simple analgesia, non-steroidal anti-inflammatory drugs can be given. If there is inadequate relief, if there is a cyclic component to the pain, you can give hormone therapy. If it is inadequate relief, then you have to just find out whether there is a neuropathic pain and find out underlying any mood disorders. So you have to try for any antidepressant. And if it is, you can definitely know that she is psychologically depressed, you can just try for SSRIs. If it is a known process, then you have to treat according to the disease-specific guidelines, targeted therapy. Next slide, please. So chronic pelvic pain is difficult to diagnose, difficult to treat, and difficult to cure. So frustration for the patient as well as physician. So thank you very much. That is my last slide. Thank you for inviting me for this topic. I accepted this at very last moment. And I just studied, and I wanted some references actually. So those references I could not add here because of paucity of time. So thank you very much.
Thank you, Dr. Vidya. It was really a lucid talk, and it is really a challenge for the diagnosis and treatment of a chronic pelvic pain, which you have elaborated well. Thank you.
Thank you, madam.
Thank you, Vidya madam, for a very nice talk on a very difficult topic and making it very interesting. Our next speaker is Dr. Sampath Kumari madam, who is going to speak on diagnosis and management of adolescent PCOS. I request the chairperson to introduce Dr. Sampath Kumari, though she needs no introduction.
Ma'am, sorry, ma'am. Ma'am, sorry, ma'am. Shobha, ma'am. Patel sir is waiting. Patel sir is waiting. We'll directly go to Patel sir. Sampath ma'am will talk. Revati ma'am, kindly introduce.
Fine. We'll move on to the next keynote address. Though we are talking a lot about save the uterus, still the incidence of hysterectomy is rising. And what are the legal, ethical, social, and medical perspectives of the rising rates of hysterectomy? Here we have got the medico-legal expert, Dr. M.C. Patel, who is the Vice President, FOXI 2018, Honorary Member, State Supervisory Board, Gujarat State, and Organizing Chairperson, Vivekan OGCON 2013. And he is a great medico-legal expert for all OGCONs of India. And I welcome you, sir, to give the details about the various legal and ethical issues of increasing rate of hysterectomy. Over to you, sir.
Thank you, madam, for kind words. Let me allow to share my screen.
Yes, sir.
Is it seen?
Yes, sir.
Yes,
yeah,
fine.
Great.
So, greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank TNFOG and Kasoga and Dr. Sampath Kumari in particular for inviting me to share my views about the subject. Rising rates of hysterectomy, legal, ethical, social, and medical perspective. So it is a matter of directly concern to us, our medical fraternity, increasing rate of hysterectomy. Usually I start any of my talk with this question: is it worth discussing? Yes. And if it is yes, then why? So with this statistic and the slide, if we go, then 36% underwent hysterectomy below 40 years of age, and median age is 34 years, and 67.3% in private health sector and 32.3% in public health sector was the observation. So approximately 2/3 of hysterectomies were conducted in private hospital. All states and union territory followed the same pattern. But as far as public facility are concerned, they are much more preferable in state of northern eastern state, Himachal Pradesh, Odisha, Chandigarh, and Puducherry. In this Union Territory, they prefer to go to public facility for hysterectomy. So, and one more very interesting observation was a sizable proportion of women underwent sterilization at young ages, less than 25 years, in high hysterectomy prevalence state, say for Karnataka, Andhra Pradesh, and Telangana, where this study was also carried out, and it was found out that there was some relation with hysterectomy and female sterilization in early age before 25 years of age. Hysterectomy is one of the most frequently performed surgical procedure we all know during reproductive age in many countries worldwide after cesarean section. So cesarean section is number 1 surgery, and then after hysterectomy is number 2 surgery as far as OBGYN practice is concerned. But are they really or scientifically indicated is the question, and it is a matter for discussion for all of us. So unnecessary hysterectomy are being conducted among rural and poor women owing to the factors, because it was observed in that particular study. One, as fear instigated by medical professional. Many times patient comes with menstrual irregularity or so, she is told that it is likely that you may end up into cervical cancer or endometrial cancer, and patient is scared, and patient may go for decision of hysterectomy or so. Solution for menstrual problems and related taboos, and failure of appropriate gynecological care, and she is told that practical difficulties in living with reproductive health problems, and hysterectomy is the best treatment or ultimate solution, and patient is convinced many times in that direction. Inappropriate use of insurance. Many times if patient is having Mediclaim or so, or insurance with any company, it is also one reason found in one of the study that rate of hysterectomies are increased. Fading employment opportunity. And let us see, this is a real happen story in state of Maharashtra, in sugarcane field worker story. In some district of Maharashtra, female workers are not allowed in field during menstrual period, and female workers opt the option of hysterectomy as soon as they complete the family, irrespective of her age, because they do not want to be out of their labor during menstrual period also, as far as this cane field work are concerned. Because, and in that state of Maharashtra, study from Maharashtra revealed that problem is much deep-rooted, and hysterectomy have become a norm in a district where cane cutting contractors are unwilling to hire menstruating women, and leading to warmless villages. There are so many villages where almost all uterus are removed due to this ground only. An issue highlights the fact that women are compelled to earn and care for their families, hence they balance their medical options with social responsibility. So they sacrifice their uterus for their family need is the scenario in those districts of Maharashtra. But anyway, ahead, as far as this type of problems are concerned, there should be a counseling with sugarcane field owner or that contractor also. Can they be allowed their salary in those period of menstrual cycle if they are their regular worker? So if sugarcane field owner or that contractors are ready to encourage this, then almost all hysterectomy done for that ground can be minimized. Role of doctor is very crucial. We know whenever there is demand hysterectomy, we should discourage them. If at all it is indicated for some other medical reason, we can discuss with her, we can offer some other alternatives, but hysterectomy should be the only and only last resort to offer, and there should not be any on-demand hysterectomy. So proper counseling with patient and patient party, and of course with this type of a field owner is also very much needed. Can they be discouraged? Naturally, if we counsel them properly with all its disadvantage to go for hysterectomy early in their reproductive life, then they can be discouraged also. So here comes a role: ethical, moral, legal, and social issues. So these are the very vital issues, and we have to address them. As far as distribution of hysterectomy in India, state and district-wise, hysterectomy by state and region of India for women aged 15 to 49 years of age, prevalence of hysterectomy operation in India was nearby 3.2%, and in rural India, it was 3.4%, and in urban India, it is 2.7%. So it is also observed. It is much more prevalent in rural India. As far as zone-wise concerned, then South India 5%, East India 3.3%, West India 3.1%, Central India 2.4%, and North India is lower, that is 2.1%. So overall, the India prevalence hysterectomy rate is 3.2, but highest in Andhra Pradesh. It was found 8.9%, Telangana 7.7%, Bihar 5.4%, Gujarat 4.2%, Dadra and Nagar Haveli 3.6%, and lowest in Assam 0.9%, Lakshadweep 0.9%, Mizoram 1%, Delhi 1.1%, Meghalaya 1.1%. So rural India had higher prevalence as compared to urban India, was the finding or statistic in that study. Majority of women underwent operation in private hospital. It was one more observation. As far as operation carried out either in private sector or in public sector, hysterectomy prevalence range as far as this Telangana pictures is concerned, 3% to 5% in 126 districts, 5% and 7% in 47 districts, and more than 7% in 26 districts. It was the observation. So study from Andhra Pradesh highlights that nearly 60% of hysterectomy were conducted on women aged under 30. It is a matter of great concern. Under 30, hysterectomy was done. 95% of them were performed in a private hospital. And when this study was carried out, the discharge summaries of these operations were either incomplete or with no information of procedure and follow-up advice. So it was serious matter in study of Andhra Pradesh statistic. As far as this cause of hysterectomy is concerned, excessive menstrual bleeding was seen in 45.8%, fibroids or cysts in 17.6%, uterine disorders in 12.7%, uterine prolapse 7.6%, and other causes 16.2%, including cervical malignancy or endometrial carcinoma or so. Let us see this situation also we have many times faced in our practice. Mother comes with mentally retarded minor girl, and she is worried of her menstrual hygiene, and she is also worried of sexual assault when she becomes little major. So she doesn't want unwanted pregnancy because her child is with mental retardation. She has no sense about her menstrual hygiene as well as intercourse and its probable result. So they request for hysterectomy. So in this type of situation, we are in a tricky situation because on one ground, this is a very humanitarian thing because we know that she is totally mentally retarded, and request on part of relative or mother is very valid. But again, it comes a matter of discussion, whether it is ethical, it is moral, or on legal part or social issues. In few of the cases, in this type of situation, doctor denied for hysterectomy and parents went to Honorable High Court seeking writ petition for permission of hysterectomy in this type of situation. And Honorable High Court had a very strict question to the parents. If she were very normal, if she were earning a lot, would you have taken benefit of that? If yes, then you are under obligation to take care of her menstrual hygiene, even if she is mentally retarded, and you should be watchful not to end up into any kind of problem. And permission was not granted. But if at all you consider that this is a very serious matter as far as hysterectomy is concerned, then you can go, because before hysterectomy or after hysterectomy, in sample study it was also found that rate of psychological disorder was higher than would have been expected in a normal population. So in case of mentally retarded patient, if at all you consider to go for hysterectomy, naturally she is not mentally sound to give consent. So consent of guardian is to be taken. But in this situation, certificate from psychiatrist is very much required not to end up into any kind of litigation in future. So as far as this rising rate of hysterectomy is concerned, there were some recommendations on part of State Women's Commission panel, and they have gone with a few suggestions. There should be comprehensive survey of hysterectomy in states where rate of hysterectomy is too high. Public healthcare system should be strengthened to address women's health issues. Hysterectomy should not be the only answer in medical problems. They should offer other remedies also. So public health sector should be very strong as far as women health issues are concerned. Government may pass legislation to prevent unwarranted hysterectomy, and it should be strictly enforced. So government may pass legislation for the same. There should be strict punishment for carrying out unwarranted hysterectomy. Privatization of healthcare systems should be restricted. These were the suggestions on part of Women Commission panel. Women who go hysterectomy suffer from multiple health problems. Government should provide proper healthcare facilities and livelihood opportunity to this type of patient. So these were the suggestions on part of Women Commission. One more suggestion was it should be mandatory for private hospital to submit report to the district administration on day-to-day basis, and all the details should be available on all the district health center. Why hysterectomy was done in that very patient. So it should be given as a monthly report or in day-to-day basis as far as appropriate authority of respective district is concerned about report of hysterectomy done in the hospital. So all these matters, there are, of course, we know there are few suggestions which are not practical in medical practice also. But if this rising of hysterectomy is continued, then it may come, government may be compelled to go with legislation for the same. As we know, PCPNDT Act came. Why it came? Because it was gender imbalance. And in census of 1971, 81 and 91, it was found that ratio of 0 to 6 years of male to female children was deteriorating at a serious rate. And government was compelled by some NGOs to come with PCPNDT Act. And recently we observed ART Act, Surrogacy Act. So if at all there is demand on part of society, then government may compel to go for legislation to challenge unwarranted hysterectomy. So these are some social, ethical issues. As far as legal issues are concerned related to hysterectomy, because we know medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first. So we should be very careful for this. and you may end up into litigation. Common allegations related to hysterectomy surgery or so. Delayed in diagnosis, investigation or treatment, misdiagnosis, investigation or treatment, wrong diagnosis, unnecessary investigation, no proper consent, complication during hysterectomy. It could be remote or recent. Trauma, hemorrhage, injury to surrounding structure, possibility of infection, fistula in future. So these are some areas as far as hysterectomy is concerned. One may have to face litigation, morbidity, and for any reason, mortality. So these are the areas as far as legal consequences related to hysterectomy are concerned. So what to do and how to prevent all this thing? It was a very famous case of Samira Kohli versus Prabha Manchanda, which was decided in Supreme Court in 2008. And consent was discussed and decided what should be the ideal consent in Indian context. So consent is more than just sign here. It is not mere piece of paper where patient has or relative has to sign, but it is more than that. So during this case, it was decided and consent of Indian context was decided. So what is valid consent? I do not want to go into detail about consent. There are so many criteria for consent to be valid, but main criteria which we have to discuss for today's discussion, consent should be informed one. So in any surgery, are your patient properly informed? So same way, as far as case of hysterectomy is concerned, are your patient properly informed about hysterectomy with all its consequences, if it is done or if it is not done? So patient should have knowledge about nature of treatment with all its benefits and side effects. No fraud, no coercion, and no false promise. And patient should not be scared due to your counseling, and patient may compel to take decision for hysterectomy. Available alternatives should be explained to the patient. As far as patient comes to you for any complaint, she should have all the alternative available to her, and she can take decision for any alternative as far as treatment part is concerned. And if at all you are advising hysterectomy for valid reason, then also patient should be convinced and you should explain thoroughly and scientifically. As far as hysterectomy with salpingectomy is concerned, it has become routine almost in all of our centers that with hysterectomy, we go with bilateral salpingectomy, not to end up into ovarian malignancy in future. One more area, hysterectomy with salpingo-oophorectomy and hysterectomy with cystectomy. If we are going to go for hysterectomy and if there is a big ovarian cyst, then can we go with this hysterectomy with salpingectomy, hysterectomy with salpingo-oophorectomy, or hysterectomy with cystectomy? So can one remove ovary with hysterectomy? Because this is also a very important question. Many a times we have to face in court of law. Because removal of ovary could be accidental, could be incidental, or it could be planned. But if it is planned, then prior consent to go for oophorectomy is also very much important. If it is accidental, then you should be in a position to explain or justify that why it happened accidentally. And if it is incidental, then if prior consent is taken, then you are saved. Otherwise, it becomes very difficult in court of law to face this type of situation. So you can remove ovary if prior consent is taken. If prior consent is not taken, but if it is life-saving, then you can very well go with oophorectomy even if consent is not taken for the same. And if it is immediate danger to life of patient, say for example, if it is an injury to vessels supplying ovary and there is torrential bleeding, and if it is immediate necessary to save life of patient to remove ovary, then you can remove, because you can justify in court of law in this type of situation. But you should have all the facilities, and one should be experienced one to deal with the situation, and blood products should be ready in this type of situation. and prior consent is very much must. Because in this famous case of C. Jaipal Reddy versus Padmini Veluri, National Commission has very specifically mentioned that consent is not mere piece of paper where patient or relative has to sign. You have not to say that please sign here. But this paper is very important document of your counseling, of your communication. Whatever you have counseled to the patient, all the points should be entered in consent paper, and then patient or patient party has to sign. So it is a documentation of your communication. And once patient signs the consent paper, it becomes a documentation of your communication. So let me share this also. On FOXI website, FOXI uniform consents are available with 3 medical legal counselor, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad. We have prepared almost 30 different consent for, say, for example, cesarean section, for hysterectomy, abdominal, vaginal, endoscopy, and so on. And I am happy to announce in Kasoga, all those consent which are in English on FOXI website are translated in Kannada, and in last conference at Hubli, it was given to all the delegates who attended the conference. So it is very important consent. We have prepared with very hard work and with Maharashtra Law Society collaboration. So you can utilize those consent. So as far as consent is concerned, not to end up into any litigation, we have prepared those consent in 2 parts. Part 1 is information about surgery, say for example, hysterectomy. So we have explained name of procedure, that is hysterectomy, whether it is open or abdominal or laparoscopic. Or we have mentioned if you are going to go with salpingectomy, unilateral or bilateral, or ovarian removal, or any other ovarian cystectomy or so, we have to simply mention name of procedure. Meaning of procedure, what is the meaning of that procedure? We have written in a very simple language, purpose or indication. So you can only justify in court of law your decision of hysterectomy if proper indication is given in that consent. And you can justify only if these indications are given in your standard textbook. So in this type of situation, say for example, patient had been to you with bleeding disorders, and you have to go for hysterectomy, then you have to justify whether it is indicated in our standard textbook or in our standard guidelines by FOXI or ICOG or RCOG or so, or in any articles published in index journal. So if it is supported, then only decision of hysterectomy can be justified in court of law. Description of procedure, how hysterectomy will be done, we have mentioned. Benefit of procedure, if hysterectomy is done, which are the benefit to the patient? And if we are going to go for removal of ovaries, then effect of removal of ovary, effect of removal of cyst, effect of removal of tube. Benefit of procedure we have already mentioned. We are under obligation to explain all the alternatives to the patient. If at all we are going to go for advising hysterectomy, are other alternatives there to the patient available? And patient is a final authority to decide which alternative she decides to go for. You cannot compel her to go for hysterectomy. You can explain, but ultimate decision is on part of patient only. Consequences of refusal of procedure. Many a time patient may go for refusal to go for hysterectomy if at all you have advised. Then which are the consequences of refusal? You are under obligation to explain. Outline substantial risk, possibility of excessive bleeding or blood accumulation, possibility of infection, possibility of injury to surrounding structure, urinary bladder, ureter, bowel, blood vessels, possibility of complications of anesthesia. Every individual has a different way to cope up. We have mentioned in that also. Possibility of hernia formation, adhesions, or prolapse in future. We have mentioned everything in that consent. And very rare condition also we have mentioned. Part 2 is undertaking on part of patient. Whatever we have counseled in part 1, patient will go in undertaking in part 2, and at the end of consent, patient will sign or patient will go for thumb impression, whichever the case may be. But if it is thumb impression, then it should be well attested by person who knows that patient. But in this situation, that person should be major and should be mentally sound, and signature of doctor should also be there in consent form. So to conclude, rising hysterectomy is a matter of consent, and proper counseling to the patient is very much important, and counseling with the owner of this, say for example, sugarcane field. In this type of situation, when hysterectomy is rising due to this reason, on part of NGO or as a association, we can have a word with owner also. Discourage on-demand hysterectomy. If at all patient is with you for demand hysterectomy, we should discourage patient to go for hysterectomy when it is not medically or scientifically indicated. So your decision to go for hysterectomy should be very judicial, and you should be in a position to prove in court of law if at all you face any litigation. This gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. There are so many provisions in law in your favor as far as medical practice is concerned. But if you do not know, they will not be useful. So have some basic legal knowledge.
So, excuse me, sir. I am Priya here. Sorry, sir. 5 more minutes, sir. Extremely sorry, sir.
No, it is, I think he's...
Within 1 minute.
1 minute.
Have some basic legal knowledge. Always obtain medical legal advice whenever you are in doubt. So there is always a way. So if you want to sleep like this, take judicial decision in case of hysterectomy. Take tender care of your patient. Pray your Almighty God before going to sleep, and keep my visiting card below your pillow. So with regards, salute to both organizations, TNFOG and KASOGA, for inviting me to share my views about this very vital issue of rising hysterectomy. Thank you very much. Please do not assume. Please ask if any query, any question, if time and chairpersons permit. Thank you very much.
Thank you, Patel sir. Thank you very much, sir, for giving an exactly outline of what are all the reasons for increasing hysterectomy, where we have to focus, especially on private sector. And you have clearly explained the need to spread the message of save the uterus still more firmly to all GPs and MBBS doctors. And really, it is going to help us a lot. And actually, in my practice, hysterectomy status has come down to less than 50%. Actually, I am now a consultant to give second opinion for patients who have been advised hysterectomy.
So, rightly said by Dr. Revati Madam, because under Public Awareness Committee of FOXI, when Dr. Kalyan was chairperson, he has taken this task, save the uterus. And during COVID, he went with a webinar, and whenever physical meetings were possible, he has traveled across India with this mission of save uterus. And one video is also available, but due to paucity of time, I am not able to show that video. It was on part of FOXI, how to go for saving uterus in our day-to-day practice.
Thank you, sir. Dr. Vidya.
Thank you.
Yeah.
Thank you,
Thank you,
Patel
sir.
sir. With he has taken his time to come here. He was
Yes,
busy with some
thank you
other,
very much, sir.
Thank
Thank you
Welcome.
for eye-opener talk for
thank you.
everyone.
Thank you, sir. Thank you for this wonderful talk. Next, I call upon our next chairperson, Dr. Kasturi Donivant Madam and Dr. Vidya Prabhakaran. Madam Sampath Kumari, Madam, will you be speaking now?
No, we will take it later. No problem. We will go. We will proceed with that.
Okay.
So in this 1 minute, Shobha, in this opportunity, I invite all of you for our VP conference in Kodaikanal on August 10th, 11th, 12th, and 13th. So I expect everyone to be there. Thank you.
We are all there, Sampath.
Sure.
We are an organizing team only.
Yes, organizing team. Yes.
Kasturi madam, Dr. Vidya Prabhakaran.
Ma'am,
Are you there?
Yes, yeah,
madam.
Kasturi ma'am. Yes, all right.
Please
Shobna ma'am, Radhika ma'am will take over, madam, if you want.
Okay, okay. Thank you very much.
Radhika ma'am, please.
Thank you.
Shobha, you
Radhika
did excellent work. I congratulate you. Thank you very much for joining for all.
Radhika ma'am.
Thank you, madam.
Radhika ma'am. Okay.
Radhika, are you there? Yeah, no.
Revati ma'am, you can continue, ma'am. I'll call her. Revati ma'am, you can just introduce the chairperson. Kasturi
First,
ma'am.
Dr. Kasturi, Professor IOG Egmore, and she's a state level master trainer in EMOC and state level trainer in colposcopy. Next, Dr. Vidya Prabhakar from Salem, and she's assistant professor KMC Manipal from 1995 to 2000, recipient of Foxy Dhira Award, organizing chairperson of Foxy South Zone Conference. Her special interests are high risk pregnancy and infertility. Over to you, chairpersons, to introduce the speaker.
Thank you very much, Revati ma'am. I must initially thank both Kasova and our TNFOG team and Dr. Sampath Kumari ma'am, especially for giving me this opportunity. This is a very important session, and I'm very happy to see that there are, very contemporary and upcoming topics here in this conference today. Can I have the CV of the chairperson, CV of the speaker, please? Dr. Bhumika. Okay, I would like to welcome Dr. Bhumika Gunasingh. She has done MBBS from Government Vellore Medical College, MS Obstetrics and Gynecology from Sri Ramchandra Institute of Higher Education and Research, Registrar at Joseph Hospitals, Chennai, and her special areas of interest are high-risk obstetrics. And she's going to talk to us about B nodes. Welcome, Dr. Bhumika.
Thank you very much, ma'am, for that introduction.
Dear speakers, only 10 minutes capsules, please.
Please stick on to time. That's very important. Bhumika, you can start.
So we are going to talk about a very upcoming topic, B nodes. On the outset, I'd like to thank Sampath Kumari ma'am for giving me this opportunity because it was a very good learning point for me also. So what is this V nodes? So basically, we started off with open surgeries, then we switched over to laparoscopic surgeries, and now we have scarless V-node surgeries. So which is nothing but vaginal natural orifice transluminal endoscopic surgery, where we proceed with the surgery through the vagina and it is completely scarless. So basically, this V-node surgery can be used to address various adnexal pathologies. And various surgeries which are done are hysterectomy, salpingectomy, oophorectomy, salpingo-oophorectomy, cystectomy, and sterilization. So in the following slides, we'll have an idea of how this procedure is exactly gone about. So basically, the components of this V-node surgery includes this Alexis retractor, which is used for retraction of the vagina, and this specific thing called gel point V-path transvaginal access platform. So through this platform, only the V-node surgery are done. So the other instruments are similar to our lab instruments. That is, we have a camera and we have all operating instruments as in our laparoscopic surgeries. So basically, this is an animation video which will give us an idea of how V-node surgery is done. So this particular surgery is for hysterectomy. So basically, the vaginal wall is retracted and we go about with an incision, that is posteriorly the pouch of Douglas and anteriorly the utrovesical fold is dissected, and after which the Alexis retractor is introduced. So this Alexis retractor will give adequate retraction of the vaginal wall. And after the Alexis retraction is introduced, we have to make sure that there is no tissue which is present between the retractor and the vaginal wall. So we are making sure that there are no tissues. And then we are introducing the gel point platform. So after which, similar to laparoscopy, we have an insufflator, and then we have our lap instruments and we proceed with whatever surgery is required. In this video, we have, they are showing us how hysterectomy is proceeded by. And after which hysterectomy is done, they remove the gel point platform and the uterus is also removed. The Alexis retractor is removed, and then we use absorbable sutures for closure of the vault. So the basic advantages of using a V-node surgery when compared to a vaginal surgery is that the ureters are easily identified and you can explore the abdomen also, and large uteri and difficult to remove adnexa can be proceeded in V-node surgery. And when compared to laparoscopic surgery, they say that the post-operative pain and the need for analgesics is less, and the ergonomics is better for surgeon and better cosmesis definitely, because we are not giving a scar, despite a lap scar being a very small one, and even fewer post-operative complications. So this research paper was published in VJOG, which compared V-nodes with that of laparoscopy, and it concluded by saying that V-node surgery has a shorter hospital stay, a faster recovery time, and less pain medication was used when compared to endoscopic surgery, less post-operative pain, and the duration of surgery was also less. So, and ACOG, and that is American College of Obstetricians and Gynecologists and the American Association of Gynecological Laparoscopists recommend for V-node surgery whenever it is applicable, and it is done only for benign conditions as of now. So that is my presentation. Thank you very much.
Thank you, Dr. Bhumika, for a short and crisp presentation on V-nodes, which is going to be a safe and alternative procedure in the near future. I think we'll move on to the next topic. That is the current concepts in hirsutism by Dr. Sadhana Devi. She is a senior consultant at Dilroth Hospital and Medway Hospital. She is a member of OGCON and IFS. Her areas of interest in ART and high-risk obstetrics. Over to you, Dr. Sadhana Devi.
Please unmute yourself, ma'am. You're mute.
Good afternoon, everybody.
Move to your first slide.
Good morning, everybody. I would like to thank TNFOG for giving me this opportunity to talk about hirsutism recent updates. So definition, excessive terminal hair that appears in a male pattern in women. So about the pathogenesis, this is because of growth of sexual hair is entirely dependent on the presence of androgens. So androgens induces the vellus follicles in sex-specific areas to develop into terminal hairs, which are large and they are more heavily pigmented. So hair grows in non-synchronous cycles. That is, the growth anagen phase is approximately 4 months for facial hair. Due to long hair growth cycle, it takes approximately 6 months to detect the effects of hormonal therapy and approximately 9 months for these effects to be maximum. So here the androgens act on the androgen receptors and they convert the vellus follicle into the terminal follicle. So the sensitivity of the hair follicle is determined by the androgens, particularly the testosterone, which is converted to DHT by the enzyme 5-alpha reductase. So the hirsutism score do not correlate well with the androgen levels because the androgen-dependent follicular response to androgen varies considerably. So coming to the etiology, so hirsutism majority is because of androgen excess, more than 80%. And these women, 70 to 80%, have PCOS. So this is a gonadotrophin-dependent functional ovarian hyperandrogenism is a source in case of PCOS. In idiopathic hirsutism, women have hirsutism without hyperandrogenemia. They are eumenoric women with no clinical evidence of PCOS. The non-classic type of CAH is present in 4.2% of hyperandrogenic women. So clinicians must also consider other diagnoses like Cushing's, acromegaly, hyperprolactinemia, and hypothyroidism in the differential diagnosis.
Sadhana.
Yes, ma'am.
So, this slide show poda. நீயே இதுல பிரசன்டேஷன்ல போட்டுருக்க கீழே அந்த கப்பு மாதிரி இருக்கு பாரு அதை ஆன் பண்ண
யோகேஷ் ஸ்லைட் ஷோ
அந்த மார்க் பக்கத்துல ஒன்னு கப்பு மாதிரி இருக்குல்ல அதை கிளிக் பண்ணினா போயிடும் கீழமா டவுன்ல எங்கே போயிட்டியே
வெளியில வந்துட்டேன்
என்னடா பண்ற Is it okay, madam?
Hey,
no, you have stopped screen share only. You have to share the screen again.
Screen பண்ணு ஷேர் பண்ணு திரும்ப இல்லனா அதுலயே அப்படியே பேசு வரலனா
screen share பண்ணு
உனக்கு அவன் பண்ணி தரான் அவனை திட்ட வேற திட்ற நீ என்னடா பண்றேன்ட்டு
yes okay
okay fine இல்ல நினைக்கிறேன் சரி நீ ப்ரோசீட்
Go ahead with this. Go ahead.
பரவாயில்ல அப்படியே போய்
move on next slide
yes
Sadhana ma'am you are in a mute
yes ma'am yokesh இது எப்படி போறது
ma'am slide la already click on it yes ma'am
So we talked about the non-classic forms of congenital adrenal hyperplasia, which is present in 4.2%. So the other differential diagnosis to be considered would include Cushing's, acromegaly, hypothyroidism, and rarely hyperprolactinemia. So we need to consider also topical androgen use by the partner or anabolic steroids or valproic acid when evaluating. So for the diagnosis, the modified Ferryman-Galway scoring is the gold standard for evaluating hirsutism. So 9 body parts that are most sensitive to androgens are assigned and a score from 0 to 4 is assigned. 0 is for no hair and 4 is for frankly virile. So these scores are then summed up to produce hormonal hirsutism score. So this FGS diagnosis depends upon the ethnicity. So the recent guideline says US and UK black or white women, a score more than 8 is diagnostic of hirsutism. On the other hand, South American women and Asian women, a score more than 6 diagnosis hirsutism. For Mediterranean and Middle East women, a score more than 9 to 10 is diagnosis of hirsutism. When the woman is diagnosed of hirsutism, we need to measure the total testosterone levels in all women with abnormal hirsutism score. So the level of evidence is 2. On the other hand, when the serum testosterone levels are normal, but if the woman presents with sexual hair which is moderate or severe, or if the sexual hair growth is mild, but there's clinical evidence like menstrual disturbances or progression, then measuring early morning total and free testosterone is suggested. In eumenoric women with unwanted local hair growth, that is in the absence of abnormal score, testing is not suggested. Further evaluation includes measuring DHEAs to screen for adrenal hyperandrogenism, further workup to identify the origin of androgen excess due to atypical clinical findings may include serum androstenedione levels, assessing the response to co-centropin of 17-hydroxyprogesterone, DHEAs, 17-hydroxypregnenolone, and 11-deoxycortisol to exclude rare forms of CAH, adrenal CT, and ovarian ultrasound to suspect androgen-secreting tumors. And of course, a transvaginal ultrasound for ovarian hyperthecosis. So this is a chart showing how to evaluate a woman with abnormal hirsutism. Any women with abnormal hirsutism score as determined by the Ferryman-Galway score or local sexual hair growth with clinical evidence of hyperandrogenic endocrine disorder, the first to be tested is a total testosterone blood levels. If the testosterone levels are normal and the hirsutism is mild and isolated, a trial of dermatologic or oral contraceptive therapy can be adhered to. On the other hand, if the hirsutism is moderate or severe or there is clinical evidence of hyperandrogenic endocrine disorder, consider free testosterone blood levels, which can be calculated from the total testosterone or by the sex hormone binding globulin levels, or it can be by the equilibrium dialysis. If the free testosterone levels are elevated, then hyperandrogenemia is diagnosed and androgen excess workup should be constituted. So the major hyperandrogenic endocrine disorders to be considered are PCOS, non-classical forms of congenital adrenal hyperplasia, Cushing's, virilizing tumors, and hyperprolactinemia. Any women, a menstrual history, symptoms of hyperandrogenism stigma, family history should be evaluated. So during evaluation, height, weight, BMI, skin examination, which includes hirsutism, acne, acanthosis, skin tags, everything should be taken into account. So for women with regular menses, additional laboratory testing would be done, as we said, total testosterone levels. In idiopathic hirsutism, if the levels are going to be normal, dietary modifications would be the best option. On the other hand, if the 17-hydroxyprogesterone is more than 200 nanograms, a diagnosis of non-classic congenital adrenal hyperplasia should be considered. If testosterone is more than 200 nanograms per deciliter, ovarian tumors should be considered. On the other hand, DHEA is more than 700 micrograms, adrenal tumors. So the diagnosis of PCOS can be with Rotterdam criteria. So the pharmacological therapy, coming to the pharmacological therapies, combined oral contraceptive pills form the initial therapy for treating patient-important hirsutism. So what is patient-important hirsutism? Any women with unwanted sexual hair growth of any degree that causes distress for the women to seek additional treatment is labeled as patient-important hirsutism. So these are the new recommendations. Anti-androgens is not suggested as initial therapy. All oral contraceptives appear to be equally effective and the risk of side effects is low. Any women who have high risk of venous thromboembolism, like obese women when the BMI is more than 35 and over 39 years of age, ethinyl estradiol low dose 20 micrograms and a low risk progestin can be considered. If patient-important hirsutism remains despite 6 months of monotherapy, addition of anti-androgens has been suggested. Flutamide is not recommended due to its potential hepatotoxicity. In all patients, a trial of 6 months is suggested before changing the dose, switching to a new medication or adding a medication. If sufficient improvement has not occurred, combination with an oral contraceptive pill and anti-androgen has been suggested. So the level of evidence is 2. So this is a slide showing oral contraceptives and associated venous thromboembolism risk. So LNG, though the androgenicity is high, the relative risk of venous thromboembolism is low. On the other hand, desogestrel, androgenicity is very low, but the relative risk for venous thromboembolism is high. So we already saw these progestins are usually 17 testosterone derivatives. They have varying degrees of androgenicity. To quote, LNG has high androgenicity and desogestrel has low androgenicity. So a 12-month trial comparing OC pills containing either 3 mg drospirenone or 2 mg cyproterone acetate showed similar reduction in hirsutism score. Similarly, systematic reviews compared OC pills containing anti-androgenic progestins, cyproterone acetate and drospirenone versus all other OC pills and the relatively androgenic progestin LNG versus all other OC pills. So the results showed amazingly LNG had a similar effect on hirsutism scores compared to other drugs. The potential benefit of OC pills containing LNG is lowered venous thromboembolism risks. So coming to a short slide on anti-androgens, CPA, cyproterone acetate, 50 to 100 milligrams per day on menstrual cycles 5 to 15 can be combined with ethinyl estradiol 20 to 35 micrograms from day 5 to 25. So spironolactone 100 to 200 milligrams per day can be divided in 2 divided doses can be administered. Finasteride 2.5 to 5 milligrams per day can be given. Flutamide on the other hand, both low dose and high dose should be avoided because of the risk of hepatotoxicity. So hair follicle treatment, hair removal therapy, photoepilation is considered if unwanted hair is brown. So for photoepilation, ND, YAG or diode laser could be delivered with appropriate skin cooling. Electrolysis is suggested if the unwanted hair is white or blonde. So for women who desire rapid response to photoepilation, can add eflornithine topical cream may be suggested. So the take-home message for diagnosis of hirsutism and for treatment of hirsutism. So for diagnosis, so the first thing would be for any women with an abnormal score, the serum testosterone, total testosterone levels should be tested. If the total testosterone levels are normal, but the sexual hair growth is moderate or severe, or the sexual hair growth is mild with clinical evidence of hyperandrogenic endocrine disorder, early morning total and free testosterone levels should be considered. For eumenoric women with unwanted local hair growth or normal hirsutism score, testing is not suggested. For screening for hyperandrogenic women for non-classic types of congenital adrenal hyperplasia, early morning 17-hydroxyprogesterone levels in the follicular phase should be considered. And for treatment of hirsutism, most importantly, for the patient-important hirsutism, we need to start pharmacological therapy with combined oral contraceptive pills, most probably LNG, and add direct hair removal methods. For women with mild hirsutism and no evidence of endocrine disorders, either one of the approach is suggested. For hirsute women with obesity, including PCOS, lifestyle changes are strongly recommended. Thank you.
Thank you very much, Dr. Sadhana Devi. That was an absolutely clear, crisp, and comprehensive presentation. You nailed it. Thank you very much. Any questions can be viewed on the chat box. Can we have the next CV of the next speaker, please? Okay, I'm very happy to introduce Dr. Shravani Chitra. She's an MBBS from Chettinad Hospital and Research Institute, completed master's degree from Annamalai University, and then she has also done a fellowship in reproductive medicine and fellowship in minimal access surgery, written a chapter in mastering the techniques in hysteroscopy by Osama Shaki. Okay, she's got a lot of laurels to her credit. I'm very happy to welcome you, Dr. Shravani. The stage is yours.
Thank you, ma'am. I'll just share my screen. I'd like to thank everyone for giving me this opportunity. So my topic for discussion today is ART Regulation Bill 2021. The bill mainly aims at...
Ma'am, sorry to interrupt. Can you please stop share and share again because your slides are not moving?
Okay.
Please click on the screen and then share, ma'am.
Now is it okay?
You can go to slideshow mode.
Slideshow mode is not seen, ma'am.
Yeah.
Just a minute. Yeah, now is it moving?
No, ma'am.
It's not.
Ma'am, you're clicking the PowerPoint, ma'am. Please click on the screen and then share, ma'am.
Blue.
Share screen, then click on the screen and then share, ma'am. Don't click on the PowerPoint.
Ma'am, you can continue, ma'am, please. No problem. You can continue. Yeah. Some problem. Please.
Okay, ma'am. So the bill mainly aims at regulation and supervision of ART clinics and ART banks, prevention of misuse, ensuring safe and ethical practice of ART services, and regulation and supervision of research and development. So the ART regulation bill was passed by the Lok Sabha in December, on 1st December 2021, and Rajya Sabha on December 8, 2021. The bill basically has 6 chapters. The first chapter includes the preliminaries and the definitions, where the bill has defined ART as a technique that attempts to obtain a pregnancy by handling the sperm or oocyte outside the human body and transferring the gamete or embryo into the reproductive system of a woman. ART Bank is defined as an organization responsible for collection and storage of the gametes and embryos and supply of gametes to ART clinics or their patients. An ART clinic is defined as any premises equipped with requisite facilities and medical practitioners registered with the NMC for carrying out procedures related to ART. And a commissioning couple is an infertile married couple who approach an ART clinic or ART bank for obtaining its authorized services. An embryo is defined as a developing or a developed organism after fertilization until 56 days. And a gamete donor is the person who provides sperms or oocytes with the objective of enabling an infertile couple or woman to have a child. And infertility is the inability to conceive after 1 year of unprotected coitus or other proven medical conditions preventing the couple from conception. So chapter 2 includes the authorities that, who are in charge of regulating the ART. It involves both the national and the state authorities. So the national authorities include the National ART and Surrogacy Board, the National ART and Surrogacy Registry, and the appropriate associated appropriate ART and Surrogacy authorities. And in the state, it includes the State ART and Surrogacy Board and state appropriate ART and Surrogacy authorities. Usually the central board is in charge of the entire process. The central board helps in maintaining the code of conduct of every clinic and bank, and their infrastructure, the manpower, equipment, and of the ART clinics and the banks. So the ART clinic and banks will provide all the details to the National Registry. So the National Registry will keep the details of all the clinics of the country, the nature and types of services provided by them, the outcome of services, and the other relevant information. And all this information is stored at the central database, which is then provided to the central board to help them make any policies or research in ART. And the central board always helps in performs and supervises the bodies like the state board, the National Registry, appropriate authority, and surrogacy board. And overall, it helps in reviewing and monitoring the implementation of the Act, and also helps in advising new policies and recommending changes to the central government. So the appropriate authority is the immediate regulatory authority who will deal with the ART clinics. Usually the central government and the state government within 90 days of application will appoint the ART authority and surrogacy authority in the union territory or the whole of the part of the state. So once the appropriate authority will consist of a chairperson who is a joint secretary of the Health and Family Welfare Department, a vice chairperson who is the joint director of the Health and Family Welfare Department, and includes 3 members, an eminent woman who represents the women's organization, officer of law department of state or the union territory, not below the rank of deputy secretary, and an eminent registered medical practitioner. So the authority, the functions are to grant, suspend, or cancel the registration of a clinic or bank and maintain details, to enforce the standards, supervise the implementation of provisions of this Act, to investigate and take actions of complaints of breach of the provisions of this Act and initiate independent investigations, and also to recommend to the National Board and State Board about the modifications required in the rules and regulations. So the Chapter 3 includes the procedures for registration of an ART clinic. As of now, no ART procedure should be performed without registration. So every ART clinic and ART bank must be registered under the National Registry, formed under the ART rules through appropriate authority. So the clinic and banks will only be registered if they adhere to the certain standards, including the manpower, infrastructure, and diagnostic facilities. And registration is usually valid for 5 years, after which it has to be renewed. If suppose the application is rejected, the reason has to be stated by the authority, and the owner can appeal and also is given a chance to explain. So in case of registration or reapplication, then no additional fees has to be given. And registration may be cancelled or suspended if the entity contravenes the provisions of the bill. And Chapter 4 includes the duties of the ART clinic and the ART banks. So usually the clinics must ensure the eligibility of the commissioning couple, the woman or the gamete donor. They should provide professional counseling and also help the couple to take an informed decision, make them aware of the rights of the child born through ART, and the donor's details should be kept confidential, and the gametes should be obtained from the banks. So the banks should screen the gamete donors for medical illnesses. They collect, screen, and store the sperms in case of males between the age group of 21 and 55 years, and they can provide the oocyte donors, the females between age group of 23 to 35 years of age, and also should collect all the necessary information from the donor and also get a confidentiality signature from them. So the do's and don'ts of a clinic. In the ART clinic, the services can be applicable only to women above 21 years and below 50 years. For a man, it should be above 21 years and below 55 years. They should issue a discharge certificate stating all the details of the ART procedure performed. Every clinic should maintain a grievance cell. They should cooperate and make available their premises for any physical inspection by the National Board, National Registry, or the state boards. Provide all the information related to enrollment, the procedures undertaken, and the outcome to the National Registry periodically. And they should not perform any treatment without a written informed consent. And in case of donors, they should get an insurance coverage for a period of 12 months. They should not cryopreserve any human gametes or embryos without specific instruction and consent in writing from all the parties seeking ART in case of death or incapacity of any party. And a bank shall not supply the sperms or oocytes of a single donor to to more than one of the commissioning couples. And any of the commissioning couple may withdraw his or her consent any time before the embryos or gametes are transferred to the concerned woman's uterus. It is very important to maintain the records in very detailed manner, and also it has to be submitted online within 1 month after establishment of the National Registry. And the records have to be maintained for at least 10 years. And upon expiry, they have to be transferred to the central database of National Registry. In the event of closure of the clinic, and then all the details should again be transferred to the central database of National Registry. The use of human gametes and embryos, not more than 3 embryos may be placed in the uterus of a woman. And the woman shall not be treated with the gametes or embryos from more than 1 man or woman during 1 treatment cycle, and never mix semen of 2 individuals for the procedure specified under this Act. And collection of gametes posthumously done is only allowed if prior consent is taken of the commissioning couple. And do not use ovum or any derivatives from the fetus in any process of the IVF. And use of any gametes or embryos or their transfer to any country outside India for research shall be absolutely prohibited. And sex-selective ART is prohibited under PCPMDD 1994, only with an exception to diagnose, prevent, or treat any sex-linked disorder or disease. Pre-implantation genetic testing is usually allowed only to screen embryos with known or pre-existing heritable or genetic diseases only. And donation of the embryo after PGD is allowed only with the approval of the commissioning couple or the woman, or when the embryo suffers from any pre-existing heritable or life-threatening or genetic diseases. And the storage of gametes and embryos is has to have appropriate standards. The clinic should have, the banks should have appropriate standards in respect to their security, recording, and identification. And the gamete of the donor or embryo shall be stored for not more than 10 years. Sale or transfer of gametes and embryos, it is usually prohibited, except in case of transfer of own gametes and embryos for personal use with the permission of the national board. And the child born through ART is considered as a biological child of the commissioning couple and is entitled to all the rights and privileges available to the natural child. And the donor shall relinquish all parental rights over the child or children which are born through his or her gamete. The chapter 5 includes all the offenses and penalties. Any advertisement regarding facilities of sex-selective ART includes punishment of imprisonment for not less than 5 years and a fine not less than 10 lakh rupees or both. And any of the following offenses like abandoning, disown, or exploit children or child, running an agency or a racket or an organization for selling or purchasing human embryos, and importing or helping an import of gametes, exploiting the commissioning couple or transfer of a human embryo into a male person or an animal, selling of embryos or gametes for the purpose of research, and use of intermediates to obtain gametes. All these are punishable, and at the first contravention, they are punished with a fine not less than 5 lakhs, but may extend up to 10 lakhs. In subsequent contravention, they have an imprisonment of not less than 3 years, which may extend up to 8 years, and a fine not less than 10 lakhs. All the offences under this Act shall be cognizable and bailable. The trial for the punishment is conducted in the presence of Metropolitan Magistrate or a Judicial Magistrate of the first class. And in case of any offense committed, the executive head of the clinic or the bank is deemed as guilty, and they are punished accordingly, unless he or she can prove that the offense was committed without their knowledge, or he or she has exercised all due diligence to prevent the commission of such an offense. So chapter 5 is miscellaneous, where they have stated that the central or the state government may issue notices from time to time, And if in case of dispute between the central government and the national board, the central government will have the final say. And similarly, if any dispute arises between the state government and the state board, the state government will have the final say. If the national board or the national registry or the state board find that there is any offense committed by clinic or any bank, they are allowed for search and seizure according to the Code of Criminal Procedure 1973. And there is no suit or prosecution can be held against the appropriate authority or any officer who is authorized for anything which is done in good faith or intended to be done in pursuance of provisions of the Act of or the rules or regulations. So based on this 6 chapters of the bill, later in 2022, the central government issued the rules that have to be followed by the clinics and the banks. So we have, as of now, there are 2 levels of clinics which have to be registered. In level 1 ART clinic, only intrauterine insemination procedure can be performed, and it requires a minimum of 1 gynecologist with postgraduate degree, and minimum equipment required is a microscope, centrifuge, and refrigerator. And ART level 2 clinics can perform surgical retrieval of gametes, handling the gametes and sperms for fertilization, embryo transfer, storage of gametes or embryos and research can be done. And they should have 1 gynecologist, 1 anesthetist, 1 embryologist, 1 counselor, andrologist, and a director. And the minimum requirement of equipments would be a microscope, incubator, laminar airflow, sperm counting chambers, centrifuge, refrigerator, equipment for cryopreservation, ovum aspiration pump, ultrasound machine with a TDS probe and a needle guard, test tube bomber, and anesthesia resuscitation trolley. So for ART banks, usually they are allowed for screening, collection, and registration of semen donors and cryopreservation of sperms, and perform screening and registration of oocyte donors. They can operate as semen banks, oocyte banks, or even both. And they should maintain records and regularly update them to the national registry. Minimum of 1 registered medical practitioner trained in handling, preparation, and storage of semen samples should be available. And the minimum equipment would be a centrifuge machine, incubator, microscope, and a laminar airflow. So application for registration, ART clinics would submit Form 1 and ART banks would submit Form 2 to the appropriate authority. And the fees would be rupees 50,000 for level 1 ART clinics, level 2 would be rupees 2 lakhs, and 50,000 for ART banks. And for establishments run by government, no fees are applicable. In case the application of registration has been rejected, then on resubmission, no fees shall be required.
2 more minutes, ma'am. Sorry, 2
more slides, ma'am. 2 more slides, ma'am. I'm done. So for certificate of registration is granted by the appropriate authority, and that Form 3, 1 copy of the certificate of registration should be displayed in the clinic and the ART bank. Other duties would be to maintain the following forms, which includes the consent of the couple or woman, consent for IUI with husband sperms, donor sperms, freezing of embryos, freezing of gametes and parental consent, oocyte retrieval consent, and oocyte donor consent. So to conclude, the ART Act has allowed standardization and accountability of ART clinics and banks. It has enabled accessibility to data, improved the public awareness and social ethics. But there is always scope for some changes in future that can make it more convenient for both the intending parents and the clinicians, and also expand its accessibility to currently discriminated groups. And the government has made provisions for those changes in the bill by stating that certain instructions would be stated later as per the requirements and can be modified on the recommendations of appropriate authority. It has put in place government bodies which would be reviewing and reassessing to implement any further changes required. Thank you.
Thank you, Dr. Shravani Chitra, for enlightening the audience on the regulations of the ART Act, as well as the prevention of misuse of these ART clinics, especially which is very essential in the present day practice, as well as explaining the safe and ethical issues of the ART. Thank you. And at this opportunity, I would like to thank the organizers for giving this opportunity for chairing sessions. Thank you.
Thank you.
Thank you very much.
Thank you, madam. We'll move on to the next session, which is the panel discussion on fertility preservation in modern gynecology.
Ma'am, primary amenorrhea.
Sorry, discussion is on primary amenorrhea. The moderators are Dr. Akila and Dr. Gayatri. Dr. Akila
Radhika, please stick on to the time, 40 minutes panel. Okay?
Yes, ma'am, sure.
Ma'am.
So Dr. Akila Vaidyanathan, madam is from, she's done her MBBS from Ramachandra Medical College and master degree from Annamalai University, Chidambaram, and she's undergone laparoscopic training and in World Laparoscopic Center and Kiel School of Germany. Okay, she is a faculty of UA Foxy, Trichy and Salem, and she's presented papers at national conferences. Okay, Dr. Gayatri N. She's an MBBS from Chengalpattu Medical College and she's done MD from Rajamuthiya Medical College. And she's done PG diploma in National School of Indian University, Bengaluru, consultant Shamla Nursing Home, Trichy, executive member of TRIOPS. And interest is high risk obstetrics. And Dr. Thenmozhi is an associate professor in Obs and Gynae department, Chengalpattu Medical College. She's done her PG in Tanjore Medical College. And she's a UG and PG teacher for 15 years, presented papers in national and international journals. Dr. T.M. Vaishnavi has done her UG in Tanjore Medical College and MS in Stanley Medical College. She's a trained laparoscopic surgeon handling high-risk cases. Dr. Swati Rathore is a professor of Department of Obs and Gynae in CMC Vellore, and she's worked as senior registrar in Sattar Jung Hospital in New Delhi, and observer of fetal-maternal medicine unit in Auckland City Hospital, New Zealand, and consultant in CMCH since 2005. Dr. Purnima Saravanan is a consultant Obs and Gynae fertility specialist, Sri Abhirami Fertility Hospitals, Erode and Karur, Abhirami Kidney Care, Erode. Dr. Uma Brinda, she's from Government Tanjore Medical College and has done her post-graduation in IOG, Chennai. She's working as assistant professor, Department of Obs and Gynae, Government Raja Mirasur Hospital, Tanjore, and she's at present the secretary of Tanjore Obs and Gynae Society. Her areas of interest are high risk. So let us, I invite all the panel members and moderators, and can you please start the discussion on primary amenorrhea.
Very good afternoon to everybody. I welcome all my panelists for the meeting. Without wasting much of time, we'll go.
And please stick on to the time.
Yeah,
40 minutes. Thank you.
And now I welcome all my panelists. So before we go on to discussing the cases here, let us get a few of our basic definition and other things clear.
Gayatri ma'am, sorry, you can go to slideshow if you don't mind, please.
Just a minute, it's getting done. We'll go like this itself actually by, okay, fine, good. By definition, so primary amenorrhea, by definition is failure to reach menarche. When do we evaluate? It's 13 years, there's no secondary sexual characters, then we would like to evaluate. Or a 15-year-old girl with development of secondary sexual character, we should evaluate. Or if there is any initiation of the breast development is there, but not attain menarche after 5 years, we would like to evaluate. So for menarche to occur, we understand that the higher centers, you should have a normal functioning hypothalamic pituitary axis. We should have a good ovary and a proper reproductive anatomy with no outflow tract obstructions, normal nutrition and normal lifestyle, a good lifestyle, healthy lifestyle, and absence of any other chronic illness which can affect menarche. So we would like to move on to the cases. A 16-year-old girl is brought by her mother with complaints of not attained menarche. So how would we proceed? Yes, we have all our panelists here who would like to take this question. Dr. Thenmozhi.
Yes, madam. Good afternoon. Yes, madam. Good afternoon. I first thank TNFOG and Dr. Sampat Kumari madam for giving this opportunity. So the 16-year-old girl have come with amenorrhea. And we have to first ask what was the family history when her mother attained menarche.
Excellent. What else?
We have to first ask whether that is a familial thing that she is getting delayed, other than that, what because of the constitutional thing. And then we have to examine thoroughly her head to foot, and we have to see her the secondary sexual characters, like the breast development, presence of axillary hair, presence of the pubic hair, and the female voice, and whether she has any environmental factors like a very high stressful condition, or about her nutrition, what is she's taking, and yes, madam. And
yes,
whether,
go ahead, please.
Whether she had any whether she is having any contact like that, and then first we have to think of all those things, and then we can ask for any thyroid disorders, and then we have to examine for the hirsutism features like that, and then for abdominal examination we can go for the mass is palpable, and local examination whether this hymen is present or not, and we can do it will be completing with perirectal examination to palpate the uterus and the cervix anteriorly.
Excellent. So it's very important. I mean, half of your answers you will get it in history and physical examination itself. Whether was the family history, any secondary sexual character, and when they started, any history of cyclical abdominal pain, trauma, surgery, medications, and nowadays even young age chemotherapies and all are seen. History of any neonatal bleed. This will tell us whether there is the anatomy which is functional or not. And very important, as westernization is happening everywhere in India, we need to ask whether she is sexually active. Even before menarche, we do come across certain things in metros especially. Any other symptoms that we are able to relate, especially to chronic illnesses, and inquiry about the girl's lifestyle, heavy exercise, whether she has history of anorexia nervosa, etc. In physical examination,
we do a general examination. Is very important. BMI, obesity is one of the major things, and Tanner staging. As you said, breast development and pubic hair, and abdominal palpation if there's any mass which is felt in the pubic region or any other mass. Local examination of the genitalia has to be done, and rectal examination.
So, just for a revision's sake, in the telarchy, we have the stages. The stage 1 says that there is no breast development, no breast tissue palpable. It's a flat chest. In stage 2, we have a small breast bud which is palpable right under the areola. In stage 3, this palpable breast is outside the area of the areola, but the areola is not yet developed. It's infantile. In stage 4, the areola develops above the contour of the breast. And in stage 5, you have the proper adult shaped mold, and the areola recedes into a sink, and the whole thing appears as a single breast tissue.
And pubarchy, when the stage 1 is there's no hair, stage 2 is downy hair, and stage 3 is scanty terminal hair. Stage 4 is terminal hair that fills the entire triangle over the pubic region, and stage 5 is terminal hair that exceeds beyond the inguinal crease onto the thigh. So if the same girl is brought to you, 16-year-old girl, so it's all secondary sexual, she has all secondary sexual characters are present. There's a family history of menarche at 15 to 17 years. She's thin-built, her athlete at school. Her eating habits are normal. And per abdomen and local examinations are not very much, nothing is remarkable. So what would you investigate next? Dr. Swati?
Dr. Swati has got some network issue. She's just messaged. So I think Dr. Vaishnavi, are you there?
Yeah, ma'am.
Yeah, take this here. What will you like for this scenario?
Yeah, the secondary sexual characters are present, which means she's having estrogen, like she's estrogenized. So that part, so now we have to make sure whether anatomically she's fine, whether she's having a normal Mullerian system so she can menstruate. And for that, we'll have to do an ultrasound. So that will ensure whether the uterus and the cervical canal is present or not. And then hormonal analysis may need to be done if everything else is, if she has a uterus and an ovary is present.
Because the secondary sexual characters are present, we are almost quite sure about the hormones, the presence of hormones and the hormones acting on the target organ. So
Yes.
we can go for the ultrasound, as you said. The first, investigation of choice will be an ultrasound. So in our present case, you have the uterus with the ovaries. So what do you do next?
So,
is there anything else? How would you diagnose this girl?
Actually, the family history, it is between 15 to 17 years. So we can actually wait. But then there are other factors like she's thin built and she's an athlete at school. So that has something to do because their needs, they can be reassured, but then they have to be told to maintain a normal weight, at least above 40 to 45, like that could be an ideal weight for the reproductive system to function normally, for the hypothalamo-pituitary axis to be functioning normally. So
you need a minimum amount of adiposity for steroid hormone synthesis and maintenance.
Yes. So that thing we have to, apart from reassurance, we have to tell them to ensure that they have that much of weight gain. So she will probably menstruate in some few months or within that age of their family.
So we reassure, give her a little of nutritional advice, and we keep her and follow up.
Yes.
Excellent. We'll go for the next scenario. The same girl now gives you a history of an occasional abdominal pain, but the patient can't say anything further. She's not able to say how often and how frequently she gets it. And there is no other significant history. Secondary sexual characters are present. She's in TANUS 4 and average build. There is a suprapubic tenderness on deep palpation. And in local examination, you see a big bulge at the introitus with a bluish membrane. How would you proceed? Dr. Vaishnavi? Anybody else is there?
I'll take the question.
Dr.
So, if there is, as it has been told, suprapubic tenderness on deep palpation and cyclical abdominal pain. So, it is most likely an outflow tract obstruction. Ma'am, am I audible?
Yeah, you are. Go ahead.
Yes, ma'am. So it is most likely a case of an outflow tract obstruction. So most likely an imperforate hymen. So apart from evaluating the presence of other anomalies like the kidneys and by doing an imaging, then we may need to go for surgical treatment for the imperforate hymen.
So here, whenever we have some problem, yes, doctor. Yes, go ahead, Dr. Tenmuri.
Rarely we can intervene. Cervical stenosis also associated with that. We have to thoroughly evaluate the upper tract also. So we have to do a MRI beforehand.
See, here the case is very clear when you have this bluish membrane, because obviously if the membrane is so bluish and it's extending, you can say that there is no transverse pelvic flow or the whole thing is very thin. But if your clinical finding is not so clear, you can't proceed without an MRI. Otherwise, we are bound to not give her a good surgical cure. So that is what we would like to bring up in this case. And ultrasound imaging of the kidney is very, very important, because all these genitourinary systems, that's how we call it. So we need to have the urinary system evaluated as well. Any other important counseling would you advise or any other follow-up, Dr. Uma?
Yes, ma'am. Yes, ma'am. She is more prone for endometriosis also.
You hit the bullseye. Come on.
Yes, she has to be given counseling regarding future chance for endometriosis, madam.
Just an add-up, madam. If the history for the cyclical abdominal pain has been for a particular long time, then we may suggest combining a laparoscopy along with the hymenectomy.
No, ma'am, not initial.
Not in the initial. Yes.
Would you like to go for the same sitting?
No, ma'am. Not in the same sitting.
For follow-up,
if she is having a high chance to get endometriosis, we should give a counseling regarding that. And in future, if she presents with any symptoms, it suggests endometriosis. That's all, and no need for a combined procedure lab at that time.
And in these girls who give you such history, we can't even take a dysmenorrhea as a primary dysmenorrhea. We need to evaluate it properly, because even if they don't have endometriomas or chocolate cysts, they could have deep infiltrating endometriosis.
Yes, ma'am. Yes.
So moving on to the next one, the same girl, the 16-year-old girl, she comes with a mother. So the history is nothing. There's no significant any history.
Tanner staging, she has secondary sexual characters are developed. Tanner stage 4. General examination, there's nothing significant. Everything looks normal. So what would be next? Dr. Purnima?
Has Dr. Purnima joined us?
Hello. Yeah. Hi. Hi, ma'am. Very good afternoon.
To the panel,
And yeah, I'm sorry, I'm having a little bit of connectivity issues. I hope I'm clear. So
Yeah,
when having seen the history and case scenario, so we'll do an imaging if other general examination, other parameters are normal, since the secondary sexual characters are normal. So we have to look for the imaging. And then if in the ultrasound, if the uterus and ovaries, depending on that, we'll have to proceed. So what is
So in this case,
imaging in this?
There's absent ovary, there's absent uterus and ovaries are seen. What would be next?
Then we'll have to do the hormonal levels, and then also we can do karyotyping. So and then proceed further accordingly.
So why do you do a karyotyping? What exactly do you want to differentiate?
We have to differentiate between the Mayer-Rokitansky Kushner-Hauser syndrome from the androgen syndrome.
Exactly.
So we also have to differentiate from the testicular.
We are not sure whether it is ovary or gonad.
Yeah.
So, Mayer-Rokitansky syndrome, counseling is very important when we go about. What can you offer? What kind of treatment can you offer for a periods? Can you offer any kind of periods? Can you offer anything of that sort?
No, ma'am. Actually, in Mayer-Rokitansky Kushner-Hauser syndrome, there will be an absent uterus or a rudimentary uterus will be present. Most cases, it will be non-functioning. So we should counsel her regarding in future she may not have her periods.
So we have to tell her very clearly that because our kind of population associate feminism with having her periods. So we have to tell her very clearly that it's okay, and counseling, we might have to spend quite some time to reassure her. Has Dr. Swati joined us?
Yes.
Yes. So Swati, what will be her sexual prospects? She be able to have a normal life? How are you going to counsel her?
Her lower 1/3 of the vagina only will have been developed. So she needs a deep vagina. For that, we can counsel her for undergoing vaginoplasty near marriage. And then for reproductive prospects, we can ask her to go for surrogacy. And then in recent terms, we have read about the articles of a uterine transplant. We can update her.
That is looking into the future. The great you brought up the point. And for her reproductive prospects, which exact program would you like her to go through? Surrogacy, yes. What about the gametes?
Surrogacy. Gametes, she can donate gametes. She can be the donor. She can be own her child. Her
So she can be a mother, but she can never be pregnant.
Yes, she can be a biological mother, but she cannot carry her in her womb.
Carry her child. Would any other panelists would like to add anything for the Myanmar-KH syndrome? Any panelists would like to add any extra points? Okay, so
this vaginal reconstruction is needed with vaginal dilators.
Yeah, nowadays even simple deepening procedures can be successful. There is some amount of depth in the vagina.
Yes, and other renal anomalies, spinal anomalies to be ruled out.
And yes, other organs also, hearing defects and heart defects have been reported in association with them, and necessary evaluation is mandatory.
Yes.
And Dr. Swati, how would you like to differentiate this from the testicular feminizing syndrome? What is the finding that differentiates? Dr. Swati, are you with us? Dr. Vaishnavi, would you like to take this?
Yeah, ma'am, I'm here. The finding on clinical examination would be to look for pubic hair, and the presence of which will indicate that she's genotypically she's a female, 46XX. So if she's going to be 46XY, then the hair will not be present. And the investigation to differentiate will be doing a karyotyping. So that will tell us if she's 46XX or she's 46XY.
XY.
So if it is XY, then it is a case of androgen insensitivity syndrome. And if it is XX, then it is something else that is different from the previous case.
So now we have, now assume that this is our next patient who has been diagnosed with testicular feminizing syndrome. Now, what is the difference between sex and gender? Any of my panelists? You can volunteer this question.
So, gender is what she identifies herself. Either she can be identified as herself as a female, or can be she can identify herself as a male. So what she thinks in her mind, psychologically. So that is gender. Sex is what is a appearance, physical appearance is sex. So where in this testicular feminizing syndrome, she thinks herself as a female and she was brought up as a female. So we have to give counseling.
Also female, but she is actually not. So here,
but actually she is XY. But we have to counsel her regarding that, and we can inform her that her hormones is a XY chromosome, and we have give counseling regarding the further her sexual life like that. We can go for a vaginoplasty, deepening her vagina like that. We can have counseling for her.
So what about her sexual prospects?
Yes, she can be taken as a female. She thinks, because she thinks as a female herself, she can be allowed her to be as a female, and she can have a sexual life, marital life, by deepening of the vaginoplasty can be advised for her.
And reproductive prospects, Dr. Uma?
Reproductive prospects, because
she is not. Yes, ma'am. As she is not having a uterus, and both ovaries and uterus are absent, so she only choice is adoption. No rule for surrogacy and all in this case.
Or gamete donation she cannot do gamete donation or
there is no anything else. Would you want to tell her anything more than this?
She could, as she's having a Y chromosome
to be removed.
Yes.
Gonadectomy should be done.
Around after secondary sexual characters are well developed. Yes, the two things we have to note in androgen insensitivity syndrome is that these gonads, unlike other syndromes, there is a less chance for tumors, and the second one is it is essential for a secondary sexual characters to develop. So even if we diagnose at 13 years, around 13 years, we should wait till 18 or 20 years, and then only gonadectomy should be planned.
Excellent. And but then in the meanwhile, they should be monitored.
Yes, ma'am.
So going to the next scenario, again we have a girl with no significant history. Here we do not have any secondary sexual characters, and her per abdomen local examination, general examination unremarkable. So what next? Can I have Dr. Purnima to answer this?
Yeah. So again, we'll have to go for the hormonal levels. So depending on the FSH and other thyroid, other parameters, we'll have to proceed further.
We have to do ultrasound, which is non-invasive, and it will help us in the diagnosis. Ultrasound. First ultrasound, go for ultrasound, and then that will be substantiated by the hormone analysis. Because she has no secondary sexual characters, we have to see what about the uterus and ovaries, whether present or not, and that has to be substantiated with her hormone analysis.
Hence, here in this case, when we have already said that the secondary sexual characters are not there, we know that there is no estrogen, and there is no ovary which has produced any hormone, and no estrogen. So here, I think the hormone assay comes before the ultrasound. So when the secondary sexual characters are not there, according to your protocols and your hormone assay comes first. Once you have proven clinically that the patient is that clinically, the ultrasound comes first to look for the target organs. So here now we have a case. This girl had the FSH is 32. Dr. Vaishnavi, what next?
Dr. Vaishnavi?
Yes, ma'am. The FSH levels are like 32. Is that what I heard, ma'am?
Yes.
Yeah, it is usually when the FSH levels are higher, it is always recommended to repeat it after a month. But then the 32 is still on the higher end. So which means that the pituitary is secreting FSH, but the ovary is not responsive to it. Which means the issue is somewhere in the compartment of the ovaries. So we'll have to find out first by imaging whether the ovaries are present or not, and then go for karyotyping to find out whether the issue is really in the genetic chromosomal end.
So yes, it could be a primary ovarian failure. That could be a weak ovaries, or it could be a genetic disorder. So we could do a karyotyping, which could be 45X0. And what other investigations would you like to do? Any other?
Turner's 45XO is a multi-system involving disorder, so which can involve, which can present along with diabetes, thyroid issues, heart defects, and kidney issues. So we'll have to evaluate everything one by one, step by step, and then we will have to go for addressing the primary issue. And people with Turner's will have a proper, will have a uterus and an outflow tract as well. So we can initiate therapy to let them menstruate with estrogen and cyclical progesterone. And so menstrual function will be sorted. And for reproduction and the other issues, we'll have to go according to their...
We'll take this one by one. How are you going to use menstruation for this girl?
Is that to me, ma'am?
How are we going to induce menstruation for this girl? Is it
so? No.
Her,
give them initially for unopposed estrogen needs to be given. So in equine estrogen needs to be given, which can be gradually increased in dosage. And
how
then
are you actually going to? What is your prescription going to be like? What estrogen would you choose? How would you?
Equine estrogen.
Okay, conjugated equine estrogen. What dose would you like to start? How long?
You have to start it initially in smaller doses like 0.25 milligrams, and then we will have to increase it. And then after a year of supplementation, then progesterones need to be added. In the every 14 days once for 14 days.
Does the family agree with this? Anyone has a different opinion?
Dr. Swati, we should look at the height. These Turner syndrome, they are short-statured. So before starting estrogen, you should look for the height. And if needed, growth hormone should be started initially, and then only we should start estrogen. Ideal time to start is between 12 to 15 years, not before 12 years. And same like we should start with equine estrogen, and first we should look for the secondary sexual characters to develop, and then only we should add progesterone for withdrawal bleeding and look for bleeding.
Sorry for the interruption.
Yeah.
You have another 10 minutes.
Yeah. This is the last case.
Okay.
Actually,
thank you.
When we start inducing periods for the Turner syndrome or the primary ovarian failure, the first period is always a breakthrough bleeding. We give them estrogen because we want the secondary sexual characters and the growth spurt blocker. I agree that the first period is never a withdrawal, it is always a breakthrough bleeding. You keep giving her estrogen till she bleeds, has a breakthrough bleeding. Once she has the breakthrough bleeding and establishes her menarche, it is after that we go for the COCPs, or you give the estrogen first and then 10 days of withdrawal. This is what I wanted to emphasize in this slide. And yes, anyone to take it up? Dr. Purnima, how about her sexual function? How would you counsel her? Will there be any difficulties? Dr. Purnima, are you with us?
The uterus and the vagina will be well developed because there is no anti-Mullerian inhibitory hormone. So uterus and vagina will be
no sexual. Yeah. Dr. Swati, are you there? We haven't heard you much. Dr. Swati, how about her reproductive functions?
I don't think Dr. Swati.
Dr. Uma?
Yes, ma'am. She is having a uterus is there. She can try her pregnancy by oocyte donation. we should look at the other factors, renal functions, thyroid disorders, and echo should be done. She's more of having coarctation of aorta and other valve abnormalities. So actually, it is a relative contraindication for pregnancy. We should rule out all other abnormalities and then counsel her regarding the oocyte donation and then go for reproductive. Her pregnancy should be planned after a thorough medical evaluation of all the disorders, and she should be explained about all the dangers of becoming pregnant, and then only pregnancy should be planned, and that too by oocyte donation.
This Turner syndrome, we all know they have streak ovaries. So most likely they will go for a donor gamete program. But there have been cases reported where these streak ovaries do produce a few gametes. So we will have to tell them that the rate of failure in having that gamete is quite high. But we can offer them if they interest.
So for FSH is more than 20, then it's ovarian dysfunction. So we do karyotyping as we discussed, or I think we have all discussed about all this. 46XX is primary ovarian failure or resistant ovarian syndrome, and 45X0 is Turner's. So now comes when our FSH is less than 20, what would we go about? How would we go?
So the defect could be at a higher center.
Higher center.
At the higher center. So
it could be hypothalamic pituitary dysfunction, where the FSH level could be very low, as low as 5. It could be a thyroid disorder, a hyperprolactinemia, or hyperandrogenism. So for hyperandrogenism, we'll require an MRI to be done to rule out if there is any adrenaline tumor
or an ovarian tumor. Now, the last case scenario, we have a girl with no secondary sexual character. Her FSH is 8. And there is no virilization also, and her general examination is normal. So what next, Dr. Vaishnavi?
Yes, ma'am. Absent secondary sexual characters would mean that she has no estrogen. Then FSH levels 8, almost like within the normal range, means that her hypothalamus is functioning properly. So we'll have to, since there is no virilization, then we'll have to assess for the anatomy and the other endocrinological abnormalities, and then assess her actual history and her age. And then if everything turns out to be normal, then we can consider it to be a constitutional delay and then wait for it.
So for her, we would like to assess her bone age first. And then we could say
that
it's
is
delayed
also
or
delayed.
that is also delayed. Then it could be a constitutional delay of growth and puberty.
And this one flow chart will give us precisely how we should go about in any case of primary amenorrhea, a concise flow chart. So in any case of primary amenorrhea, the first thing will be a general examination where we decide whether she has her secondary sexual characters or not. Presence obviously says that the estrogen is there and working well. And in today's era, we should not and dare not forget that even before the onset of menarche, we have cases of pregnancy reported. So, and this is a very sensitive thing. You have a girl who's not even in a menarche, and obviously they are all, even if they are sexually active, they are going to deny it. So how are you going to convince her, or how are you going to do this pregnancy test? Anyone from the panel? Dr. Purnima, do you have any ideas? How do we convince, or how do we do that without getting into trouble?
Sorry to interrupt, only 5 minutes more.
This is the last slide, ma'am.
Okay.
Madam, we can have a one-to-one counseling with her within a room, and then we can ask for any contact, sexual contact, and then we can do her a UPT, urine pregnancy test.
They are most likely to deny, madam. They see us for the first time or something, they are not going to trust us.
We can probably directly do away an ultrasound, ma'am.
Directly do an ultrasound. Yes, not bad, but if it is an early thing or something like that. Yes, what you said is exactly one point. It's very easy to get away with it because everybody will expect an ultrasound at that time. I would like to give a small idea. Just do a urine routine. Ask your lab to include it. Need not report it. They can confidentially tell us. After that, it will be easier for us to proceed with. This is just my own thought. It's not in the protocol, of course. And yes, positive, you leave her alone. And negative, we go for a pelvic ultrasound, and where we look for the uterus. If the uterus is absent, Then the karyotype, which is if it is XY, it's an androgen insensitivity syndrome and the necessary counseling. And a normal karyotype, it could be Mullerian agenesis and the necessary counseling for that. If there is no secondary sexual character, we need to find out the hormone problem is there. There is no estrogen, but which is the culprit? Which compartment exactly? It is the higher compartment, the accessory compartment, or the ovarian compartment, for which we go for the FSH. Once the FSH, we find out it is less than 20. We know that the ovary is not the culprit. We try to look for where either it's the higher thing or the surrounding structures like the prolactinemia and the thyroid. We go for a brain MRI can be done to look for empty cellular syndrome or something like that. And if the FSH is between 5 to 20, look for virilization or other associated problems. Virilization is there. You try to measure the serum testosterone at DHEAS, and you can find out if it's a case of hyperandrogenemia, and you may have to go for an MRI. If there is no virilization, FSH between 2 and 12, it could be a constitutional delay, or it could be a normal thing where again you have to go for the imaging. If the FSH is more than 20, then the probable culprit is your ovary, which is not responding to your higher centers FSH. Then we try to do a karyotyping. If it is normal, it is an ovarian insufficiency or a resistant ovary syndrome, the Savage syndrome. If it is abnormal, it is a genetic syndrome, which is the Turner syndrome. This is the final protocol primary amenorrhea, which includes everything.
Thank you. I would like to thank all the panelists for giving us a wonderful answer, and I would like to thank TNFOG and Dr. Sampath Kumari for giving us this opportunity.
And thank you all the panelists for this active participation.
Thank you, ma'am. Thank you so much.
Thank you, ma'am.
Thank you. Thank you, ma'am. Thank you.
Moving on to the next program. So I invite the judges, Madam Dr. Vijaya Madam, and Dr. Seethalakshmi Madam, for the debate on NMC regulations. Dr. Vijaya Madam is the former director of Institute of Obs and Gynae, Egmore, Madras Medical College, and her special interests are high-risk pregnancy, infertility, laparoscopic surgery, and she has a number of credits. She's a national level master trainer, skill lab, and trainer in safe delivery practice, and as EMONC, emergency obstetric neonatal care, and she's a master trainer in FOGSI RASC program and member of FOGSI Public Health Awareness Committee, master trainer at FOGSI DIRA, and next is Professor Dr. K. Seethalakshmi Madam. Currently, she is working at Institute of Obs and Gynae, Madras Medical College, and she's a certified urogynecologist with special interest in POP, especially vault prolapse. And she's done research in autologous. Facial sling in abdominal sacrocolpopexy, received PhD in urogyne through Dr. MGR Medical University, Tamil Nadu. She's trainer for specialists in urogynecology since 2011. She has numerous publications and international national publications and has participated as a faculty in various national and international urogyne conferences and reviewer in IUJ. Okay, next I invite Dr. Rahul Anand Kanagasababadi, Senior Consultant in Government Comrade Hospital, Chidambaram, Tamil Nadu. Is a PhD research scholar at Annamalai University from 2021 to present. Areas of interest: obstetric medicine. And he has received the Srimati Bhagavati Devi Jamana Singh Prize for Best Paper in Geriatric Gynecology in ACOG 2023. And also KFOG Presidential Gold Medal. And he has numerous papers which were published in various conferences. I invite Dr. T.M. Sandhya Devi, who's Assistant Surgeon, Government Kamraj Hospital, Chidambaram, and he's done his MBBS in Sri Moogambika Institute of Medical Sciences, Tamil Nadu, MSOG Institute of Obs and Gynae, Tamil Nadu, and FMAS World Laparoscopy Hospital at Gurgaon. His special areas of interest: endoscopy and gynae oncology. I'm really proud to introduce the madams, and please take over the dais, ma'am, for the debate. Dr. Vijaya ma'am and
Good morning. Am I audible?
Yes, ma'am.
Yes, madam. Yeah, maybe my video is not seen. I think it's nevertheless. I have immense pleasure in listening to the sound and voracious debate by Rahul and Sandhya. And Rahul, the stage is yours.
Thank you, madam. I'll just share my screen just a minute.
Dr. Vijay, please make your video on so that we can see.
No, there is some problem, I think, ma'am. Maybe.
Network problem. Okay.
Yes, ma'am. Video varma.
Is the screen seen, madam?
Yes, we can see.
Yes, sir.
So good evening, everyone. Before going on into the debate, I am so happy to be presenting this in front of my teacher, Professor Dr. Vijaya madam and Professor Dr. Sita Lakshmi madam. So disclaimer, the aim of an argument or a discussion should not be victory but progress. So let us see what this debate brings out. So the debatable topic today is the National Medical Commission regulations on limiting OBGYN practice. That is, only super specialists to tackle gynae endoscopy, urogynecology, fetal medicine and gynae oncology. So I have been tasked with the monumental task of speaking in favor of the draft. And so what is this regulatory draft actually? So the NMC released a draft regulation in last October stating that broad specialties are to limit the handling of clinical cases under the scope of super or subspecialties once there are 100 super or subspecialties available in that particular discipline across the country. So why should we be bothered about it? No general surgeon is going to do an open heart surgery or a metastatic brain cancer craniotomy surgery. No gastroenterologist is going to take up a complicated liver transplant just like that. And no pediatrician is definitely going to treat a childhood malignancy. So is it going to be a problem for us? So we obstetricians along with orthopedicians and dermatologists used to pride ourselves as end specialists. So is this a sweet cookie or is this draft really a bitter pill to swallow? So let us see what the rationale behind the draft actually is. So who are all these stakeholders involved in this regulation? It involves the doctors, the policymakers, the corporate enterprises, the judiciary, the media, and ultimate beneficiaries of the entire healthcare industry, that is the patients. So what about the doctors? First, the doctor should be aware of the availability of super and subspecialty courses in OBGYN. And why is this important and what should we do? What are the implications of this draft? And what is the future of the teaching hospitals in the super and subspecialty courses? Pertinent to obstetrics and gynecology, we are no more an end specialty. There are super specialty courses which are offered for 3 years. They are the Doctor of Medicine, Master of Chirurgy and the Doctorate and National Board in 2 separate super specialties called as Gynec-Oncology and Reproductive Medicine and Surgery. There are also postdoctoral certificate courses for 1 year, postdoctoral fellowships and fellowship and national board for 2 years in maternal fetal medicine, high-risk pregnancy, obstetric medicine, gynecologic oncology, reproductive medicine and surgery, female pelvic floor surgery and reconstructive medicine, and even in family planning. So these are the only courses which are certified by the board. So why is this important? I would like to take you through a case which was reported just 2 weeks ago. The National Medical Commission finds an anomaly in the qualification of a Delhi doctor accused of negligence. This doctor belongs to a very reputed private hospital and is a very senior consultant in pediatrics. The problem was relating to a case of a preterm neonate who developed cerebral palsy. The issue happened because the doctor was advertised by the hospital as the head of the department of the division of neonatology. The family had accused him as that he does not have a doctor of medicine in neonatology or a doctor of national board in neonatology, which is certified by the National Medical Commission. The doctor in question has an MD, has a DCH, has a DNB pediatrics, and is also certified by the Royal College of Edinburgh with an MRCPH. He has also undergone special training for 3 years in the field of neonatology. Yet, the NMC said that his qualification is not certified and he cannot practice as a neonatologist and he cannot advertise himself as a neonatologist. The court took it into suo motu and has fined 10 lakhs for him. You might also remember a case which happened a few months ago where a senior gynecologist was slapped 10 lakhs qualification for performing an anomaly scan, and the court recommended that level 2 TIFA scan should only be performed by certified radiologists or postdoctoral fellows in fetal medicine, and the senior gynecologist was slapped 10 lakhs. So this draft regulation is very, very important and we should know where we stand. Moving on, our clinical decisions also involve multidisciplinary team approach nowadays. The Royal College, the WHO, the ACOG and the FIGO, all the scientific organizations across the body recommend this multidisciplinary approach for obstetric emergencies in every single maternity unit. So all maternity units are expected to be equipped with a 24/7 obstetrician, anesthetist, emergency physician, intensivist, a clinical transfusiologist, wonder who that is, and a hematologist also to tackle emergencies. So moving on to the teaching hospitals. So who are going to teach these super specialists? My seniors would definitely remember and agree that the first cesarean would have been taught to a gynecologist by an undergraduate doctor, and the first open heart surgery would have been done by a general surgeon, and the first liver transplantation should also have been done by a general surgeon. So notwithstanding anything contained in these regulations, the previous appointments that have been made under the minimum qualification of teachers in 1988, the recommendation of the councils prior to that shall be protected despite any provisions of these regulations. So the teachers are already safe. So how does this draft influence the policymakers? This is actually very beneficial for the policymakers because this draft forces them to increase the pool of seats available in OBGYN super specialty to meet the growing demand, and incentivizing doctoral degrees to improve the uptake. As you have already might have read in the newspapers, there are no takers for MCH in general surgery, following general surgery, and DM following general medicine. The Supreme Court has ordered the cutoff to be reduced to 0%. So anyone who has qualified appeared in the exam can take the seat. So and more institute of national importance should be opened so that such high qualified core specialties and super specialty strengthening should happen, and the public hospitals should be strengthened with newer super specialty and subspecialty departments in every district across the state. So how does this draft influence the corporate enterprises? As you can see, the advertisement very rarely matches the reality, just like the case which I had previously mentioned. So this draft forces them to curb false advertisement. It ensures corporate entities to look for quality in credentialing of the healthcare professionals which they are employing. It evens out the scales by redistributing the appropriate clinical cases to the corresponding specialties. So what is the role of the judiciary in this draft? Law versus medicine, what are the arts? The Western data says that every 1 in 3 doctor has a lawsuit against him. We are no far behind. The era of consumerism has also caught up in India. So the medical fraternity is very well protected by this draft, and it ensures that the highest standard of care was offered if the draft regulations are followed, and it reduces the infringement of litigation issues on the broad specialists also. And finally, the patients, who are the ultimate beneficiaries of the healthcare industries, they are better informed. They have a bigger basket of choices to go to the corresponding super specialty or subspecialty doctor, which leads to higher patient satisfaction scores. And there are lesser room for unanticipated errors in clinical judgment when the procedure is done by the appropriate specialist. So the draft is still in its nation state, so let's not rise in furor against it. It has not yet been passed as a bill. So it will be, should be, and must be subjected to modification. That is the whole purpose of the regulation. It is not yet set in stone. So I would like to suggest a few modifications. I hope the panel would agree with me. So there should be clarity on the time frame for this shift to happen and specific directions on who should handle what. Our representatives from our own parent society, FOXY, should be involved in the final draft, and knowledge dissemination through such continuing medical programs like the OGCON 23 organized by the TNFOG and KSOGA should be happening in a continuous manner so that these regulations disseminate to the grassroots level. Until Professor Dr. Sampath Kumari Madam told that such a thing was happening, I and none of my colleagues were aware that such a regulation has been passed, then that too dating 6 months ago. So do we need to panic? Definitely no. So what we should do, it is time to actually limit the practice. We have to take breaks. We should never be available 24/7 because it will never be appreciated. We should establish a strong referral linkage to tackle unforeseen emergencies, whether or not we are in the public or the private sector, and we should continuously involve ourselves in FOXY activities to update ourselves. Moreover, we should invest in professional indemnity to protect ourselves from litigation, and we should at some point let go of the God complex. We are just healers. We cannot treat everything. We are limited by the physical and mental capabilities of a human body. And we should have accessory source of income. A recent paper told that YouTubers on an average earn more than the top earning doctors. And we should learn a hobby to have mental peace of mind and take adequate vacations. We should also remember that the stethoscope is an instrument of science. It is not a Mangal Sutra. We are not married to the stethoscope. And we should always stay updated. So I have presented the evidence, Recipsa Loquitur. Hope it speaks for itself. And I am sure that our beloved judges will stick to my side and prove that Satyameva Jayate and truth alone will triumph. Moving on, Dr. Sandhya Devi is my opposition. She's not there to stop me. She's just there to establish the facts which I have already proposed, although using a double connotation. Before winding up, I would like to thank TNFOG and KSOG for giving me this opportunity. And a very big thanks from the bottom of my heart to our Vice President, FOXY, Professor Dr. Sampath Kumari Madam, for giving this very interesting and quirky topic for deliberation. Thank you for your patience.
Hello, is Radhika is there? Who's the other person?
Sandhya, ma'am.
Sandhya, is she there? Hello, Sandhya?
Hello, Sandhya, doctor. I'll check, ma'am.
There is a 2-minute rebuttal is also there, no, for Rahul?
Yes, madam.
I called her. She said she's
joining me.
She said she's joined, it seems, ma'am. Vijaya, ma'am?
Yeah,
but she's not here. We'll just check.
Sandhya?
She's there, ma'am.
Okay.
Dr. Sandhya, please. Replay.
Sandhya?
She's in the faculty list, attendee list. She's not there now.
Joined as attendee, ma'am.
Join as attendee.
I have shared the link to her, madam. I'll call her.
No, she's already joined. She's there, but I
Please
spoke to her
accept as
also.
promote to panelist, Sandhya, ma'am.
Yeah, yes, ma'am. Yes, ma'am.
Yeah.
Good evening, ma'am. Am I audible?
Yes. Yeah.
Am I audible?
Yes.
Yeah, you're audible, Dr. Sandhya. Please carry
Yes,
on.
ma'am. A very good afternoon to everybody present here. Ma'am, my slides are visible, ma'am?
No, not
Ma'am, you need to join as a panelist, ma'am.
No, just like they told like to join as an attendee.
No. I have clicked as promote to panelist. Please click that panelist. Accept it.
Okay. Yes. Panelist.
Yes, ma'am. Now you would just please share your screen, ma'am.
Ma'am, my screen is visible, ma'am?
Yes, ma'am. Can you make it a slideshow, ma'am?
Am I audible?
Yes, ma'am. But slideshow is not seen, ma'am. Yes, ma'am. Perfect, ma'am.
Mute laptop.
Ma'am, you are audible and slides are seen, ma'am. You can go ahead, ma'am.
Sandhya? Who is unmuting me? Am I audible?
Yes, madam.
Okay. Sandhya? Maybe she's scared of Rahul.
Ma'am.
Sandhya, can you please start?
I think so. Her audio is having some issue.
Vijaya, ma'am?
Unmute panna.
Sandhya, you're audible.
In the link, faculty link.
Sandhya present.
Dr. Sandhya, can you hear us?
Sir, எனக்கு screen audible இருக்கா?
Yes, ma'am. Audible இருக்கு. Screen தெரியுது, ma'am.
A very good afternoon to everybody present here. Thanks for the opportunity. Moving on to the topic, so far we heard the merits of NMC regulations by Dr. Rahul here. And now let's see
let's hope just to ignite the debate on the issue. Next.
Please click on the screen once and then you can move, ma'am. Accept பண்ணுங்க, ma'am.
Yes.
Yes, ma'am.
Dr. Sandhya, if it is very difficult, you can,
Yes,
without
ma'am.
PPT,
Now
you can talk.
move. You can move, ma'am. You can move now, ma'am.
Okay, ma'am. So, let's write against NMC regulations on limiting the OB-GYN practice. Only super specialists to tackle gynec endoscopy, urogynecology, fetal medicine, and gynec oncology. I'm Dr. Sandhya Devi, MSOG, practicing as assistant surgeon at Chidambaram GH. And what you heard in the past 10 minutes about utterly butterly delicious hamburger, like melting butter with the stuffed ham and vegetables in between. Though it looks delicious, the nutritive value is absolutely zero. Now, time for the reality check. Let's have some Indian superfood. Take some amla. Though the appearance is not that catchy, the nutritive value is abundant here. Let's see what the NMC regulations make our doctors to face few challenges as well as the patients, healthcare industry, and law enforcement and media personnel. So we all know that obstetrics and gynecologists are soft-hearted and thick-skinned. That's not the NMC regulations make it reverse. So actually, these NMC regulations are questioning their acquired competence. The 12th edition of Vaccination operative gynecology says, we retain discussion on the core of gynecologic areas of urogynecology, pelvic pain, cancer surgery, and benign gynecology, and invited new experts to contribute their surgical knowledge. This textbook not only gives the basic principles of almost all gynec surgery, it also discusses about the complications and how to tackle such complications here. And it gives a lot of courage and freedom to perform surgery. And it clearly gives almost all courage to not to depend on super specialty to perform gynec surgery. Having been spent almost 8.5 years doing MBBS, MSOG, and we are yet to spend 1, 2, or 3 more years to accomplish our super specialty or fellowship. And it has been only stated in many studies that the average lifespan of an Indian doctor is about 59 years, and of which 10 to 12 years of our life is being spent to complete our studies to start a career. What are the problems with getting such super specialty seats in India? The government of India has provided only few seats, and it's like a rat race. Dubious seat map is an unreasonable institute of national importance, and already vacant super specialty seats are there. It is very astonishing to hear that the virology seats in the Jipmer Institute are still vacant for the last 5 years. And there are lack of clarity on the multidisciplinary technique and team and the emergencies. How much of an emergency are we supposed to anticipate? Almost, it says that around 0.1 to 0.2% of urethric injuries are happening in cesarean section. Do we ask urologists or urogynecologists to accompany for almost all the cesarean section we do? Or should everything be sent to a super specialist? If that is the case, I may have to refer an old woman from a remote village to a JIPMER or a CMC village or an MMC to undergo her prolapse surgery. It never ends there. The news will spread to the almost all old age women in the village, saying that people are all referring to other institute to undergo such surgery. So they will be very reluctant to reach the nearest healthcare facility to undergo surgeries and their medical needs. The problems to the healthcare industry need not say anything about this. The picture itself speaks. So how can a topmost, the most populous country in the world get treated by just handful of super specialty people? With all that, the public sector is also facing a lot of difficulties, and that it is like congested apex institutes are going to be there. So they are going to decentralize those facilities and incentivizing existing pool of broad specialty doctors to serve in the remote to access areas. It is like 97% of the super specialty people are serving in an urban area, and I don't think how many of them will dare to work in a remote setup. And so establishing the satellite hospitals to serve the rural people and decongest the apex institutes, unnecessary referral for the basic surgeries which can be done in the district level need not to be referred to an apex institute, so that they are not overburdened. and the quality of treatment is going to be good. And by they were reducing waiting times and minimizing errors, and the back referral to the first referral unit to be avoided. And JIPMA, they are referring almost few cases back to the first referral unit because they have been overburdened with the cases. What about the private sector? Like they are also facing similar difficulties in this, like reduced opportunities, corporate politics, and target-based incentivizing, and increased pressure on the broad specialists. And too much room for vindictive interpretation, as to the conundrum of deciding what falls exclusively under domain of super specialists, and more of lawsuits and more defamation. As Sir said, like consummation is more common in this era. Like this will be like another opportunity to backbite. Coming to the media, like media is another emergency mafia in the current society. They have almost all the supernatural power to convert a rumor into a reality. And again, this NMC bill will act as a platform to trash the trust between the doctor and a patient. Now, who will be the ultimate sufferers here? The patients are the ultimate sufferers. They may take time to reach the facility where the needed facility is being provided. So there will be a delay due to overcrowding. And the ultimate sufferers are going to expand out of proportion to the medical needs. And the rural health will be grossly affected by this restriction due to non-availability of super or subspecialties. It is very disappointing that in population of India, like almost 70% are the rural population. So if they are not being served by the government of India, then whom they will serve? Whom they will save? So let us agree to disagree. So I would like to against the present form of regulation, but I would like to agree Dr. Rahul's presentation if there are some changes have been made, like modifying the NMC regulation, address the implementation issues, resolve the barriers, clarify the obscure areas that are open to the malicious interpretation, protect the medical fraternity, more leverage and an autonomy to the state medical council and public health regulatory agencies, and increasing the super or subspecialty fees, incentivizing pursuance of doctoral degrees, addition of more institutes of national importance, and relaxation of selection criteria, and dissemination of knowledge and awareness campaigns by the regional scientific bodies. My dear opposition, it is very easy to defeat someone, but it's very hard to win someone. Aributan?
Rahul?
Yes, madam. So a very interesting presentation, Dr. Sandhya, but I think you have reinforced what I myself was trying to communicate. Unless there is a law, we cannot build on top of it. Nothing will force the government to increase the super specialty seats unless the NMC says that only they can be qualified to do such things. So the Supreme Court has already issued a mandate saying either radiologists or postdoctoral fellows in fetal medicine only are supposed to permitted to do targeted imaging for fetal anomalies. So this has to be disseminated and represented in all forums to increase the postdoctoral fellows in fetal medicines. The advantage when we obstetricians become postdoctoral fellows in fetal medicine is that we can clinically correlate the findings, whereas the radiologist stops just with the image. The same thing holds for all the other specialties also. And I think it is time that we specialized and branched off. That is happening in every single department across all the professions in the world. Why not in medicine, in obstetrics and gynecology? See, you have law for medicine, law for engineering, law for... So there are so many different specialties in law. Likewise, in obstetrics and gynecology also, it is high time that we focused the need for these super and subspecialties. And we are highly entering into the era of consumerism with the insurance companies and their claims, the professional indemnities, the consumerism courts, the lawsuits. A single lawsuit is enough to ruin our peace of mind. One case which goes wrong, one case for which we are penalized. Nobody will stand behind us, not the patient, not the attenders, not the law, not the media, and sometimes not even fellow doctors. The only thing that stands between us and possibly a criminal prosecution is our own protective scientific body, FOXI, and our parent societies, TNFOG and KSOGA. So we have to reach a consensus. We have to make sure that the representation is heard. And there should be a law, there should be a regulation. It is called a regulation for a reason. It regulates who should do what. See, the thing with even earlier we had a discussion. In majority of the places, general surgeons are still doing hysterectomies, which is a very strongly condemnable practice. I'm sure you would agree. The same thing holds good for super specialty also. A recurrent failed prolapse with mesh protruding outside is better tackled by someone who has urogynecological exposure. And that urogynecological exposure should preferably be board certified. That is what we are aspiring for. So we should empanel these super specialists. And I think that already it is being done by super specialists. The only difference is the presence of a board certified degree. The training, which is informal or unofficial, should be brought under the purview of the medical council. And we should make sure that this NMC regulation percolates to every last gynecologist practicing in the remotest part of the world. And I'm sure this conference will be a suitable platform for that. So I think that will be my rebuttal. I still rest my case. The NMC regulation on limiting the practice of the obstetrics and gynecologist against the super specialist is a very welcome one. Again, it is in its nascent stage. It will be revised, re-revised, and the final version will make sure that we live a very happy, peaceful, and hassle-free, litigation-free life. So thank you, Dr. Sandhya.
Thank you, Dr. Rahul.
See, now this
I would
is.
like to thank
Yeah, let me finish my judgment. And this is the time to go for the judgment. And I think you all know, you must have listened to Dr. Patel's talk. And OG cases are, medical legal cases are highest in the world. And it is very surprising. Yesterday I was going through the net. Tamil Nadu is the top in all medical legal cases in OG. So we must know the basics of ultrasound and the basics to repair a bladder injury in case of emergency. And of course, we all learned internal iliac artery ligation during PPH. We went into the retropetal area and we just saw the internal iliac artery, and we started doing almost all the obstetricians are now doing internal iliac artery ligation. So the basic thing, and identification of the insult and identification of the injury and identification of the complication intra post-op is more important than whether we should repair or who should repair, who should be called. And in case of emergency, if it is a simple bladder injury, of course you can do it in a double layered procedure. But in case if you are keeping in mind of the all medical legal issue, it's better to call the concerned specialist. We must it's better to loop in our own colleagues from the other specialty to do all the onco surgeries and the bladder injuries or ureteric injuries, or especially the fetal medicine. Lots and lots of cases are there because it is a double penalized thing for the obstetrician. Mother and the fetus both are involved. So I feel it's better we should loop in the specialties unless and until the NMC regulations have come, the proper changes are made. That's what I feel. Over to my friend, Dr. Sita.
Hello, am I audible?
Yeah, Sita.
Hi, Vijaya, how are you?
Hi, fine, thank you. Please go on.
Yeah, I thank the TNFOG President, Dr. Sampath Kumari, for giving me this opportunity. Now let me tell my verdict. Let me show the PPT of my verdict. Please wait. Is it audible? Is it visible?
Not visible.
No.
You are audible, but the slides are not visible.
Not visible. 1 minute.
Share screen போட்டிங்களா சீதா?
அத போடுறேன்.
ராகுல் எங்களை தான் பாக்குற மாதிரி இருக்கு, அதுக்குள்ள ஒரு தேங்க்ஸ் மெசேஜ் போடுறிய மேம். சான்ஸே இல்ல ராகுல்.
Okay, let me speak because my PPT is not visible. And there are several.
Sita, you can start speaking, no?
Yeah. Am I audible? Am I audible?
Yes, yes.
Yeah, there are several subspecialties in obstetrics and gynecology recognized by the American Board of OBG, and the ABOG administers certification exams for each subspecialty. So OBGYNs may be certified in one or more areas, and they can also pursue some outside opportunities within the specialties which are not recognized by the national board or the respective boards of the countries. So the subspecialty of OBG, as the Rahul and Sandhya told, they include maternal fetal medicine, gynecology, urogynecology, and so on. The super specialty specialization after MSOG and the gynecology also is good, but the boarded subspecialties are gynecology, female pelvic medicine, complex family planning, critical care medicine, and so on. So what is the comparison of reasons for choosing the obstetrician and gynecologist to do the subspecialty training? Recently, the applications for subspecialty fellowship positions in obstetrics and gynecology have increased. A survey completed by the fellows in United States between the period of 1996 to March 2006 was aimed at determining why there was increase in the trend of application for subspecialty fellowship. The two most influential factors in all four subspecialties were the interest of the specialist in their respective subspecialty like urogynecology, and the lifestyle of the doctors who do the fellowship in subspecialty rather than doing the broad obstetric and gynecology practice. So an overwhelming majority, 99% of the fellows were either very satisfied or satisfied with their decisions to pursue the fellowship training. So certain fellowship in minimal access surgery are there in foreign countries like Germany, USA, UK, Australia, and Singapore. But Indian fellowships are far more cheaper and better for practicing, because in the end, what matters is the clinical practice. So abroad fellowships are mostly the observerships where you don't get hands-on practices. So I encourage the specialist. India is such a big country with a vast population, and the country needs more subspecialties to treat the diseases in urogynecology and gynecology, where the disease prevalence is more than the number of the specialists available in the country. So the country should give the adequate treatment, that is the required treatment to the patients in the area of the concerned field like urogynecology, fetal medicine, and gynecology by the subspecialists who have been trained in the fellowship or certified. So the final verdict is fellowship and certification are sufficient to deal with subspecialties in OBG, which is evidence-based. Once again, I thank TNFOG President Dr. Sambat Kumari to give me this opportunity to talk in this conference. Thank you so much.
I thank Sambat for giving me the opportunity. I was really thrilled and delighted to watch the rebuttal and all the arguments. It's a very, very nice topic.
This topic was selected by Rahul only. Fantastic topic, and it is the need of the hour. Thank you, Sita, for the wonderful verdict. I think it will be useful for everyone. Thank you, Rahul. And Sandhya, Vijaya.
Thank you so much, ma'am.
Thank you, madam. Thank you, madam.
Bye, Rahul.
Thanks for the opportunity, TNFOG.
Thank you, madam.
Thank you so much.
Radhika, ma'am.
Yes, ma'am. Thank you, madams. That was a wonderful discussion. The next session is debate on leiomyoma shrink. Dr. Virendra Kumar sir, and leiomyoma remove by Dr. J. Prakash Patil. So, may I invite Dr. Manohar madam. She is a professor in HOD Department of OG, Coimbatore Medical College.
Radhika, ஒரே நிமிஷம். Sita, அந்த verdict chat box la போடுறீங்களா? ஏதாவது link ஏதாவது?
Yeah. I am trying to share the screen somewhere.
இல்லனா அந்த linkல மட்டும் chat box la போட்டு விடுங்க.
Okay.
Okay, Radhika.
Okay, ma'am. Thank you. So Manohar madam is a UG and PG teacher for 17 years. She's present president of Coimbatore Obs and Gynae Society. She is the best outgoing student in 1990 MMC. Johnson has won numerous awards, Johnson medalist as well, and also the state best doctor award in 2019. And she has numerous publications and research credit.
Thank you for the kind words.
Okay, thank you, ma'am.
Good afternoon, everyone. I take this opportunity to thank President and Sambat ma'am, Secretary, and Dr. Vidya Dobi, KSOGA President, for giving me this opportunity. So we'll move on to the debate, whether to shrink. So I welcome Dr. Virendra Kumar, Head Department OBG, WIMS Bellary, President Bellary OG Society, and has worked as Secretary. I am a Bellary Chief Coordinator, 20 years of teaching experience. MBBS from JNMC, MD from WIMS, and DNB from Pune. He has organized various live workshops and CMEs, and is organizing Secretary of 30th State KSOGA Conference 2019. Had delivered orations, delivered more than 100 presentations as faculty, published papers in various journals, is a master trainer of HDP in pregnancy certificate course, and contributed chapters in various textbooks. So I welcome you.
Thank you, madam. Good afternoon, everybody.
And
am I audible?
Yes, you're audible.
Yeah.
Yes.
Please enable me to share my content.
Whether we are shrink and how to shrink.
Chitrakala, allow him to share, no?
No, it's already allowed.
Can you see the screen?
Yes, sir. Yes, sir.
Yes.
Yes, sir. Thank you, ma'am. And at the outset, I thank TNFOG and KSOGA for giving me the opportunity to speak on the very important debate, shrink leiomyoma. Women are constantly subjected to a lot of psychological and physical suffering. And we know that nature is cruel to women because of our unique biological role to be played in this world. The request for medical management always predominates in our clinical practice. Also, quest for new molecules and techniques continues in the research arena. If you observe, always women prefer preservation. It may be preservation of fertility, it may be preservation of body integrity, it may be preservation of social and cultural factor and personal preferences. With this background, I would like to quote a study wherein the internet survey was conducted regarding medical or surgical management of fibroids. 30% preferred shrink, another 34% preferred shrink and remove, and only 22% opted for removal of the fibroid. If you observe various guidelines by various societies, 2/3 of the recommendations offer non-surgical alternatives or medical therapy, and only 1/3 of the recommendation go for surgical therapy. Again, if you look at the algorithm, the last resort is removal of the fibroid. That means we should make each and every effort to remove, not to remove the fibroid. We should try to manage it medically. No doubt, hysterectomy and myomectomy are the definitive treatment for fibroid. However, we should remember that one size not fit all. There is a recent paper published in Reproductive Sciences 2022. There is a call to action for clinicians to implement evidence-based best practices when caring for women with uterine fibroid. We have to empower the healthcare providers to optimize the quality of care being given to women with fibroids using the best evidence-based practices. That means we should be knowledgeable about both shrinking techniques as well as removal techniques. What are the options available to us? There are many methods like medical, it may be hormonal, non-hormonal tablet techniques, procedures like uterine artery embolization or focused uterine ultrasound and surgical. We should always individualize the treatment for patients with fibroids. We should look at their symptomatology, size and location of fibroids, need and desire of the patient to preserve fertility or the uterus, what are the available therapy for such conditions, and the experience of the therapist is important to offer treatment. If you look at this up-to-date article, as you know, most the latest the knowledge is provided by up-to-date website. In this April 2023 article, it is written that apart from submucous fibroids, patients with all other type of fibroids who do not desire pregnancy are offered medical management to reduce their heavy menstrual bleeding as well as the size of the uterus. In this aspect, Mirena or levonorgestrel IUD, the most guidelines support the use of LNG. Even though it does not reduce the size of the uterus to a greater extent, definitely there is greater reduction in heavy menstrual bleeding. GnRH analogs, they have played a very long role in the shrinking of uterine fibroids. They're often used preoperatively as a surgical adjunct to improve anemia and to decrease the total uterine size. Or sometimes it may be used as a transitional therapy to natural menopause. For example, a patient coming in a perimenopausal state with fibroid uterus. GnRH agonists, 30 to 40% reduction in size seen in 8 to 12 weeks. There is reduced hysterectomy, reduced blood transfusion, and myomectomy. There are lesser incidents of vertical incision, and most of the cases can be done by vaginal hysterectomy. So that is the advantage of using GnRH agonists as a shrinking agents for fibroids. And according to Cochrane database review in 2017, many even did not require further treatment after receiving GnRH analogs. Nowadays, there is more focus and research on GnRH antagonists because GnRH analogs like Lupre-Depot have to be given in a parenteral formulation. However, GnRH antagonists such as elagolix, relugolix, linugolix are new promising oral preparation, and there is 40 to 60% reduction in size with 80 to 90% reduction of heavy menstrual bleeding and bulk symptoms. And linugolix has a greater reduction in volume of fibroid compared to elagolix and relugolix. Elagolix has to be given twice daily, relugolix has to be given once daily, and the advantage of linugolix is you need not add any add-back therapy while using GnRH antagonists. Of late in 2018, when we were students, we were told that fibroid is a hyperestrogenic state. More emphasis was given on the estrogen. However, in 2018, it is researched that progesterone is necessary for the growth of fibroid. In this aspect, several selective progesterone receptor modulators like mifepristone, ulipristal acetate, vilapristone have been used with variable success rate in clinical practice. Ulipristal acetate is effective in reducing bleeding fibroid volume. However, a single course of 3 months can be used preoperatively for delaying surgery or avoiding the surgery. And long-term intermittent 4 consecutive courses. One course means 3 months period. Intermittent 4 consecutive courses may be used as a medical therapy. However, there is a controversy regarding ulipristal acetate. It is approved in Europe as well as in India. However, it is not approved in Canada and FDA because of the rare possibility of liver cancer with the incidence of 1 in 2 lakh was observed with ulipristal acetate requiring liver transplantation. However, European Medical Agency has allowed use of ulipristal acetate with the monitoring of liver function tests. And the endometrial changes that may be seen with SPRM are not cancerous. Mifepristone 25 milligram once daily for 3 months and maintenance dose of 10 milligram thereafter has statistically produced significant reduction in size. However, the researchers say that there is high quantity data available, but low quality data does not validate its regular use and it is not FDA approved. However, mifepristone is effective in reducing or shrinking the fibroid. Vilapristone is a newer SPRM. It is both agonistic and antagonist, and it is appear to be high quality molecule compared to mifepristone or ulipristal. Uterine artery embolization. 90% of the patient report improved heavy menstrual bleeding. and it is not limited by number of fibroids and intra-abdominal adhesions. 78% had satisfaction compared to 87% who underwent hysterectomy, which is not statistically significant. Though not intended for use in those desiring pregnancy, many case series of pregnancies have been reported following uterine artery embolization. And there was a concern regarding ovarian function. However, the article published in 2019 says that there was same level of anti-malarial hormone with both UAE or hysterectomy. Focused ultrasound energy is being used to shrink the fibroids. High intensity focused ultrasound, otherwise called as HIFU, is extensively used in China, and in other parts of the world, MRI guided focused ultrasound is being used, and 75% of the people had satisfaction. Only there was 13% of reintervention, and the live birth rate was nearly 73%. Nowadays, people are thinking of not removing the uterus or fibroid. They are advocating radiofrequency ablation. Laparoscopic radiofrequency ablation or intracavitary radiofrequency ablation is also being researched, and they have found considerable success. However, if you look at the management of fibroids, it is symptom-oriented approach. However, there is a recent article which says that a more preventive and personalized paradigm is necessary for treating the fibroids. They say that it has a complex biopathological process, and since we are only targeting the symptoms like heavy menstrual bleeding or dysmenorrhea, and there are various subsets of patients who have developed fibroids, wherein you can consider hypertension, and some of the fibroids uterus have associated with low vitamin D, and patients with whom cardiometabolic risk is there. We can use simvastatin. It is an ongoing trial. I think it is going to give a new perspective as far as the medical management of fibroid is concerned. And the results will be out in another 2 to 3 years, because the recruitment started in the year 2019. So always think of shrink before you remove the fibroid. One size not fit at all. And so many researchers underwrite the importance of the shrink. Respect patient autonomy, needs and desire. Preserve womanhood integrity. Recognize, acknowledge, assess and choose the suitable method instead of simply removing the fibroid or uterus. New research is necessary to understand the complex pathophysiology behind the simple fibroid. Thank you for your patient hearing. Now, I rest my case and allow my friend Dr. Jayaprakash to speak on his views on fibroid.
Thank you, Dr. Virendra Kumar. Now I welcome Dr. Jayaprakash Patil, who is a laparoscopic and pelvic surgeon, Director, Betadur Advanced 3D Laparoscopic Center, Raichur, Karnataka. He is a chairman and endoscopy committee of KSOGA 2022, senior consultant teaching faculty of RDT Hospital, Batalapalli. Is operating faculty in several state and national conferences, and his areas of interest are endometriosis and fertility enhancing surgeries. So I welcome Dr. Jayaprakash to
Thank you, madam.
Talk in favor of surgery to remove fibroid.
Yes, ma'am. First of all, thanks everybody. Thank you, Kasoga and TNFOG. For those who do not, can you see my screen, ma'am?
Yeah, but you have to put it in a slideshow mode.
Yeah, I will. Yeah, I did my DNB from Otanchitram, Dindikal district. So I two states coming together, both Tamil Nadu and Karnataka. It's always a nice feeling for me. And thank you all the office bearers of both Kasoga and TNFOG for giving this opportunity. And Dr. Virendra Kumar, who's a good friend of mine, has given me a kind of very good platform to build my case. Okay, he told one thing is it's whatever the medical management he has told was not actually definitive. Definitive remains to be surgical. Anyway, but I want to tell before starting my debate that all myomas need not have any intervention. 1 minute. I want to minimize this. Some problem. Yeah. Sorry. Yeah. So not all myomas need intervention, whether it is a medical intervention or surgical intervention. Just because somebody gets a scan for something else, and then, you know, a general physician or a general surgeon sends to you with a report saying that a woman has 3 centimeters myoma, does not require intervention, be it medical or be it surgical. Now, we all know we need an intervention whenever, only in 2 situations as far as myomas are concerned. One, whenever she has symptoms, either it is a pressure symptom or related to dysmenorrhea or menorrhagia, or when the fertility is required. Okay. And another disclaimer before putting my case is that I am not a trigger happy surgeon. So, you know, I already stated in the first slide itself, not all myomas need surgical, intervention, be it medical or surgical. Also, I also believe that all myomas need not have a surgical intervention as well. And third thing is, when symptomatic, okay, fibroids can be really troublesome. See, we have seen women coming with hemoglobin of 2-3 with a torrential bleeding she had because of submucous myoma. Women having severe dysmenorrhea because of submucous myoma. Women coming with a retention of urine. These women require urgent intervention. Okay. What are the advantages of surgical management? Okay. As Virendra sir already said, it's a definitive solution. Better symptom control compared to medical, because medical treatment takes a lot of time to improve, and improved quality of life because the dramatic improvement in the quality immediately post-operatively. Okay. And now the chances of recurrence after stopping medication, whether be it GnRH analogs or ulipristal, whatever, is pretty high. So you need not have to worry about the recurrence. Yes, she can have another myoma in a different place. That's a different story, but you are sure that this myoma will not recur. And now, because of this so much advances in the technology as far as minimal access surgery or whatever is concerned, now the surgery has become very, very safe. Okay. See, when woman comes with a retention of urine because of the anterior fibroid, most of the time, unless you remove that fibroid or the uterus, she will not be able to void. So you cannot send her with a catheter, with a ulipristal and say that, okay, you take this for 3 months and come back. Okay. You have to give her some solution. A woman who comes with 2 or 3 grams of hemoglobin, you can only give GnRH for 2 to 3 months till you build her hemoglobin up. You have to operate her on, otherwise she will end up again with a 2 or 3 grams of hemoglobin. So symptom control also, definitely immediately after surgery, they are going to have much more satisfaction as far as the removal of the disease is concerned, because whether it is a heavy bleeding, whether it is a pelvic plane, or whether it is a dysmenorrhea or whatever, sometimes dyspareunia, will be immediately relieved. So fertility preservation. Okay. Myomectomy, when we talk about fertility preservation, preservation not necessarily means that you preserve the myoma, which is actually a tumor. You want to preserve the uterus, not just the whole thing. So if an intervention requires removal of myoma, sometimes myomas, I am referred with the myomas of different size, different locations by IVF specialists. They say that, okay, this myoma needs to go. Not necessarily patient has symptoms. So medically, when we see that, okay, myoma needs removal, that is the only thing which is available. Otherwise, because you cannot prolong a woman for another 6 months, 1 year for her to undergo embryo transfer. So I already emphasized on the advances in technology. Now we have so good energy sources, the in-bag morcellations, and good V-locks, which has made myomectomy very, very safe. Okay. Now, I think Dr. Virendra has already told what is the role of medical management before surgery, either to correct the anemia or to buy some time, or sometimes to minimize the size, especially in submucous myoma, not necessarily with a subserosal or intramural myoma, it doesn't really matter. Whereas in submucous myoma, giving a GnRH analog or some drug to shrink the size makes it easier to, you know, remove completely. Or sometimes women want to postpone their surgery for 2 or 3 months because somebody's exam is there or whatever. So such things you may have to give medical management. Now, most of the drugs are yet to prove their total safety. Now, GnRH analogs, I have had women who have got 2 or 3 doses of Lupride depot injections with so much bad hot flashes. Some even had depression, mood swings, irritability, dryness of vagina, they never had intercourse after Leupride injection, especially given for endometriosis and fibroids. So it is not a very safe drug. For temporary measures for 3 to 6 months is absolutely fine. But then if you prolong for more time, definitely GnR channels are not very good. And Ulipristol there was so much gaga about Ulipristol being so safe and so good and all that. And suddenly you have reports of liver rupture being reported. Now in India, many countries have already banned, as Virendra Kumar told, but then in India, we are not still very stringent with these safety measures. So they are being pushed. Now, once you stop these medications, whether it's GnRH or analogs or whatever, most of these do come back to their size within 6 months or 9 months or so. So medical management will give temporary relief, but then definitively, probably you would need surgical intervention. I've already told the problems of GnRH analogs or antagonists, what are the side effects.
Sir, sorry for the interruption, sir. Another 2 minutes.
Yeah. I'm finishing.
Okay.
Yeah. So uterine embolization, again, they have a lot of disadvantages. You have post-embolization syndrome, you have premature ovarian failure being reported, abdominal cramps, vaginal dryness, sometimes hematoma because of the surgery. And there are good amount of rates of higher redo, which are required. Okay. Now, HIFU or MR fulguration, it is yet to take off in a big way because of the cost factor. Now, I know that some of the people who are in Malaysia and China are doing, but still no center in India is yet to do because of the cost involved, and the results are not yet very convincing. And there are more contraindications than indications in these HIFU. Okay, surgical management, the Victor Boni, we have to remember him every day as far as myoma is concerned. He did say that the restoration and maintenance of physiological function should be the ultimate goal for surgical treatment. Now we have laparoscopy, we have hysteroscopy, we have abdominal procedures, so many things we can do. And as I already told, we have now better understanding as far as the specimen retrieval is concerned. We have in-bag morcellation, there are vaginal now colpotomy we are doing more frequently than this thing, and sometimes mini laparotomy. Now hysteroscopic myomectomy, there's so much of advance that some of the small fibroids we are removing even as an office procedure or just with their TIVA, and the patient goes home same day. Okay, even cesarean myomectomy, if in careful hands, if you don't, I do it routinely, myomectomy can be performed because you don't have to leave it to chance or that she will take medications or she will require another intervention, so we can still do. Okay, hysterectomy can be considered in some conditions. Okay, now there is a good amount of support. American College does say that surgical management is a safe and effective treatment for symptomatic fibroids, and randomized control studies have also said that surgical surgical management is superior, and non-surgical options can be there just to postpone or improving symptoms temporarily. So overall, these studies do tell us that, the surgical management of the fibroids, while the non-surgical options may be appropriate for some women, and we need to, as a long-term relief, we may have to resort to surgical care. So again, before putting my last slide, I want to tell that no need to be a knife-friendly surgeon. You have to weigh your pros and cons before putting the knife. But definitely, if you want a definitive relief for the woman, surgical management remains a very attractive option for many patients. Thank you very much.
Thank you, sir. And then Dr. Virendra for your rebuttal.
Yeah. So we have to take a balanced view on this important topic, because all patients are not for surgical management. At the same time, all patients are not for medical management. And as per the guidelines say, majority of the patients can be treated medically. Those requiring fertility, or where the myomas are very large in number, or when they have distorted the cavity, definitely there is a role of surgery. But what I want to say that most of the patients, when they're only symptomatic, having been completed the family, should not be offered surgery as the first line of treatment.
Okay. So coming on to the judgment, as both of them have claimed, all the fibroids, as we see, are not subject for any treatment, either it is a medical or surgical. But as proven again and again, the one says doesn't fit all. So we cannot say like the fibroids are always for medical management or they are always for surgery. So as a clinician, we need to categorize which patient depending upon whether they are coming symptomatology and whether they come for infertility or for the heavy menstrual bleeding. So depending upon the patient's age and their need, then you have to decide upon whether we are going for medical management or for surgical management. When medications were not available, we had no other go, we had to go for surgical option. But as medicines have started coming in, we can use like whether it's a postponement or to improve the anemic status, or if she's in the perimenopausal age, we can give medication, and provided patients can come for follow-up and we rule malignancy. So patient have to counsel them, and if they're ready for coming for follow-up and they are ready to take up the medicines compliant, then we can go for medical management. But our patients coming from far off places or from villages, and if you are not sure that they won't come back again or they'll be going in some problems, then we can offer them a surgical management. But then they have to be in a taken up in a center where all the facilities are there. As well, all lab surgeries everybody is doing, but I'm afraid it is not available in all the peripheral villages. So even the patients started going, the facilities are there, but it is not available in local corner of the country. So to depending upon the patient, you have to choose. It is not a straightforward judgment like you go only with the medication or go only with the surgery. So again, patient needs and what is the options available, and depending upon the cost, because once we start giving them ulipristal and all the complications, you have to counsel them and they have to come back for the reassessment, and whether they are going in for complications, everything has to be counseled. So I would like to say it is again medicine or surgery. It is depending upon the patient's age, need, and what is the affordability and whether they can come back for the follow-up. Everyone accepts the team also and the faculty also, because there is no one size fit all, as already said, and we can handle both medicine and surgery for the betterment of the patient. So whatever said and done, the treatment is for the betterment of the patient. So we need not stick on to surgery or we need not stick on to medications. So that depending upon what is the need and how competent we are and how the patient can come for follow-up, we can use both medications. But as the medications start coming on, we can use them also. So we need not always, we have to be like informed. We first ourselves have to be informed that there are medications available. Patients shouldn't come and teach us. So medications are coming all the way and we can use the medication as well, but we shouldn't be sticking onto the medication and losing the patient or the patient's whatever is the need for the patient. So we have to judge as a clinician and choose either of the thing. Thank you, ma'am. Thank you for the opportunity. I hope everyone accepts this.
Yes, ma'am, definitely. Thank you so much.
Thank you.
Thank you, madam.
Thank you.
Thank you, ma'am.
Both of them have done a very good job bringing about all the modalities of treatment available in the fibroid. I thank both of them. It was nice.
Thank you, madam.
Thank you, madam.
Thank you,
madam. Both
Thank you so much.
Jayendra sir, thank you. Jayrani, are you there?
Yeah, I'm very much here, Sampath. Sorry, extremely sorry for the
No problem.
inconvenience I have created.
So once again, I invite all of you for the HRPCON conference, VP conference in Kodaikanal 10, 11, 12. Now we will have the last panel.
11.
Radhika,
Ma'am, the last but not
என்ன
the least.
ரேவதி மேடம் ஏதோ சொன்னாங்க
11, 12, 13 pa. You are telling 10, 11, 12.
இல்ல 10 வந்து ஒரு ரிசர்ச் மெத்தடாலஜி ஒர்க் ஷாப் இருக்கு அதனால
Okay, right.
Okay, madam. Thank you, madam.
Thank you for the
Radhika,
opportunity,
introduce
madam.
the panelists and the moderators.
Okay, ma'am. So now the waiting, we are going to start the panel discussion on fertility preservation in modern gynecology. I invite the moderator, Dr. Jainani Kamaraj, madam, who is a senior consultant of reproductive medicine, infertility and sexual medicine, director, Akash Fertility Center and Hospital, Kadabalani, Chennai, president of OGCON, treasurer, Kapisar, associate secretary, World Association for Sexual Health, Advisory Council member, World Association for Sexual Health. She is a member of Joint Organizing Secretary, ISA 2015, member of Board Studies, MGR Medical University, lifetime member of FOXY, member of ASRM, Escher, and she has won Best Doctor Award by Dr. MGR Medical University. And she's a well-known consultant all over India. The next, Dr. Kundavi Madam, she's the HOD Senior Consultant, MBBS DGO DPNB, MNMS FICOG, Diploma in Reproductive Medicine and Advanced Laparoscopic Surgery. She's a specialist in reproductive medicine, laparoscopic surgery for more than 20 years, trained in ultrasound and andrology. She's a lead fertility consultant at IRM MMM, an active member of FOXY, OGCON, IMA, ISR, and TAPISAR, Fertility Preservation Committee member. And she has numerous publications in reputed journals, and she's an examiner for FNB and MGR University Fellowship Program. Okay. Can you please, the next, I invite Dr. Mangala Devi, Director, Smile Baby IVF, KC Raju Multi-Speciality Hospital. She's a certified IVF specialist from NUHS Singapore, Diploma in Reproductive Medicine, Kiel, Germany, and MBA in HSS in BITS Pilani and MBA in HHS Singapore. Dr. Prema Disunha, Professor OBG, Father Mullah Medical College, Bangalore, past President Bangalore OBG Society, 2016 to 2018, and member International Forum of Teachers of Bioethics. Dr. Shobha Yuan, Diploma in Reproductive Medicine, and Dr. Shobha is a leading fertility specialist, endoscopic surgeon with over 15 years of experience in fertility and women's health, with fellowship in Kiel's School of Reproduction in Germany. And she's a life member of IFS, IMA, and FOXY. Presently, she's a secretary for Kasoga Infertility Committee. And Dr. Vidya Prabhakar, Madam, she's the
I've already been introduced, ma'am. Fine.
Yes, ma'am. Dr. Madhumita Arun Karthik is a fellowship in reproductive medicine. She has she's been the treasurer and
Radhika.
Okay, ma'am. Dr. Deepa Mallikarjun Patil, the consultant Vijaypur, in Vijaypur Assisted Fertility Center and Shobha Nursing Home, Vijaypur. She has done her MBBS from JJM Medical College, Davangere, and fellow in reproductive medicine, IRH Milan, Bangalore, and she has presented many papers in state and national conferences. The next panelist, please. Okay. Okay, let's start the long-awaited panel, ma'am.
I'm extremely sorry. Good evening, everyone, and I'm very sorry because obstetrician's life is totally unpredictable, and really, I have saved one patient. It's a very big story, and I thank you, Sampath, Revati Madam, for giving this opportunity, and apologize for all the issues that was created. Can you see my screen?
Yes, Jairani.
Okay, so
screen தான் தெரியுது.
Screen தான் தெரியுதா? Okay.
Yeah, we are not seeing anything, ma'am.
Okay. So, can you see now?
PowerPoint வரல.
PowerPoint வரலையா? We are seeing only screen.
Ma'am, can you please stop share and share once again, ma'am?
Okay.
After opening the PowerPoint.
Okay, I'll stop share.
Yes, ma'am. Please click on the screen and then share. Share screen. Then
okay.
Screen.
Then screen.
No, ma'am.
Your PowerPoint?
Yeah, PowerPoint is open only.
No, ma'am, we can't see, ma'am.
Desktop is not.
And maybe you can stop the screening. And
ma'am, ma'am, you can PPT WhatsApp la post பண்ணுங்க, நான் பிளாட்ஃபார்ம் வந்து பிரசன்ட் பண்ண சொல்றோம்.
அப்படியே சரி, இல்லனா நான் இன்னொரு ஐபேட்ல வேணா வரவா?
அதுல குரூப்ல போட்டுடுங்க, பேனல் குரூப்ல நான் அதுல எடுத்து
இருக்கே, பேனல் குரூப்ல இருக்கு.
அதுதானா மேம்? பேனல் அனுப்பிச்சிருக்கா?
இருங்க, நான் இல்லைன்னா இந்த என்னோட ஐபேட்ல லாகின் ஆகுதான்னு பாக்குறேன். ஐ வில் see the if I can log in that also. I can இதுல இருந்து வேணா கனெக்ட் பண்ணிடுறேன்.
Started, yeah, I'm there, but I'm not able to means I'm able to see.
Ma'am, in iPad, we can see the screen. Ma'am, can you please open the presentation?
Okay.
So your screen is seen. You can just press the PowerPoint, madam, now. The PowerPoint slideshow.
Okay. Is it from the iPad? Maybe you can present it. I can. Yeah, that will be better. It's in the.
Yes, ma'am. 1 minute.
Yeah. Because it is taking both the Mac is taking up the other one. I don't know why it is happening.
Ma'am, I shared your screen, ma'am.
I stopped it.
Yes, ma'am. Now I am sharing, ma'am.
Okay. You put in the slideshow, it will be like this only, yeah?
Yes, ma'am.
Okay. So you will be moving the slide. Am I right?
Yes, ma'am. Yes, ma'am.
Okay. So can I have the first?
Available, ma'am. Jerani ma'am, Madhumita madam in the flight.
Okay. We will have.
All the panelists are
So I think you can move the next slide. So we know the fertility preservation. Sorry, we have to have. Can I have the? Yeah, I can see that. Yeah, not a problem. So fertility preservation, we all know it is a very growing topic in the management of oncological disease, both benign as well as the gynecological malignancies. It is because they are the one which we are treating them can alter the ovarian reserve, mainly because of the mechanism related to the pathology as well as to the treatment performed. Definitely, they always have an effect on the ovarian reserve and the human fertility. So definitely there is a need for the fertility preservation, which is an upcoming modernized treatment for many of the malignancies in relation to the fertility. It's not only the oncological conditions, but also benign conditions like endometriosis and adnexal torsion, ovarian torsion, and some genetic syndromes like Turner syndrome, premature ovarian insufficiency, the Fragile X syndrome, all have an issue of lowered fertility reserve. Can I have the next slide? So definitely the fertility preservation is the need of the hour. And as you look into the National Cancer Institute, nearly around 3 lakh children globally are diagnosed with cancer each year. And the advancement in the chemotherapy and the radiotherapy has revolutionized the cancer treatment and improve long-term survival. Although many survivors will remain in good health, disease-free, the prognosis 3/4 will experience very short-term and long-term effects of the treatment. The cancer paradigm has now appropriately shifted to include the quality of life in the survivorship, with the fertility cited as one of the most important quality of life indicators by the survivors. So there is a need of a comprehensive approach to fertility preservation in adolescents receiving cancer care therapies, which remains a mandatory and it should be included in the therapy. Next slide. So there is a need for the fertility preservation, we all know, but the basic principle that we should know when we plan a fertility preservation is, one, it should impact on the cancer treatment what we give, because that definitely going to affect the fertility. So you have to plan any of your therapy which has a less effect on the fertility. That should be the first one. So any drugs you choose, plan your drugs which has a better effect on the preservation of the fertility, which will help you to have a better preservation of the fertility. That is one. Second is, you also should consider that there is a non-malignant medical conditions that also may affect the fertility. That also should be considered in the fertility plan. Second, one planned indications, which you all know, it is the ovarian reserve preservations, which happens in many of the women who are pursuing for the career and other things. That also should be considered. And also we have to think of the genetic conditions, which can increase the risk of insufficiency and early menopause. And many at time, the upcoming gender reforming hormone therapy and surgery, which also can affect the fertility preservation. So these are all the very important things that we should consider. Next slide. So I think I couldn't see my slide. Yeah, next slide, please. So how you have to do the preservation and what are all the conditions which come across in the gynec practice where you have to plan your treatment. Next slide. So that is a very important one we have to know. I think Dr. Deepa, can you tell me what are all the ways that women can preserve her fertility before any cancer treatment? So what are the broad outline of treatment available for the preservation of fertility when a woman come across in a young age cancer? Can you just let me know the basic things?
I'm not sure you can see Dr.
Yeah.
Deepa.
Yeah. I think, madam, you can tell me. You can tell me that. Oh.
Right. Okay. Good evening, everybody. I'm Dr. Prema.
Yeah.
The methods for fertility preservation, it varies from different ages, whether you have a partner or not. The earliest we know was embryo cryopreservation. There you have a partner and you need to choose eggs, sperm is available. They create embryo and use it maybe after the treatment. Then we moved, not so good, but where you don't have a you then preserve the oocytes only. So this is the egg oocyte vitrification or cryopreservation.
Next slide.
The third method is in the very young, where we don't, maybe ovarian preservation is done. Ovarian preservation is done. That's the third method, not seen in a slide. We have also procedures for fertility sort of sparing. This was for fertility preservation, where you take it out and we preserve it. For fertility sparing is, suppose the person in malignancy is undergoing radiotherapy, maybe you can remove the ovary and transposition it somewhere else earlier on, like in the iliac fossa, right up to the lateral and higher up, so that it doesn't come in the field of irradiation or thing. But there will be other problems on the uterus or the thing that will look later. Maybe uterine transplant may be required if the uterus is destroyed.
Yeah,
or by radiation, by shielding the areas that may help us.
Yeah, you're right, ma'am. As you rightly pointed out, these are all the very important steps that we have to consider when you're planning the treatment for the women. Can you tell about the men when a boy comes to you for a early age adolescent cancer? What are the basic things that you should advise?
After puberty or
Next
something,
slide.
can do the sperm retrieval can be done. But if it's very
Next
early,
slide.
Just like in the younger person, in the girl, then we will have to do testicular biopsy, and testicular tissue will be preserved. Then day 2, you have to do radiation shielding during receiving of radiation.
So that's very correct, ma'am. As you rightly pointed out, these are the various methods which are available in an oncological perspective of any treatment when it is indicated in a young adolescent, both the girl and the boy, because we always come across young age cancers, either at the form of a lymphoma or leukemia or seminoma or ovarian dysgerminoma. All this have an effect, has to be treated properly. At the same time, we have to consider all these things. So there are very many questions that come to the parents regarding the child's fertility preservation. So it is always important that we have to talk to the patient, discuss with the parents, and if the child is more than 18, we have, it's an adult, we have to talk with them. So if the child began the puberty, options may be oocyte or sperm cryopreservation, as rightly pointed out. And if the girl had a cancer treatment before puberty, then you can even opt for an ovarian tissue cryopreservation. And of course, we also know about the boys, we can preserve the testicular tissue and the sperm tissue, as rightly pointed out by madam. Next slide. So next, coming to the very important point, you have to remember, can fertility preservation interfere with successful cancer therapy or increase the risk of the recurring cancer? Madam, can you enlighten us?
Who are you asking?
Yeah, you can talk, ma'am, or else anybody can take up this question. So, yeah, please, ma'am, please.
Yeah, ma'am. Usually, fertility preservation will not interfere, ma'am. If it is an early stage or something like that, if we have a time of 2 to 4 weeks, it's enough. In male, it is only a matter of giving one sample. For a female, we require some 15 days to 20 days. If it is not a dire emergency, I think 2 weeks, 3 weeks, it is not going to interfere in our fertility preservation will not interfere in the treatment of the cancer.
I think it varies with early and late. If it is advanced, then we cannot wait for our starting chemo. But if it is in that case, you have to just retrieve. But if it's earlier, then maybe 2 weeks, and you can do the different type of controlled ovarian stimulation by, even in the luteal phase, you can do it, or you can take the ovum and in vitro maturation.
Random start protocol.
We can talk about it in detail in later. Yes. So that is a broad outline, as rightly pointed out my panelists, that the preservation should consider the nature of the cancer, the severity and the type, and also about the genetical conditions, and all these things has to be considered. And also we have to be thinking of one risk of this cancer recurrence. When we preserve the preservation methods, should the cancer cells, we can reintroduce the cancer from the frozen tissue, also has to be considered when we are planning for the cryopreservation of the frozen tissue. So these are all the things that we have to think in the patient. So next, coming a few scenario we can discuss. I think madam is Dr. Deepa is here?
Yes,
yeah. So Deepa, I ask you about one question. We have one patient, a young girl, age around 15. She has come to the clinic with a sudden pain abdomen and acute symptoms of acute abdomen like vomiting, pain. And on examination, we suspect an adnexal or a torsion or an ovarian torsion. And on an ultrasound, we see a ovarian cyst with the features of torsion with a little Doppler in the pedicle. So how you are going to manage her? Can I have the next slide? So what are the basic things? Next slide. Next slide. These are completed. Yeah, next slide. Yeah, next slide. Next slide. Yeah.
So adnexal torsion is usually associated with adnexal tumors, and it may also have been associated with normal ovary, maybe because of excessive ligamental laxity, especially, and also intra-abdominal pressure changes, especially in pre-pubertal and neonatal age. despite the fact that there is no uniform standard to assess the viability of the ovary and choose conservative surgery or radical surgery for patients with adnexal torsion. Patient with ovary and ovarian cyst torsion can attempt to preserve the ovaries without any serious complications. In this regard, adnexal detorsion is safe and essential for the preservation of fertility due to high recovery rate of ovarian function. The detorsion must be associated with the immediate or subsequent removal of the tumor or the cyst, and also with ovaripexy in order to prevent the recurrence of the torsion.
Next slide. Yeah. Continue, ma'am. Yeah, please continue.
Preservation techniques for benign adnexal tumors and adnexal torsion, bilateral or contralateral. Repeated torsion or ovarian surgery is done in ideally in these cases. It's better to do a cryopreservation, and also in cases where adnexectomy with single residual ovary, which where you have suspected malignant tumor or any necrotic adnexa secondary to protracted torsion. So here, fertility preservation techniques available for these patients in infertile age, in infertile patients is the cryopreservation of ovaries and embryos. It is important to evaluate whether these patients should be considered also as poor responders due to various other causes like reduced ovarian reserve, secondary to any pathology like endometrioma, or any subsequent surgery. Therefore, a personalized approach is of paramount importance. And moreover, strategies aimed to improve the outcome of ovarian stimulation could be suggested, particularly if concomitant pathologies are present, such as PCOS syndrome.
Yeah.
Also, although cryopreservation of ovarian tissue is the technique for in a pre-pubertal age, it can also be applied in cases of healthy ovarian tissue removal concomitantly with other patients with the removal of benign tumors in women of childbearing age also.
Yeah, you're right. As you pointed out, yes, we have to consider the viability of the tissue. And if there is a non-malignant or a benign condition or a simple cyst or an ovary without any pathology, if it is going for a torsion, definitely we have to think of detorsion, which is accepted nowadays. You can even, there are scenarios where they have done twice or thrice even a detorsion to conserve the ovaries for the future fertility. So that is a very important point that we should consider when a child or an adolescent girl come with a torsion of a normal ovaries. But if there is an associated concomitant, any other malignancy you suspect, then you have to be very careful about taking all the biopsy and also have a proper consent. And then also you can even conserve a normal appearing one ovary for the fertility and advise them to go for the next step, either an ovarian tissue cryopreservation or ask them to go for a oocyte preservation after controlled stimulation. So all these things has to be considered, has to be discussed, and definitely all this has to be planned. So this is regarding our benign condition and the adnexal tumors, which is very common. Now coming to the next common condition which we encounter as an adnexal pathology, that's an endometrioma. So young women, can I have Madam Dr. Prema for your discussion about women, young women, she's around 28, come to your clinic with a fertility, for an infertility, married 3 years, the male parameters normal, everything normal. She has a progressive dysmenorrhea and an ultrasound. She has bilateral endometrioma, more than around 4 centimeters size, with all other parameters apparently normal. Her AMH is around 3.5. So how you are going to plan the fertility preservation for her, because that's very important, as well as treat her for the fertility, as well as you have to consider, now we are not going for the infertility treatment at all. We are more concerned about the fertility preservation when we are planning for the surgery, because she wants a surgery now. So how you are going to plan, what are all the things you will consider for the fertility preservation aspect of this girl with endometriosis?
Yeah, tough, but let's break it down. Nearly 50%
Next
of
question. Next slide.
50% of women with infertility have endometriosis. So you're going to see this a whole lot. So the approach should be thoughtful.
Next.
It should be personalized, and it should be patiently done. The reason why is that because in endometriosis, it's a recurrent disease. It affects the infertility. It affects the fertility. Surgery will also damage. Endometriosis will also damage. So we are looking at fertility preservation for these ovaries, for this endometriosis. So we can do the AMH is normal, ma'am.
Yeah, it's normal, madam. 3.5.
Yeah, okay. And so the different methods in these cases of endometriosis also, we have different approaches, conservative, like either OC pills or during surgery, or we are going for
She wants fertility, madam. She wants fertility. She wants
at a later date, maybe.
Yeah.
She wants. Yeah, so we have different choices for that. So again, we have the same oocyte retrieval and cryopreservation of the ovaries. I'm sorry, oocyte so we can do oocyte preservation for them, and or we can do
she's
embryo.
very young. She's very young. She wants to go for the surgery. So during the surgery, what is it? Because that's commonly that is the commonly that is the one which we are doing. So what do you want to tell the audience about how we have to do the surgery, preserving fertility as well as the preserving the reserve? Because she needs a surgery. She had 2 bilateral
normally we would approach this as surgery because bilateral endometrium. But I just wanted to make a point that the thing was, we have to talk about fertility preservation because of bilateral. Yeah, affecting both the ovaries. So we will, first of all, endometriosis naturally has a lower oocyte in them. So, and when we do the surgery by hysterectomy, if you're doing, then you are removing some more of the ovarian reserve. So we have to be careful what method we choose, since it's a thing. You can do even either the cystectomy, or we have to do, if you have laser, maybe you could.
Next slide.
Yeah. You have this on the slide. Okay. So those are the methods we use for during surgery.
Yeah. So ideally speaking, we have to do a minimally traumatizing the normal tissue. We can even go for a proper plane of the cleavage, the fibrotic capsule. We have to be very careful in removing the capsule. At the same time, we have to be very delicate. And even we have to go for a vasopressin installation, which helps for the proper cleavage of the capsule from the endometrioma, which will help you to conserve the more of the ovarian normal tissue. And close to the hilum, we have to be very careful. The current bipolar or a monopolar, you have to be very careful in applying over the hilum, because that will affect the blood supply to the ovary. So you have to be very careful about all these aspects during the surgery and during the procedure. And even you can use, just as madam said, a cystectomy alone and a hemostatic sealant without much of current you can use. That is a very important thing that you should keep in mind when you are planning the surgery. And very importantly, if it is a major bilateral extensive endometriosis, if you suspect, it is always better you have to refer to the senior surgeon who has been expert in the surgery, because there have been a lot of studies which proved that with a junior surgeon, the loss of the ovarian tissue is more, which is very important from the point of the fertility preservation. So these are all very important points that you should think and plan. And as madam rightly pointed out, we have to think of the ovarian cryopreservation, which is very important. We should talk to the women, especially if she is a little older. We have to tell her, even just don't bother about the endometriosis. Go ahead with your oocyte cryopreservation, or if she's married, get a embryo cryopreserved. That will help you for a better fertility outcome. So that all should be discussed well ahead when you come across a women with endometriosis. So we have to think of the risk to damage the ovarian tissue as well as the conservation of the ovarian tissue, which is very important when we have to plan the endometriosis and the cryopreservation. And in the women with endometriosis, the stimulation, can I have the next slide? The stimulation of the ovaries also is very important, because when you want to, next slide. Please, Chitrakala, next slide. Can I, So next slide. So that is a very important one. As you pointed out, we have to think of the women's age. If she's elderly, the first choice of treatment should be the cryopreservation. If she's younger, we can still talk of a surgery. But if she's older, more than 35, there is a one point is the tissue cryopreservation, either the ovarian or the embryo. If she's married and having a partner, we can go ahead for the cryopreservation. Next slide. Next slide. So that is a, before that, yeah. So that is a very important slide. They have compared a oocyte and embryo cryopreservation as well as with the ovarian tissue cryopreservation. They have seen that oocytes and embryo cryopreservation has a better success rate, especially the embryo cryopreservation, and that avoids the laparoscopy procedure, and the risk and damage to the ovarian tissue is very much reduced, and the reproductive potential of the follicle is very much better. And we have to get at least 2-3 times, we have to stimulate her and get the best, more number of oocytes. Then afterwards, you can plan the other procedures and surgeries. So that is a very important step. Regarding the ovarian tissue preservation, again, it needs a surgical intervention. So this women with endometriosis always need more of a embryo cryopreservation, which is better success related to the fertility. That is a very important point we should see. Next, coming to the ovarian tumor. Can I have the next slide? Yeah. So can any one of the panelists can talk about managing an ovarian dysgeminoma in a young age? What is it and how we have to do? What about the newer management therapy in that? Can I have a next slide? Yes. I don't know who is there in the panel right now available. Anybody can take this question. Madam, if you, madam can talk, yes.
Usually these if it's early ovarian tumors, early or like borderline or early stage ovarian tumors, either for epithelial or germ cell or stromal, it doesn't matter. We can do one-sided, and because the contralateral ovary will have only just 0 to 2.5% of secondary in the other ovary. So we can do conservative, only one side, the ovary can be removed and the other side maintained. It will be there. But so this is a fertility sparing surgery can be done for them. And even we may have to give chemo also, adjunct chemotherapy for them. During that chemotherapy, there is a possibility of giving GnRH analogs for starting 2 to 4 weeks earlier, so that the oocytes are in a slower this thing, there's no growth and they're not affected by the chemo.
Correct.
If it's advanced, the thing, then there is we have to get in with the chemotherapy.
Yes, madam. As you rightly pointed out, we have to think of the chemotherapy. The drugs used to be very carefully planned, as well as you rightly pointed out, we can use an adjunct therapy, which we will talk later, especially the GnRH agonist, as rightly pointed out, to conserve the oocytes and the follicle from the destruction even with the chemotherapy. So that is a very important point that we all should know. I will talk about it little detail in the next slides. Can I have the next slide? So after the ovary, we are going to the uterus. I think I can ask Dr. Shobha, madam is there? Yes, Dr. Shobha is there? Yeah. Can you talk about cancer cervix in a younger women with a CIN 1 and 2 and then endometrial hyperplasia, everything? You can talk about the uterus as a whole. Next slide.
If it is an early cervical cancer or a CIN 1 or 2, it may be, if they are willing for a regular follow-up, we can, after our fertility is completed, we can go ahead with the remaining, whatever the surgery. But if it is already something dangerous, then we are early stages, we can go for fertility sparing surgery like trachelectomy, radical trachelectomy, or a conization can be done, ma'am, in these patients. In these cases, fertility is possible. Only problem lies in the like in radical trachelectomy, we have to go for elective LSCS only, and cervical conization, we have to go for a stitching and all. But unfortunately, in CA cervix cases, just because it is a radiotherapy is a main treatment, it is very difficult to conserve the uterus for fertility. If at all, if we conserve also, it will not be able to conceive the patient. Thus, if at all, if we plan for these patients, if they are married, then we have to make embryos and keep it, advise them a surrogacy.
That's
if it is already, if it is a young, she is not married, then oocyte preservation is the best option, ma'am. So unfortunately, as I told, in CA cervix, it is very difficult for them to conceive once it is, and nowadays in India, it is young females are getting attacked by the CA cervix. So surrogacy is the main thing if they preserve their egg and the embryos. Depending
it's correct. As you rightly pointed out, if it is an early stage of a CA cervix, we can go for a uterus sparing surgeries like tracheotomy or or a conization, or you can even go for a conservative surgery or even a removal of the cervix alone with the conservation of the uterus. Still, you can have some amount of pregnancy can happen. But as you rightly pointed out, surrogacy is the option. But we have to keep in mind, there are other ways by which we can prevent it. Here comes our vaccination. We have to motivate all the young children to get vaccinated to prevent this cancer cervix in the future generation. So, doctor, how you will be seeing an endometrial cancer? So the same women, the cervix is fine. She has an endometrial hyperplasia. So how you are going to treat her, especially if she's a hyperplasia with the atypia, without atypia?
Without atypia is not a problem, ma'am. We can do a conservative line of management. But with atypia is a pre-malignant condition, we have some of the medical line of management till she reaches her fertility thing. Like we can start her on oral progesterone, or we can put her a Mirena. Then single thing, it's a multidisciplinary approach is very important in these patients, like oral progesterone and Mirena, metformin, and then megestrol acetate. All this can be tried, and keep taking the biopsy once in 6 months. See whether ATPI has gone to the any further CA. If it is not, then we can try a fertility thing.
Correct. Yeah, you're right. I agree with you. That's very important. The progestational agents are the only drugs which are, a drug of choice for this conservative management. And we have to advise the patient to go for a earlier fertility treatment, which is very important. The stimulation, everything has to be planned, and you have to be very careful about the progression of the disease also, which is very important. So next is, of course, we are seeing the uterus. Now coming to the breast. So breast cancer, we know it is only completely correctable. One of the important cancer which can be completely correctable and can have a very improved life expectancy. So what are the breast cancer survivors and their fertility? How you are going to preserve the fertility for the cancer survivors after the breast cancer? Can I have the next slide? Is there anybody can take this question?
So actually, if this lady is married at the time, so we can offer her actually oocytes, stimulation, and we can preserve the oocytes. But if she's not married, then in that case, we can go in for an ovarian tissue preservation, cryopreservation, and then go in for the therapy, because definitely the agents used here are going to be gonadotoxic. So we need to do a cryopreservation of the ovarian tissue if she is not married.
Yeah. So as you rightly said, that we have to go for a control ovarian stimulation, and we can even take out the oocytes. Either it could be a IVM we can do a embryo preservation also if she's married, as rightly pointed out. The very important, the protocols that we have to include, the drugs which are very safe, especially in the breast cancer, that is the tamoxifen you can use, that can give a better stimulation safety for this women instead of using a heavy stimulation. And carriers with BRCA mutations should be given a proper counseling, especially in the family. When they have a carrier, they have to be advised about cryopreservation of the oocytes and getting the pregnancy very faster. That is a very important step that you have to know. We have to talk and counsel the patient, especially when women come with a breast cancer. You have to plan not only for her, but also to the family. If they have a BRCA mutation, we have to counsel all the family about the fertility preservation, either in the form of a oocyte preservation or a tissue preservation or a IVF, which can be advised for them. Next slide. So coming to the lymphomas, we know Hodgkin's, non-Hodgkin's lymphoma, they are very much correctable, and they are the disease of the younger age group population. So how we are going to plan their fertility preservation? I think anybody can take this.
Can I take it, ma'am?
Yeah, please.
Usually, lymphomas are very common as childhood cancer, so they occur in around 8% of the cases in children. But what we need to see is whether the females are prepubertal or postpubertal. In postpubertal females, we have a lot of options. We can do cryopreservation of the oocytes, and we can stimulate and even do an IVF and actually do cryopreservation of the embryos. And if necessary, sometimes if it's a progress stage and the treatment cannot be delayed to do an IVF, we can even do an IVM where we can retrieve the immature oocytes and then cryopreserve that, and can be grown in the lab to be utilized later to form embryos. However, the problem arises only if they are prepubertal. In that case, unfortunately, ovarian tissue cryopreservation is the only option that is available in such patients. And considering that they are usually very young children, then parental consent is also necessary. And this ovarian tissue cryopreservation, after preserving this tissue, this can be utilized later to do an autotransplantation, but the success rate of achieving a pregnancy is very low in these cases.
Yeah, very absolutely. You are very correct and perfect. So these are all the options that we have to plan or discuss or counsel the parent when they come with a young age group lymphoma. All the options available, you have to tell them. Definitely, that is a very important step that we should have an idea of as a gynecologist. We should talk to them about all these things. So far we were talking about all the childhood and young age common cancer. So the basic fertility preservation techniques, what we use in the females are very important for. One is the embryo cryopreservation. Second is an oocyte cryopreservation. And second is ovarian tissue cryopreservation, and then IVM. These are the 4 modalities of the fertility preservations, which we all should know, because these are all being done by us, not by the oncologist. So we should know the details of how we are going to do. What are the things that you have to plan? You may be an ART specialist or you may be even a gynecologist, but you should be in a position to start it immediately without a delay, so that you can help the women to have a better fertility preservation, especially in the cancer. So what is the mature oocyte cryopreservation? How you do, and what is the thing that you have when you think of a mature oocyte cryopreservation? Can Dr. Mangla, you can tell me a little more depth about it to all of us to understand what is it? Is it a better choice, or an embryo is a better choice? If it's a mature oocyte, who are all the ideal ones for the oocyte, and how you go about it, and what is the success?
So we look at mature oocyte cryopreservation in post-pubertal women. But if the women are unmarried or if they don't have a partner, then we would prefer mature oocyte cryopreservation. And nowadays, cryopreservation has progressed a large extent, and oocyte cryopreservation is also much better than before. However, I would like to say that on the offside, that when we thaw the oocytes for use, the utilization of these oocytes to produce a live birth or even to result in a developing embryo are very less. So if we have a choice, or if the patient is married or has a partner, then embryo cryopreservation is any day better than oocyte cryopreservation, for the simple reason that these can be utilized in a better manner later to result in a pregnancy and a live birth. So if given an option, then I would prefer an embryo cryopreservation in these patients than an oocyte. If they have no partner, then no choice, then probably it would be better to go ahead with the same, whatever is available.
Yeah, you're right. Can you throw some insight about what is the type of stimulation you will use for her when she comes to you for a mature oocyte cryopreservation or an embryo cryopreservation? Do you give any importance? Because we have to finish her within a month or within 2-3 weeks, because she'll be almost planning for the cancer treatment. So how you are going to plan her control ovarian stimulation for this patient?
So considering the time factor and of course the fact that the treatment for the cancer has to be started, we won't be waiting to downregulate or even for day 2 of the cycle as we do in normal patients. So we would do a random start of controlled ovarian stimulation is what is suggested. And if possible, retrieval in the same cycle, depending on how the ovaries are stimulated, will be done, and then cryopreservation should be gone ahead. And this again, as Madam earlier mentioned also in the panel, it depends at which stage of cancer the patient is in. Even those 10 days or 12 days are very, very important in terms of starting the therapy for the cancer. So if we have that time, we would prefer a random start of the ovarian stimulation.
Yeah, you are very correct. But here we have to think of one important point in the stimulation, that we should always keep the estradiol levels low, because many times the ovarian tumor or the, yeah, sure. So can I have the next slide? So next is the IVM. A few words about IVM. Can anyone tell me about the IVM? In vitro maturation. So one important thing is the stimulation. You can use the letrozole, which is a very important drug, and tamoxifen can be done for the stimulation, and it can be started randomly, and even luteal phase you can start. That's very important thing that you should keep in mind about the time factor. A word about IVM. Can anyone tell about IVM, in vitro maturation?
So in IVM,
okay. Please go ahead.
Yeah, please.
Yeah, you're taking it?
Yeah, please, ma, please.
Okay, so in vitro maturation, actually we need not stimulate. So it is also ideal for younger girls. And so we don't stimulate, and we take out the oocytes, and then they are preserved and they are put in as a medium where, with all the sufficient ingredients in the medium for it to mature. So that once they are matured, then they can be preserved as matured oocytes. Or if it is required to do an IVF immediately, that also can be done. Otherwise, it can be preserved and then it can be used later.
Yeah. So yes, you're right. That is a very important point. Can I have the next slide? So all these important aspects, the ovarian tissue cryopreservation, this can also be done by two ways. One is the straight ovarian tissue cryopreservation, or it can be made into a implantation. Heterotropic implantation can also be made. That is also one important thing. Next slide. Next. Yeah. So far we have seen about all the therapy. One important thing I want to insist here for all the viewers is the fertoprotective adjuvant therapy. The main drug of choice is the GnRH agonist. Can anyone just say one or two lines about the GnRH agonist, how its impact when you are planning for a chemotherapy, how fast you can give, how is it protective along with the chemotherapy? Can we give this just a few lines about it? Yes, Madam Vidya, Madam, please.
So actually, this is all in the nascent stage as of now, and there are contradictory results. But both gonadotrophin releasing hormones, and there are some other agents as well, which are used. And here, intramuscular or subcutaneous GnRH analogs seem to be very effective in protecting the ovaries during chemotherapy. And they should be given before or during the treatment.
Next slide.
And,
next slide.
The results have been actually variable in different studies.
Yeah, that's very correct. Only one point about next. It should be started. We should continue the GnRH agonist along with the chemotherapy. It can be given up to 2 weeks after the end of the chemotherapy. That will preserve the follicles in a better way. And especially in estrogen sensitive tumors, like where they are using the tamoxifen therapy, that can be initiated along with GnRH agonist treatment. That gives a very good support for the adjuvants for the preservation of the follicle. Next slide. Next slide. Next. Go next. One word about the premature ovarian insufficiency. Madam, can you tell a few things about this?
Yes, premature ovarian insufficiency actually occurs in about 0.2 to 1% of the cases. And we find that in these patients, it could be either because of the inherited factor, like it could be a Turner syndrome or a Turner mosaic, or it could be a Fragile X syndrome or any of the pre-mutant varieties, or it could be also because of acquired causes, like sometimes the autoimmune diseases, like many times associated with the diabetes and other thyroid insufficiency and thyroid tumors as well. And sometimes it could be also because of toxins. So it could be either acquired or it could be the Turner syndrome or one of the varieties of Fragile X syndrome. And what happens in these patients is that we need to remember that they undergo premature the ovarian insufficiency at a very early stage, very early stage. So unless we diagnose very early and do that cryopreservation. If we wait till she comes, gets married, and then comes, many times we might have already lost. We would have missed the bus by then. But then it is very variable. The premature ovarian insufficiency actually occurs some years even before the menopause. So there might be some amount of follicles available still in these girls. So it is worth trying. And there are a few things which give us a pointer. One is, what is the karyotype? If it is a mixed type or mosaic type, we are more likely to find oocytes. And on the scan, at least if we find one ovary which has got some follicles to be seen and a good volume ovary, then we have better chances of getting some follicles out of this girl. And also some of them would have had regular menstruation as well. So all these people would be better candidates. And in these patients, it would be better if she is an unmarried girl, pre-pubertal or just about pubertal. So what we can do is, in these cases, ovarian cryopreservation can be done. Multiple biopsies can be taken, multiple cortex, but then many times it will be streak ovaries. So we may not be able to find much in these patients. We have to actually properly counsel them. Even if we take this, we may not find too many follicles in their cortex. That has to be explained to them. And then another thing is, if we use it also for IVF and embryo transfer later, many times they may have some abnormalities, chromosomal abnormalities, which are coming up in these patients. So that also we need to counsel them. And for these patients, we can also offer them PGT before that. So pre-implantation genetic diagnosis must be offered for these patients. And the preserved ovarian tissue, actually, if it is a good amount, we can also, and we have taken only the cortex, the medulla is still available, we can transplant it over there, orthotopic transplantation, or we can do subcutaneous transplantation. And so these can be used for IVF later and to give them a preservation. Another thing we must remember is many of these Down syndrome, many of these Turner's children, they have a problem of cardiac disease associated, and sometimes they are very prone for aortic dissection or rupture during pregnancy. So these would be candidates for whom we should suggest surrogacy. So all these must be counseled for these individuals.
That's very great, ma'am, that you covered almost everything about the premature ovarian insufficiency and the Turner's, which is very important that we come across. When we come across a women, we have to counsel them everything. So the International Society of Fertility Preservation definitely recommends certain aspects. We must counsel any young cancer patient about the fertility preservation, which should be done very importantly. And it should be individualized, which is very important, which should consider the severity, the fertility expectation, and also about the personal risk of the gonadal failure, and the drugs also has to be counseled very importantly. So counseling is very important. Either we have to take the mental health counselor as a genetic counselor and the financial counselor. Everybody play a role in the counseling of this fertility preservation, especially in the oncological condition. Yes, last to conclude, we all know with the improvement of the treatment in the pediatric malignancy, medical conditions that threaten fertility, survival rates are increasing. So we have to have a proper counseling about the fertility preservation options, which are available both for the female and the male prepubertal and the pubertal patients, and discussion of such options with the patient and their families to the initiation, before the initiation of the therapy is very important, because many times when they come after the therapy and they ask you, doctor, they have some options like this, why you missed it? You'll be really in a problem. And sometimes there may be a lot of ethical and medical issues also, and psychological issues for the survivor to go through all these things. So you need always a multidisciplinary approach in the fertility treatment, especially in the counseling for the oncological basis of the fertility preservation. Yes. So we have to think of all the conditions, not only the next slide, not only the oncological condition, also the benign conditions like the torsion, ovarian cyst, and also endometriosis management, which all play a very important role in the fertility preservation. So with this, I thank all my panelists. They have done a very wonderful job. And I feel very sorry, and I over great thanks to Sambat and Revati Madam for accepting my apologies to start a very late panel. Thank you so much. And I once again thank all my panelists for making this a very grand, successful panel. Thank you. Thank you so much.
Thank you very much, ma'am.
Thank you, Doctor. Thank you, ma'am.
Thank you. Covered everything.
Yeah.
கடமைகளை முடித்துட்டு கரெக்டா இந்த கடமையும் முடித்து விட்டாச்சு. I request everyone to nominate and vote for Dr. Jayarani, who is contesting for Sexual
Yeah,
Health Committee,
please.
and Kalpana for Infertility Committee, and Bharti for NCD Committee, Selva Priya for Medical Legal Committee.
So we all should make the South still more stronger with like Sampath. We should be, she's our role model now. We all should work and aspire like her. The way she works, the way she worked for
all
the
the
Adolescent
best,
Committee.
all the best, Dr.
Thank you, madam.
Jayarani.
Thank you, madam. Madam, make
Karnataka
all your societies please to nominate me, ma'am, and cast their precious vote to support me.
Thank you. Thank
you so much.
Thank you. We'll be much happy to have maximum number of chairpersons and VPs from our end.
Thank you, ma'am. Yes, ma'am. Let your words come true, ma'am.
Thank you.
Yeah.
If there is no doubt, shall we go for vote of thanks?
Yes.
Yes, we had
Sampath.
Solung, madam.
I just want Sampath, see there are 48 still on show, means they are there. I want one of the delegates to express their views if they want to speak. If they are
open panna, we can have a group photo also.
அதுக்கு முன்னாடி நான் ஒண்ணே சொல்றேன் என்னன்னா சம்பத், you have brought out so many new speakers.
So many new faces and new speakers.
This is a very good opportunity for them to have.
I don't know how she works. I don't know how she works.
How you have chosen those people? Really great.
She has so many data of speakers, I think. Rajeshri wants to speak.
Not the old ones. The new youngsters, the newcomers. To select them and bring them to this platform is a good thing.
Very good.
Madam. All young people.
I appreciate that. தேடி கண்டுபிடிச்சு எல்லாரையும் கொண்டு வந்தாச்சு இல்லையா? That is really great.
Very nice panel discussion, Jayarani, madam.
Thank you, ma'am. Thank you.
Very much. And
delegate இதை open பண்ணி விட்டுருக்கியா?
The topics
short duration everyone has prepared
3 days.
Very nice.
3 days only. 3 days only she gave.
3 days and 5 days, and it was very great. Actually, my chronic pelvic pain I did yesterday.
Very good, man.
No, I did it today. I did it today morning, and suddenly I got up in this emergency also. Everything was so bad.
Thank you, Dr. Prema.
Everything went very well.
Went on well, yeah.
Okay.
Thank you
Madam,
so much.
shall we go for a vote of thanks? Formal vote of thanks? Yes. First, I start with our chief guest. I thank Dr. Madhuri Patel, Dr. Sindhya Madam, and Dr. Kasturi for being the chief guest. And the Karnataka Society President and Secretary, Dr. Vidya and Dr. Rajeshwari, and our own President, Dr. Revati Madam, who is not at all interfering with any work which is useful work. She will tell us, okay, Sampath, you proceed. And I thank all the delegates, panelists, faculty, speakers, and chairperson for being here. And I should thank Dr. Radhika and other coordinators who are there for continuously for the past 2 days. And I should thank our Shield Pharma, Dr. Sahiti and Dr. Chitrakala, always TNFOG at any time, any program, the Shield is ready to give the platform, and she will post the fantastic photos immediately. So really we should appreciate her. And I think I have covered everyone. If I have missed anyone, please forgive me. Once again, I thank all for being here. Still we have 39 participants.
Sri Priya.
Yeah, Sri Priya, coordinator Sri Priya. She was very
Sri Priya, thank you so much. Because she didn't sleep for the past 3 days.
I know.
Working. Anyway, thank you so much.
We're not able to enter everybody, so we are
You open your video if you can, Shri Priya.
So we had 706 registrations.
Yes. And we were YouTube live also. Some people have joined through YouTube, I suppose.
YouTube live. Once again, I take the opportunity to invite all of you to Kodaikanal on
August வரைக்கும் இதே பஜனை. That's good. சந்தை இடத்துல டக்கு டக்குன்னு சொல்லிரணும்.
They had also done in Kodaikanal only. I think he's her VP conference. I could not come.
Revati madam tried. அவங்க கொடுத்த ஐடியா தான். அவங்க விட்டுட்டாங்க, அதை நான் புடிச்சிட்டேன். That's all.
Thank you. Acha, she has posted your flyers.
Ma'am, one Dr. Lalita.
from a delegate. She joined. You can ask her.
What is her name? Let her make her video
Dr.
on and
Lalita.
tell something.
Chitrakala, my
Stop
laptop
sharing.
has some problem. I joined mobile.
இந்த ஸ்லைட கொஞ்சம் ஸ்டாப் பண்ணிட்டு
Yes.
full இதுல போட்டீங்க the person.
Lalitamma Allur Chandrappa.
Yes. Lalitamma, please open your video as well as audio and you can talk.
Feedback from the delegate. I always take.